in on YouTube. I now request Dr. V. Prabhakar, our organizing secretary, to take over the proceedings. Thank you.
ಶುಭ ಮುಂಜಾನೆ ಎಲ್ಲರಿಗೂ. 33ನೇ ಕುಟುಂಬ ಸದಸ್ಯರ ವಾರ್ಷಿಕೋತ್ಸವದ ಈ ಭಾನುವಾರದಂದು ಹಮ್ಮಿಕೊಳ್ಳಲಾಗಿರುವ ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಎಲ್ಲರಿಗೂ ಸುಸ್ವಾಗತ. ಸೊ ಒಂದು ಗಣೇಶನ ಸ್ತೋತ್ರದೊಂದಿಗೆ ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ಸ್ಟಾರ್ಟ್ ಮಾಡ್ತೀವಿ. ವಕ್ರತುಂಡ ಮಹಾಕಾಯ ಕೋಟಿ ಸೂರ್ಯ ಸಮಪ್ರಭ ನಿರ್ವಿಘ್ನಂ ಕುರ್ಮೇ ದೇವ ಸರ್ವ ಕಾರ್ಯೇಷು ಸರ್ವೇಶ. ಸೊ ಈ ನಮ್ಮ ಕುಟುಂಬ ಸಂಘ ಸ್ಥಾಪನೆಯಾಗಿ 45 ವರ್ಷ ಆಗಿದೆ. ಸೊ ಇದು ಆ್ಯನ್ಯಲ್ ಕಾನ್ಫರೆನ್ಸು 33ನೇ ವರ್ಷದ ಈ ಆ್ಯನ್ಯಲ್ ಕಾನ್ಫರೆನ್ಸ್ಗೆ ಎಲ್ಲರಿಗೂ ಸುಸ್ವಾಗತ. ಸೊ ವೆಲ್ಕಮ್ ಟು ಆಲ್ ಡೆಲಿಗೇಟ್ಸ್ and speakers for this 33rd annual conference of family physicians. So without wasting much time, I call upon the chairpersons for the deliberations. So I invite first speaker of the day, Dr. Pratima Reddy, who is the lead consultant in Sparsh Hospital. She is well versed with our association. Yes, she has given 2 to 3 talks, and she is one of the very good speakers and expert in the field of obstetrics and gynecology. I call upon chairpersons to do the introduction of the speaker. First session chairperson is Dr. Abdul Alim, our organizing secretary, dynamic organizing secretary, and our senior member, Dr. Rita Prakash, who is the executive committee member. They will occupy the chairs and introduce the speakers.
Good morning, everyone. I was warmly welcome you to the 33rd annual conference of Fpcon. It's my proud privilege to introduce Dr. Pratima Reddy. She does not require any introduction because many of us are already knowing her personally and utilizing her services. She is the director and lead consultant at Sparsh Hospital for gynecology and obstetrics. She is trained extensively in United Kingdom, and she's a member of the Royal College of Obstetricians and Gynecologists from London. She's also a fellow of the Royal College of Obstetrics and Gynecology and of London, and fellow of the College of Obstetrics and Gynecology, USA. She specializes in high-risk cases, obstetrics, and she has been nominated by Times Healthcare Award for Legend in the field of medicine. Over to you, madam.
Dr. Rita, thank you so much for that introduction, and thank you to everybody in the Family Planning Association for inviting me to give you this talk. A lot of familiar faces. I know Dr. Abdul, Dr. Vita very well. Abdul is my neighbor, but we always meet here. He lives behind my house but refuses to come home. Really nice to see so many faces on a Sunday morning. I must admit, I would not have come so early, but thank you for coming. If we can start this talk. First slide, please. The abnormal uterine bleeding in the perimenopause. And I think this is extremely important because a lot of our women who consult yourselves, who are, as you rightly put down, the pillars of healthcare, and without you, we cannot partner in this healthcare. And they also see us, and this constitutes almost 60% of the women that we see. So firstly, what is the perimenopause? I mean, is it something that happens only at the menopause? Is it a time frame that people go through, women go through? Well, it usually starts in the mid-40s. So we are looking at women who are 45 and above and can possibly go on from 45 to 55. So it's a continuum of almost 10 years. So the thing to remember is that this is the time that women start having the symptoms of menopause. Some of them may, some of them may not. So it's just a matter of how each woman's body reacts. And why does this happen? It's because the ovaries start declining like every other organ in the body. The estrogen and the other hormones produced start coming down, and therefore the symptoms of menopause, which they commonly complain of, such as irregular periods, hot flashes, tiredness, etc. Also, what I want to do is make sure that we all, I know that we all know this, but I'm just refreshing my own memory and your memories as to what menopause is defined as. It is 12 months without a period. That is menopause. So we have to be very clear about that. Anything beyond 12 months, we must investigate. So a few definitions. What is abnormal uterine bleeding? As we all know, it's a change in the frequency, the regularity, the duration of flow, and the amount of blood loss. So any change in this is defined as abnormal uterine bleeding. So a couple of terminologies that have been changed, and as we all know, being veterans in this field, terminologies come and go. What's in vogue for today may not be the same. Ultimately, what we do need to understand is whatever terminologies we use, we are dealing with abnormal bleeding. So dysfunctional uterine bleeding, which is what it was called before, is now termed as abnormal uterine bleeding. Abnormal uterine bleeding. Menorrhagia is now heavy menstrual bleeding. As I said, all this is just new wine in old bottles. The important thing to remember is what are the definitions, how do we manage, and how do we treat these women. So, what is a normal menstrual cycle? I've just put this up as a brief one, but I'll go into the actual definitions, just so that we know when women come to us with having, say, missed periods, prolonged periods, frequent periods, when do we term it as abnormal? As you can see here, the frequency of periods, anything that is frequent is less than 24 days. Normal is 24 to 38 days, and infrequent is more than 38 days. So if a woman comes to you and says, I'm having my periods every 25 days, that is not frequent. And if she says it's 35 days, that is not delayed. So the normal here is 24 to 38 days. What about the regularity of menses? Sometimes they come to you and say, in the last 2 or 3 months I've had irregular periods. Should you take cognizance of this? Should you be concerned about this? So what is the normal variation? You can have +2 to almost 20 days in the regularity of cycles. So that can be the variation. When you have no bleeding at all, beyond this, it's absent. And if there is irregular, it's more than 20. What about the duration of flow? The normal duration of flow is 4.5 to 8. A lot of women come to us and say that we've not had periods for about, we have periods for about 7 days. Previously, my cycle was 3 days. It's still okay. It's not abnormal. Anything more than 8 days and less than 4.5 or 5 days is a short cycle. What is the volume? And we all know that the volume of blood quantified is not easy. So these are really figures. As we all know, more than 80 is abnormal, less than 5 is abnormal. So 2 terminologies in abnormal uterine bleeding: acute abnormal uterine bleeding and chronic abnormal uterine bleeding. So what is acute abnormal uterine bleeding and why is it important? Acute is important simply because it can cause a huge disruption in a woman's life, 1. 2, it can cause anemia, and we've seen women who said they bled and bled and bled for 3 days at home, passed clots, changed several extra large pads, and come to you actually anemic. And this can happen. So it is a woman of reproductive age. Remember, these are all women of reproductive age. She is not pregnant because you must not miss out on a miscarriage or an incomplete abortion, and she requires immediate treatment to prevent further blood loss. That is the premise of this. So how do you define a chronic AUB? When is this woman a chronic abnormal uterine bleeding? Again, bleeding from the uterus and abnormal in the duration, volume and the frequency that we talked about. And remember, the important thing is it should have been present for majority, at least 4 months of the 6 months that is required for the definition of chronic abnormal uterine bleeding. Now, the prevalence in our country is apparently about 18%. From our own statistics, it's much more than that. It affects at least 25 to 30% of women, and I'm sure you all see that very, very frequently and will agree with me that it constitutes a large number of women. Approximately 60% of our consultations are because of bleeding problems, and to the woman it causes disease, disruption of her life, and a certain disability because of the heavy bleeding and the pain that it will cause. How do we classify the causes for abnormal uterine bleeding? So it's pretty simple. PAM, P-A-M, PAM, and COIN. And what do these break down into? PAM, P is polyp, A is adenomyosis, L leiomyoma, M is malignancy or hyperplasia. COIN, C-O-E-I-N, C is coagulopathy, O is ovulatory, E endometrial causes, I iatrogenic, and N not yet classified. A lot of times in medicine, a lot of things are not classified, a lot of things we do not know, and it's quite easy to tell our patients we do not have a cause for it. Of course, they're not very happy to hear that, but that is a fact. Just the whole thing again. Polyp, adenomyosis, leiomyoma, malignancy. In leiomyoma or fibroid, it could be submucosal, which is the most common cause of heavy bleeding, or it could be an intramyometrium. Remember, the subserosal fibroids do not cause a disruption in bleeding as much as the others do. So this is one of our own patients. This is a polyp, basically an extension of the endometrium which grows into the uterus. And this can cause a significant amount of bleeding. However, what we must understand is just by removing this, and the only treatment for this is surgical, just by removing this, can we assure the woman that her bleeding problems will settle? The answer is no. However, a lot of the fertility people would like this taken out from a fertility point of view. So, a polyp, especially in and around the perimenopause, some of these polyps can be pre-malignant polyps, and that is important to remember. Adenomyosis. These days, with the advance in technology of ultrasound and advance in skills of radiologists, they're easily able to pick up adenomyosis, which previously used to be a diagnosis of pathology after the uterus was actually removed. So in simple terms, what is adenomyosis? It is the endometrium growing into the myometrium, causing pain, especially in the mid-40s or early 40s, and heavy bleeding. This is again a very debilitating condition for the woman. It causes disruption and disability for her, and I'm sure you all see a lot of women who come in their 40s with pain and bleeding. Fibroids, as we said. Again, as I said, these are subserosal fibroids on the outside, and their contribution to menorrhagia or heavy menstrual bleeding is not very much. It's the one inside the uterus or the submucosa that is more important. Now, this is very important simply because we are seeing a large increase in endometrial cancer in younger and younger women. In the past almost 10-15 years, I myself on a personal level have seen a vast increase. In fact, at one of our last meetings, we presented our statistics at Sparsh for the last 2.5 years. The Indian incidence of endometrial cancer is supposed to be about 3%, but in our statistics, it's almost 12.5%, which is a large percentage of women who have it. And in the last 2 months, 1.5 months, I had 2 women, one a 33-year-old and another one a 39-year-old who had endometrial cancer. And I'll just briefly tell you when I come to that how we diagnose this. So this is really important, and I request you to bear this in mind in those who are 45 or 40, irregular, heavy bleeding. Bear this in mind. No longer is it a disease of the post-menopause, and this is from our own statistics. Now, in the common part of it, coagulopathy, by the time the women present you at 40 or 45, they should have usually been diagnosed with heavy bleeding because of the workup of coagulopathy. But remember, von Willebrand's disease can present later on in life, and there's a family history to it. Ovulation dysfunction, again, it's a perimenopausal thing. Endometrial factors, most important in the coin part of the abnormal uterine bleeding causes is iatrogenic. We all give progestrogens, estrogens, GnRH analogs, and SERMs. Despite telling our patients to take them regularly, accurately, on time, to start and stop, most of them will stop these drugs once the bleeding stops. And we've all come across this. So that again compounds a cycle which gets worse and worse. And in this coin part of this, iatrogenic is the one that is most relevant to us. So what is important? I think we may need to dim the lights a little bit more, please. If we can just dim it a little more. Menstrual history, as we all take. So detailed history, like everything else, whatever technology we have, a history is very, very important. Menstrual history, going by whatever we've discussed it now, how frequent is it, how heavy is it, what is its duration, when does it come, important. Painful periods, as I said, it is an indicator of adenomyosis, endometrium in the myometrium of the uterus. Intermenstrual postcoital bleeding, remember, again, precursor of cancer. Please make sure that you take this on board, even if it is just 1 or 2 episodes, and do everything to rule out cancer, either of the cervix, postcoital bleeding, or of the endometrium. Now, a lot of times, women come to us in this age group and beyond in the menopause, complaining of vague GI symptoms, bloating, sometimes loss of weight, loss of appetite. Think of ovarian cancer. Ovarian cancer can give rise to irregular bleeding, but not as regularly as, say, endometrial cancer. So, whilst this is not a huge part of abnormal uterine bleeding, it is still something you have to think about when they present to you with vague GI symptoms. So, whilst I'm not saying the moment a woman presents to you with so-called, within quotes, gas, to send it off for a screening, but at least bear that in mind, take a family history, do a scan, do a CA125. Talking about CA125s, these days I've noticed that a lot of the labs are doing a CA125 as a routine. And in my opinion, and I don't know what you all think, in my opinion that is wrong, because the CA125 is done for specific screening purposes, not just as a routine. So this is something that I would ask you to bear in mind, because we have a lot of women who come to us, CA125 elevated, and what do? We don't do anything about it, except of course take a look at the scan and make sure the scan is normal. So again, these are all things that increase the worry in a patient's head. Polycystic ovaries. Polycystic ovaries is a precursor for endometrial cancer. So take that history well. Nulliparity, precursor for endometrial cancer. Diabetes, bleeding disorders, drug usage of hormones especially, and of course a family history of endometrial, breast and ovarian cancer. Very important. Examination, obese, look for anemia, palpable masses such as uterine fibroids, a vaginal examination, pap smear. Some of you I know do a vaginal examination and pap smears. but for those of you who don't, refer them over to the gynecologist. So we come to how do we manage AUD? We'll start with the investigations. As you know, we gynecologists are the simplest of obstetricians and simplest of medical doctors. We don't have that many investigations, we don't have that many drugs. Whatever we have is very basic. Because obstetricians, by way of midwives, have existed as long as life has existed. So in that way, we stand tops compared to the other doctors. Important. Do a pregnancy test. That's very important. Even if she's 45, you'll be surprised and caught out occasionally that she's pregnant and she's had probably a miscarriage. I still remember when I was training in the UK, there's this lady who came in at about 47, and when you're young, you're so full of yourself, you think you know everything. Irregular bleeding PV, we posted her for a hysteroscopy DNC, and lo and behold, the products, the histopathology came back as products of conception. I hadn't done a pregnancy test, so don't forget that. Now it has gone to the other extreme. My registrars ring me and ask me, a 60-year-old postmenopausal woman, shall we do a pregnancy test? I said, yeah, please think. She's postmenopausal, she's not going to be pregnant unless she's gone in for fertility. CBC, these women are chronically anemic, and you'll be surprised how anemic they can be. Investigations. A transvaginal scan is very important because that's more sensitive than a transabdominal scan. An MRI if it is indicated. Now, I talk about endometrial sampling only to tell you that that is now second line. It should not be your first line of investigation. So I'll come to the hysteroscopy biopsy first and then discuss this. The gold standard of diagnosis for the cause of abnormal uterine bleeding should be hysteroscopy biopsy. It should not be a blind DNC or a Bebel. Because of this is our own patient that I told you about. Now this was sitting in the cavity. And as you can see with the way the blood vessels are, etc., it turned out to be cancer. There was no surprises there. We would have missed this quite easily if we had done a DNC or a Bebel unless it had actually occupied the whole endometrium. So the most important advantage of a hysteroscopy DNC is looking inside. That's the most important thing, and taking targeted biopsies. Now, a DNC without an endoscopy is really not acceptable. You should combine it, and it's very simple. A hysteroscopy is very simple. You just need the equipment to do it, but a hysteroscopy, anybody can do it. It's not such a big deal. Pipel, again, the new guideline is that the Pipel sampling of the uterus should be replaced by hysteroscopy and DNC. It still has a place if people cannot afford this procedure, but I think we should make this affordable because this is the gold standard. This is the way it should go forward. After the investigations, we come to the treatment. As you know, there is medical treatment, the non-hormonal tranexamic acid, and here I want to emphasize the tranexamic acid that we all use so frequently. The dose is 1 gram 6 to 8 RD. So 500 is inadequate dosing. It's 1 gram 6 to 8 RD. And in acute AUB, to stop it, it is again 1 gram 3 times a day. 1 gram 3 times a day. LNG IUD, commonly known as Mirena, this, in the absence of a fibroid less than 4 centimeters, or more than 4 centimeters, which means a fibroid of 4 centimeters, we can put in an LNG IUD, and absence of any other pathology like malignancy. LNG IUD should be our first treatment for a woman with abnormal uterine bleeding. The combined oral contraceptive pill, you may ask me, 45. Do you give the COCs to women above 45? Yes, you can give it, but remember to screen them before you give it. Obesity, family history of venous thromboembolism, people who smoke, these are complete no's for this treatment. But women who categorize for this and who qualify for this, you can still give them the combined oral contraceptive pill. Progestogens is really acute. The usual ones, the Primolet, Meprate, etc. Acute to stop the bleeding, to control it for a specified amount of time. because this is not really a long-term medication given that we have the LNG intrauterine device. We have other treatment, ulipristal, as we know. We used it quite a lot when it first came out, and then it fell into disrepute because there were a few women who died of liver failure. So now the advice is that we give it for 3 months, do the liver function test, give it at the rate of 1 month, and then give it 3 months later. Now this is only to reduce the size of the fibroids and therefore hopefully bring down the bleeding. Again, in a 45-year-old with the present background of the problems with ulipristal, I have stopped using it in a big way. If they want to, I counsel them about it. Mifepristone, a lot of people use this in a lot of doses, in a lot of frequencies. There is no international guideline on this, just the studies that we have. Quickly, I'll go through this. Abdul, Peter, am I going along with time, or you're not timing me or allowing me to go on forever? No. Thank you. So we have the interventional and the surgical. Uterine artery embolization, the interventional radiologists do it. About 50 to 60% of women may benefit from it. Those who want to retain their uteruses may benefit from it. Women have had pregnancies after uterine artery embolization. The only problem here is ovarian failure if they want to have a child. May or may not happen. Endometrial ablation, polypectomy, as I showed you the polyp to be removed, may help. Myomectomy, removal of fibroids may help. And the final one, hysterectomy, which will help. Lifestyle changes. I'm sure this is what Abdul and Rita are going to feed you today. Once in a while is okay, not a problem, but also this is very important. So we all know how important. A lot of us don't make time for it, including myself. I'm guilty of it, but it is very, very important because in the women, obesity, diabetes, hypertension increases your risk of endometrial cancers and of course breast cancers. So what are the take-home messages? We all know that abnormal uterine bleeding constitutes 60% of our gynae consultations. The Mirena should be the first line of choice. Very, very important. So that is something that we must and should talk to patients about, but at the same time counsel them about the fact that for about 3 to 6 months they may have irregular bleeding. Otherwise they'll come back to you in 2 months saying, take this blessed thing out. It's worse than what I was suffering with. COCs, progestogens, they have their place as long as you have carefully taken a history, assessed the patient, and counsel them. Ulipristal, I've just spoken to you about how we do this. Now, this is really important, and I want you to please remember this and be aware of this in your practices, that the incidence of endometrial cancer is rising. You should have a low threshold for endometrial biopsy and for referring to a gynecologist if need be. Refer early, especially if the patient is not responding to medical treatment, because there may be some other background problem here that needs to be investigated and dealt with. Thank you.
Very nice presentation. If anyone wants to ask a couple of questions.
Good morning.
One.
Very enlightening session and got lots of doubts. So one question in my mind was, when I get a patient with an abnormal uterine bleeding for the first time, am I justified to give her, along with tranexamic acid, a progestogen, or do I have to first find out the etiology and then?
So the question was, if I have a woman presenting to me with abnormal uterine bleeding for the first time, can I give her tranexamic acid plus a progestogen, or should I investigate this further? So I think our investigative methods here would be, of course, a complete history and a scan, as I said, the basic thing, and some blood work. We can certainly start the tranexamic acid straight away in order to help her with that. And if 48 to 72 hours later it's not settling, we put her at progestogen. But if there are worrying factors, and of course here we're dealing with perimenopausal, not the menopause. With the menopause, just for the information of the audience, any endometrial thickness on a transvaginal scan of more than 5 millimeters is cancer until otherwise proven. Most of the time it's not, but that is how we take it. It's like an ectopic pregnancy. So coming back to this question, yes, start her on tranexamic acid. If after 3 days she's not settled, give her the progestogens to reduce the bleeding, because most of our women turn up after suffering for several days. They don't come to us immediately. And then if you still feel on a scan there are very high risk factors, then she will need a biopsy. Otherwise, you can wait and watch for the next 3 months, which is what we do, how things go. But if there is a history, as I said, of intermenstrual bleeding and postpartum bleeding, it is important that we take that on board and refer earlier.
No, once she's on estrogens, subjecting her to a biopsy, then won't the endometrium give us changes because of the medication
No.
rather than the actual pathology?
Sure. So I've spoken to the pathologists themselves about this, because as yourself, I had the same doubt that it masks whatever may be hidden below, but they said it does not. We will see a progestational change, but we will also see the abnormality if it is there side by side. So that is very clear. I've spoken to the pathologists themselves.
Thank you.
You're welcome.
If we start on
Along with,
I'll just take that question and take yours, ma'am.
thank you very much for the enlightening session. Along with somatostatin, somebody who has a neuroendocrine tumor, perimenopausal bleeding, can they take progesterone?
I'm sorry, I didn't get you.
Somatostatin, they are
Yes.
already on somatostatin.
Yes,
Can progesterone be taken?
it can be given. Progesterone can be given in almost all cases as opposed to estrogen. And we've had chats with endocrinologists, with neurologists, because somebody who's had a brain problem or a clot or VTE, whatever, obviously estrogen is a complete no. But progestogens, especially the Mirena, the LNG IUD, can be given. Yes.
Thank you, ma'am.
Thank
if we decide to give the progesterone, what should be the duration and dosage?
So the question was, if we give progesterone, what should be the duration and dosage? Now, I basically start with norepinephrine, which is Trimal 5 mg. We do it in a graded manner, 5 mg 3 times a day for 1 week, 5 mg twice a day for 1 week, and 5 mg once at night for 1 week. So 3 weeks in a graded physiological manner. This is what we give once we start it. So we don't give it to them and say stop after a week, because their bleeding will return. But this is mainly for bleeding that has not responded to tranexamic acid.
What about this controlled release tablets?
I know they come and push it and ask us to use it. You're talking about Karina and CR and all that, right, ma'am? Yeah. So I'm not entirely sure about this, because to tell you honestly, there is no guideline on this. There are no studies on this controlled release, and I think their purpose is basically to give 1 tablet a day so that it increases compliance. But do we have any data to say, yes, it's equal to this or better than this? The answer is no. So I continue to give them 3 times a day, twice a day, once a day, and tell them very strictly they have to take it, otherwise it's going to start bleeding all over again. The iatrogenic cause.
Why I'm asking this particular question is, I have seen many gynecologists prescriptions giving this Krina NCR for 21 days and stopping that, and again giving it for another 2 cycles, and then calling them for the hysteroscopy examinations and all that. So I wanted to know from you specifically what is right.
So if we are going to do a hysteroscopy and biopsy, as we said, it's not going to affect anything. It's better to do it sooner rather than later. Because in 3 months, giving it for 3 months and then calling them for a biopsy doesn't make sense. If you have thought in your head there's an abnormality, get on with it and do it straight away. Even if there is a lot of bleeding, control it with the progestogens for a brief time and go ahead. Yeah, you're welcome.
Thank you, madam, for an excellent presentation. May I please request Dr. Ali to honor his neighbor and friend, Dr. Pratima.
Oi. So what are the setbacks in this antibiotic issue? Lack of teaching on scientific evidence, and then lack of knowledge about antimicrobials, blind leading the blind. I say that is because I'm part of the Vaidehi Medical Institute there. I actually see, the professors teaching the PGs teaching the interns. When you ask a question why, I don't know, sir, my professor said this, that. I got the professor, that's how my professor taught me how to do that. So it's just, people are just following without asking questions, just picking an antibiotic out of thin air and just giving it to them and hoping after 3-4 days it doesn't work, change it to something else. And they keep changing until the patient gets better or they die, one of those two things. So same logic across the world. This is just not in India. There's a reason I became successful in the US is because even there's a confusion about antibiotics. Even though they think that they are far superior teaching facilities, no. It's the same across. When it comes to antimicrobials, there's always a big question mark. That's why they always ask an infectious disease consultant like me to come and help them out. So on an average, we see about 32 or 50 patients per day in each hospital because there are that many questions on antibiotics. So what are the complications of long use of antibiotic is adverse reactions, as we all know. Most importantly is resistance, and we are seeing an emerge of multi-drug resistant bacteria in this country, and mostly C. diff colitis. I haven't seen much C. diff colitis here. I don't know because everybody eats yogurt here, with mushroom. Maybe that's why. Those are the complications. And what are the typical conditions where you use prolonged antibiotics? One is acute and chronic osteomyelitis, diabetic foot ulcers, complicated pneumonias, complicated UTIs, mycobacteria and atypical mycobacteria, C. diff colitis, infected hardware, endocarditis, complicated skin and soft tissue infections. So we'll start off with a question here. 67-year-old paraplegic male patient with diabetes mellitus, hypertension, end-stage renal disease on hemodialysis comes in for evaluation and treatment for a pressure ulcer on the left gluteal fold, present for 3 months. Okay, remember the word 3 months. Foul-smelling discharge was noted, and you suspect underlying osteomyelitis. So, what is the next thing? Clinical versus imaging. Okay, imaging is expensive. So when you have an ulcer like this, foul-smelling, chronic, present for 3 months, a basic, simple examination is finger test. Stick your finger into the wound. And if you feel the bone, the periosteum of the bone, or if the bone is already destroyed and jagged, don't waste your money on imaging. You already know it's osteomyelitis. So clean it up, start antibiotics, get cultures, things like that. Which imaging is best? Okay? CT versus MRI. Okay, CT scan is good for chronic osteomyelitis, but if you want to diagnose acute osteomyelitis, MRI is the best modality. Picking the right antibiotics is always a challenge. If you know your microbiology well and if you know your surrounding area of antimicrobial data, then you should be able to pick the right one. Always make sure that you're covering gram-positives, gram-negatives, anaerobes until you get your cultures back. You'll usually cover most of those organisms. Oral versus IV. For osteomyelitis, oral antibiotics are a no-no. Always go with the IV antibiotics. The reason behind this is because of the first pass metabolism. So, for those of you who are not familiar with that, the first pass metabolism is when you take an antibiotic, it goes to the stomach. From the stomach, it goes to your small intestine, where it gets all absorbed. From the small intestine, it goes to the liver, where half of it is metabolized and excreted out to the bile or urine. And whatever is left then goes to the inferior vena cava, to the heart, from the heart to the lungs, from the lungs back to the heart, and then pumped out to the rest of the body. So if you give an oral antibiotic, the amount of medication in that thing, by the time it passes through all these pathways, how much is actually getting into the system? Okay, very minimum. It's not enough. That's why you give IV antibiotics, because the concentration of the drug is very high. You give it IV, it goes straight to your heart and then lungs back to the heart into the system. So the amount of medication that reaches the area is in a high concentration and the outcomes are better. Monitoring. What do you monitor in this patient on IV antibiotics? A weekly CBC and a CMP is a must because antibiotics, believe it or not, can cause bone marrow suppression. Okay, thrombocytopenia. But there's certain things you're looking for. The white cell count in hemoglobin is not going to go within a week. But platelets start affecting immediately within a week or so. Just to start seeing if the antibodies are causing thrombocytopenia, you got to monitor that. Why a metabolic panel? Renal function and liver function monitoring is very, very important because these patients can develop acute kidney injury or they can have liver issues. So you got to monitor those things on a regular basis. I particularly, especially if they're an IV antibiotic, it's mandatory to do a weekly CBC and a metabolic panel. What is end of treatment and duration? Usually for osteomyelitis, non-complicated osteomyelitis, the book says 6 to 8 weeks, but for complicated osteomyelitis, I have treated patients for months. So my longest treatment was 6 months on a patient because every time the patient comes back, it's healing a little, but some new bacteria has gone inside. You repeat a culture, that antibiotic what I was using failed, so I have to change to something else. Reinitiate the wound care program, get the wound to heal a little bit better. Reculture, another bacteria grows in. Because if you're giving a particular antibiotic, it might kill that particular bacteria, but the other bacteria will come and set up shop. Because the way I look at this, if patient is diabetic and they have an ulcer, if I'm a bacteria, that's a nice bakery shop for me. It's sweet meat. And if I'm a bacteria, I'm going to get set up shop. If I give a ceftriaxone and it kills a strep, the Pseudomonas is going to sit in shop. You go put a Pseudomonas, an MDR or something is going to come in. So bacteria is always constantly trying to invade that thing. You kill one, another one will set up shop. So constant, frequent cultures and changing the antibiotics until the wound heals. Okay, sometimes it takes months. So it all depends on how much the patient can afford and how patient you are, things like that. So this is a CT scan. Again, remember I told you CT scans are good for chronic osteomyelitis. So there's a CT here, there's an osteo of the pelvic bone here, it's already destroyed, this is normal here. This requires surgical debridement and antibiotics. So that is an acute and chronic osteo for you. Second question. A 75-year-old male patient, history of diabetes, hypertension, and chronic non-healing ulcer to the right 5th metatarsal plantar area. He has been given multiple oral antibiotics in the past and failed to heal. So what's the first thing you do? Obviously, culture. Second thing is imaging, depending on what you feel like. If you feel like this is an acute one, go for MRI. If you think so, always start with an X-ray first. If the X-ray is not showing anything, most likely this is an acute one. If the X-ray is showing something, it's chronic, and then you decide if you want to have a definite diagnosis. But if the X-ray is showing enough damage to the cortex of the bone, you don't need any other imaging. Baseline labs. Why are baseline labs important? I have had several shocks in my life. Patients come in, nasty wounds, foul-smelling pus, fever, and you already have some kind of a culture report and you start a strong antibiotic. A week later, you do a baseline, the first set of labs, creatinine is already 7. Liver function 600, 800. You're like, what the hell happened? Well, the patient didn't know he had chronic kidney disease. There's no way for him to tell me. So always, before you start intravenous antibiotics, always make sure there's a CBC and a metabolic panel. Make sure the kidney function is normal, make the liver functions are okay, and make sure this guy doesn't have a baseline thrombocytopenia or anemia to begin with. Preliminary antibiotic of choice. Again, going back to our microbiology, we know that there are gram-positives, and there are gram-negatives, and there are anaerobes. Pick an antibiotic that would cover all three. Because remember, wounds didn't happen overnight. These ulcers didn't happen overnight. They have been there for a few days. So if you take a culture, it's going to take 3 days. So for the next 3 days, which antibiotic you pick really doesn't matter, but make sure you cover gram-positives, gram-negative, anaerobes until you get the culture. And once you get the cultures, readjust the antibiotics based on the culture report. Other consultants. Who are the other consultants that we should refer to? Well, obviously, the first one would be if there's an ulcer, you're talking about a diabetic foot ulcer, the first one would be a surgeon. If you have podiatrist, that's fine, but if you don't have a podiatrist, general surgeon would be the first one. The reason is for debridement. And who are the other consultants? Immediate next consultant is vascular surgeon. Okay, you can give the antibiotics till Timbuktu, and you can give the most expensive antibiotics in the world, but if there is no blood flow to that area, antibiotics are not going to reach there. So your next immediate vascular, arterial ultrasound, ankle brachial index, and make sure you establish blood flow to that area of the foot or leg, whichever part of the body you're treating. Okay, who's the other consultant you call after that? Is plastic surgery. Sometimes you might need a flap closure. Sometimes you might need a skin graft to close the ulcer. Sometimes you have ulcers, diabetic foot ulcers that are that big. They're never going to heal on their own. So you might need to get a plastic surgeon. And obviously in US they call it infectious disease. I'm the first one they send me, and I'm the one who's calling all the other consultants. So, but here you are it. So you are the infectious disease, you are everything. So you are the main consultant. Duration and when to stop, we just talked about it. 6 to 8 weeks is standard for osteomyelitis. For diabetic foot ulcers, again, until it heals. Do not stop the antibiotics. Because the moment you stop the antibiotics, within 48 hours, the bacteria will come back and set up shop there. So make sure the patient is on some antibiotic or the other, preferably IV. If there is no osteo, oral is good. But make sure antibiotics are on board until the ulcers are completely closed, healed, and sealed. Okay? So this is, I don't know if you can see it, but that's your diabetic foot ulcer right there. So this is pretty much bread and butter for us. We see daily 10 to 15 cases of these. So next one is, that was diabetic foot ulcer. Next question is 55-year-old male patient admitted to ICU with shortness of breath and fevers, diagnosed of right lower lobe pneumonia with an effusion. Patient is now intubated, and cultures from the tube, ET tube sent was growing MRSA. Vancomycin was started and given for 10 days, but the patient's white count is persistently elevated. Repeat sputum cultures are negative. What next? Well, you have a guy who's intubated, sputum culture MRSA, you gave vancomycin, it's not getting better. You did another culture, it's not growing anything. So the clue here is this one. The first question you have to think is, why is it not getting better? Why are the cultures not happening? Because now you have an effusion, most likely this is loculated. So when it's loculated, it's nothing but an abscess. So you take an ET tube sputum culture, it's not going to reach there. So that's your first clue right there. So immediately what you need to do is CT. So CT scan of the chest now revealing a loculated effusion. What's next? You got a CT surgeon. So they come in and they do decortication, a VATS procedure, decortication in a chest tube, and everything is drained out from there, and the patients usually get better. But here, the cultures with MRSA from the pus pocket was now MRSA because it's loculated. Now it's growing MRSA. And the MIC to vancomycin is 2 now. What do? Do you continue vancomycin or you go for a bigger, higher antibiotic? Here's the answer here is, what does the MIC mean to you guys? It's a minimum inhibitory concentration. What is a normal MIC for vancomycin is anywhere between 1 to 2. So MIC is 2. Continue vancomycin. There's no reason to kick for a higher antibiotic because the most important thing here was decortication. You accomplished that. He'll get better. Just continue antibiotic, finish the course. Usually 4 weeks is the duration for empyema. Remember that. Now, if the patient cannot afford intravenous antibiotics, then you can always switch it to oral linezolid or Bactrim if it's available, and patient is not allergic to sulfur. Duration, I just told you, 4 weeks for empyema. Preferably IV is the gold standard. If they cannot, oral linezolid is the next gold standard. Bactrim, again, remember, it's a static agent, not a cidal agent. So if I have no other choice and the patient is dirt poor and he cannot afford the linezolid, then I would go with that. Minocycline, again, I wouldn't do it. Because again, it's a static agent. So I would stick with linezolid as an oral option for this one. So this is your classic CT scan with the loculated fluid. If it's a regular effusion, you'll see a nice layering, but here you can see that here is a effusion, but here there's another pus pocket here. This is loculated. Okay, so when you actually go in, you will see loculations all over here, which cannot be drained by intervention radiology. You have to actually go in, put your finger, and break up all the loculations. So that is pneumonias for you. So next topic is, you start with the question, a 55-year-old female patient, history of recurrent urinary tract infections. In the past, now just a history, now comes in with high fevers and left flank pain. Urine analysis is positive for UTI. Patient was started on ceftriaxone, but fevers persist. 3 days later, urine culture and blood culture were positive for E. coli, sensitive to ceftriaxone. Fevers and WBC continue to be high. What next? You are giving the right antibiotic. You evaluated the blood culture, they were positive. Everything is fine, patient is not getting better. So what is the first thing you think of? When you give the right antibiotic, sensitive, and you do everything right, it's not getting better, always think there is an abscess sitting somewhere. It could be a lung, anywhere. If you're doing the right thing, there's a focus of infection which the antibiotics are not able to penetrate. Remember, if there's an abscess, antibodies will not penetrate. The reason is because, what is the pH of abscess? 6.5. What is the normal pH in a human being is 7.4. So antibiotic only work anywhere between 7.2 to 7.4. Anything less than that, they become neutralized in the presence of pus. So it's very hard to treat with antibiotics unless the source of infection is eradicated. A CT was done, a left renal abscess was noted, too small to be drained by IR. Here again, you're stuck. If the IR is able to drain it, no problem. But if they're not draining it, what do you do next? Patient also have emphysematous urinary bladder with cystitis and a left non-obstructive urethral stone. So what's the point of calling a urologist at this point? Because it's non-obstructive. If it's an obstruction, you can call this non-obstructive. There's no reason for that. There's an emphysematous bladder. There's nothing you can do about it. And then the abscess is too small to be drained. What do you do in this situation? You just continue the antibiotic. Don't stop. There's no reason to escalate and throw some aminoglycoside and screw up his kidneys and hearing and all that. You don't have to do that. Stay on the antibiotics. Remember, pyelonephritis and renal abscesses, they're small. Even with the best of the best antibiotics, fevers will persist for 3 to 5 days minimum, and the white count usually is high. It takes some time for the antibiotic to work and slowly penetrate into that abscess and slowly neutralize the bacteria. What is the choice of antibiotic and duration? Again, based on the sensitivity. If it is sensitive to what you're already doing, there's no reason to change. Duration is for a renal abscess or pyelonephritis, 21 days. You have to give, okay? And then this is an example. This is not the case related, but this is a typical example of a renal abscess. Any IR can drain this one, but in my case, it was not able to drain. That is about complicated UTIs. Next scenario is a 40-year-old male patient. Pedicure was done. Pedicure is foot cleaning. I know none of you, most of you don't have time to do that. Some people go for that, okay, especially ladies. They go for pedicure, and that was done 2 weeks ago. Now it comes with nodular lesions on the foot spreading to the leg. So what you're looking at is a non-tuberculous mycobacteria is the first thing that should come. When you say that I went to some Chinese salon, had a pedicure done, I have these lesions on my leg, first thing that comes to your mind is non-tuberculous mycobacteria. So there are two types. One is rapid growing and the slow growing. The rapid growing mycobacteria are the Mycobacterium fortuitum, chelonia, abscesses, smegmatis, mucogenicum, Walensky, and megatens, and these require about 6 to 12 months of treatment. You can do oral antibiotics for this one, they will do fine. The slow growing are Mycobacterium avium complex, MAC, and Haemophilum kansasii, Malmanesi, Marinum, Simiase, and OB, these require 12 to 18 months of antibiotics. So again, there's no reason to memorize. These are all available in the literature. You can always look it up and it's available. And that's the reason I put it there, is because this is also the reason why you use long antibiotics. That's for atypical mycobacteria for you. And we have another scenario. A 65-year-old male patient admitted to the emergency room for abdominal pain, watery diarrhea, 7 to 8 times per day. CBC was done, white count of 25,000, 90% neutrophils. He's afebrile. He was apparently treated with clindamycin for a skin infection recently. The moment you see clindamycin and you see white count, one thing that should come into your mind, diagnosis, C. diff, Clostridium difficile colitis. This is one of the worst antibiotics that was created in human history. I hate it. It should never be used. The only condition I recommend using that is during necrotizing fasciitis to turn off the toxin production. Other than that, this is just a nasty antibiotic that people use all the time without understanding the repercussions of it. So, what do you diagnose? I already told you, C. diff colitis. CT was done. I'll show you the CT scan of the findings. Very interesting. It shows diffuse colitis and severe colonic edema. Then you send a C. diff toxin A and B for a PCR, and usually it turns positive, but you don't have to wait for it. You can always start the treatment before getting the results. And what is the choice of antibiotic? Oral vancomycin. Okay, that is the gold standard. Metronidazole is not a gold standard. If there's nothing available, you can start, but oral vancomycin is the drug of choice for C. diff colitis. Okay, some places don't have oral vancomycin. What they can do is they can take the IV vancomycin and compound it and make the patient drink it. It is harmless because oral vancomycin molecule itself is very big. That's why when you take it by mouth, it's not absorbed systemically. Okay, but if you give oral vancomycin for a skin infection, patient is dead because it doesn't go in and come into the system. It just goes all the way down, comes outside. So that's why oral vancomycin is the drug of choice. You can actually have your pharmacy people compound it for you if you have a chemist close by. Oral vancomycin, sometimes when the patient is really sick, you can also administer IV metronidazole along with oral vancomycin. The reason being, when you have C. diff colitis, the colon, which is usually about that big of a diameter, it becomes very narrow because of the edema. It's like a small pinhole kind of opening is there. So the oral vancomycin you give might not penetrate all the way down because of the colonic edema. So at that time you can give some intravenous metronidazole. They'll help you as a secondary agent. So how long do you treat? Usually, typically it's 2 weeks in a non-complicated C. diff colitis. In a complicated C. diff colitis, you treat it for more than 2 months in a tapering fashion. Patient still not getting better. Diarrhea persistent and WBC still high. What do you do? This is $1 million question. Not a lot of people know this one. There are very few people, few universities have tried this one. This is called direct intracolonic administration of the vancomycin. So you call your best buddy, the general surgeon, and ask him for help. They will come in, make a small incision in your stomach, pull out the small intestine, split it like a banana, halfway through. And then you put Foley catheter into the distal end of it and the proximal end of it. So the proximal one is connected to a bag where all the gastric secretions are coming out. The distal end, you put a Foley catheter and then you inflate the bulb and inject the vancomycin directly into the colon. And it will slowly start percolating down to the heavy concentration, and they do eventually get better. Once the patient's WBC normalized and he's doing better, you can always reverse the whole process. So the other one is now, new drug in the market is called fidaxomicin. So if you can afford it, if you can find it, you can use it. It's a twice a day treatment, 200 milligrams twice a day for 10 days. Very expensive even for US patients. I don't know if patients here can afford it, but if they can find it, and they don't want this procedure, there's another option for you guys. So this is your typical CT scan. As you can see, the serpentine appearance. You see how narrow this colon has become? And this is all the edema of the colon. That's how it looks like a serpent inside. And if you actually do a colonoscopy, the white plaques, this is what C. diff colitis looks like. All because of oral antibiotics. And just not clindamycin, any antibiotic can do this, oral or IV. That is C. diff colitis. So next scenario is, am I running short of time? 5 minutes. 70-year-old female patient underwent total knee replacement, 7 days later noted to have a stitch abscess and was drained and given oral antibiotics. But the drainage persisted, knee was tapped and noted to have significant elevated white count in the blood culture. The synovial fluid was positive for MRSA. IV antibiotics started, but no improvement noted. Underwent removal of the hardware and antibiotic cement spacer was placed for 6 weeks along with IV antibiotics, and then had a new hardware placed. A month later, the infection is back, and due to her age and medical issues, she was not a surgical candidate and was recommended above the knee amputation. She does not want the above knee amputation, and what are your choices at this time? Well, that's hardware infection, very complicated. Basically, you go and you do a complete washout at this point in time, and you exchange the polymer, put the patient on another 6 weeks of IV antibiotics, and after that you put them on a lifelong suppression with oral antibiotics. I have one patient who's been on oral antibiotics for 8 years, one patient for 6 years, so on and so forth. Every day they have to take one oral antibiotic depending on the sensitivity. So you can save that life. They're already 70 or 80, they got another 5-10 years, they want to keep their life, that's another option. Do you have time for one more or no? Done? Okay, so I'll stop here, and if you have any further questions, I can take a couple of questions. Yes, sir. Can someone give him the mic, please?
Sir, you have complications regarding this ulcerative colitis, in which we are usually giving salzoparin those days. In the 80s, is there any such newer treatment, ulcerative colitis, where we were using salzoparin?
Salzoparin.
You have not heard of?
I'm not familiar with that. Is that a generic name for that?
That is a
Fpcon. Yeah, that's not an antibiotic. That's not an antibiotic. So is it? Oh, okay. So no, we are not using that anymore. Sulfosal is explained. It's not an infection related, so there's no reason for it. Yeah.
one more question.
Foot ulcers?
And antibiotics, as you rightly put it, may not be reaching the paranephric foamy abscesses. How are you going to go about it?
Well, the best friend is at that point is intervention radiologist. Okay, if you can send them, they can do a CT guided aspiration of that abscess. That's one option. If they say it's too small, like the case scenario I told you, then you do prolonged IV antibiotics on that patient. Sometimes it goes up to 2 weeks, 3 weeks until they get better.
Yeah, they do get better with IV antibiotics. We have been providing them with all the things. But sometimes, the morbidity of diabetes is actually leading on to mortality. That's what I just...
Like I said, immediately if you suspect a perinephric abscess, my suggestion would be to consult an intervention radiologist, see if they can drain that abscess.
Thank you.
Okay, we can have more questions when we conclude this session. Thank you, Dr. Mahesh. Excellent presentation and very knowledgeable. I request Dr. Rita, you can honor Dr. Mahesh. We have the last speaker for the session, Dr. Vidyadhar. I request Dr. Rita to introduce Dr. Vidyadhar, please.
Good morning again. My pleasure to introduce Dr. S. Vidyadhara, Head of Department and Consultant Spine Surgery from Manipal Hospital, Old Airport Road. He has done his MBBS, MS and DNB and then went on to do his FNB and FHKU in spinal surgery. He has got so many awards. Looking at it, I'm reluctant to start off reading. He is the first Indian to become chairman of Communication Committee of Scoliosis Research Society of USA. And he has won many medals in his career. He was awarded Dr. TMA Pai Gold Medal for the best outgoing postgraduate student of the year 2002 by Mahia University, and INOR India Gold Medal for the best postgraduate student for the year 2002, Dr. TMA Pai Best Outgoing Undergraduate Student of the Kasturba Medical College, Manipal in 1998. His field of expertise is in non-operative treatment of neck and back pain and various injection techniques in spinal disorders. He deals in complex cervical spine surgeries and vertebroplasty and kyphoplasty, surgery for spinal tumors, and spinal column reconstruction, posterior anterior. Please, sir, I invite you to take over.
Good morning, everybody. I'll put the timer on so that we are on time. Yeah, thanks for being here. I think I'll not waste much of time and we'll start quickly. My topic is robotic spine surgery in today's world and what we did in Manipal Hospital in the last 8 months having this gadget. As you all know, surgery has advanced a lot and, oh, this one, you've changed. Surgery has advanced a lot and it's only with respect to technology and techniques, but what remained the same is the surgeon, indications and principles. I don't think we have changed in the last 30 years that I wanted to be a doctor. The indications remain the same: weakness of limbs, bowel bladder involvement, either inability to hold or inability to pass, and functionally disabling pain for more than 3 consecutive months. Exceptions, as a rule, is deformities, tumors, infections, and trauma. Principles again have remained the same. Only 2 indications for any spinal problem needing surgery. Either the nerve is pressed that you need to decompress, or the bones are unstable that you want to stabilize. Exceptions again, deformities, tumors, and infections. I'll go quickly about few of the things that I have learned in the last 30 years trying to be a spine specialist with respect to back pain first, because that is more appropriate for a family doctor. And I should make a mention about MRI. It is the gold standard in diagnosing anything in and around the spinal column. It can pick up a small disc bulge like this, a big disc prolapse, or a bone slip. It also diagnoses infection and malignancies at the earliest, even before it is clinically obvious. But this is a very important landmark article published by Eugene Keregi in New England Journal of Medicine, which is like the highest impact factor clinical medicine journal, which he analyzed 1,472 normal human volunteers without back pain. He did MRI for all, and he found that more than 80% of people had more than 2 findings on an MRI. Like, as you see, people had disc prolapse, people had slip disc like this, people had Schmall's nodes, people had disc degeneration, high intensity zone, and he concluded, this is his concluding slide in the journal, saying that If you do MRI in a normal human volunteer, you will find that 60% will have disc degeneration, 55% disc prolapse, 25% high intensity zone, 30% annular fissures. In other words, if you do an MRI, you will find 80% of people having more than 2 findings. Not that they need treatment, but they have findings. Now, Eugene Keregi left behind a very important scientific question. Should you treat MRI or should you treat the patient? If you treat the MRI, you are like this hunter who doesn't know where is the prey. And if you want to treat a patient looking at the MRI, every level looks abnormal, like this lineman who wants to see which wire is faulty. Friends, I am not contradicting anybody. I am sure all of you are senior to me in age and experience as a doctor, but all that I have displayed here is evidence-based medicine guidelines for treating back pain. It is after all the advances that we have concluded today that it is not the doctor who heals, it is not the rest, not the medicines, not the belts or collars, it is the nature which heals. And given time, given 3 months, 90% of back pain heals on its own. But trust me, how many of us can wait for 3 months without going to a doctor, without doing an MRI? Of course, none of us in this hall being doctors. So there comes the problem. There are 2 problems. One is we have too many more important things than health. We have Griha Pravesham, we have wedding reception, we have Brahmopadesham, and we can't avoid it. And there are too many options. Every street has a clinic, every main road has a orthopedic hospital, and every highway has got a corporate hospital. So we keep changing hospitals and doctors till finally nature heals and the last doctor gets the credit. So our department is actually right behind Ganesha statue in Manipal Hospital, the main Manipal. And I pray God every morning when I go, asking, make me the last doctor. Friends, another point, bed rest. In India, at least, I have seen that it is the 5th largest religion. After Hindu, Muslim, Christian, Sikh is bed rest. Anything and everything, lagao, it will work. If you don't give bed rest, people look at you as though you have made a sin. You can see them grumbling and going, saying that, what, this doctor, I can't walk, he is not giving me rest. So it is, and doctors also, the more irritating the patient, longer the bed rest. If they come in between, you tell, why did you come? I told you 3 months bed rest. You know, you want to avoid them. So it is a very good tool, but it is a religion, because whether normal delivery, pregnancy or cesarean, only the duration of bed rest changes. Common binding factor in India is bed rest, but with respect to back pain, what evidence says is more than 2 days actually delays recovery. It may feel good for the patient. He is lying down, mother is talking to the neighbor, 3 dina aitri, or beligenu helak hoda, but tumbane novide. Son will always think, mother is carrying, wife has gone to work. Having said, more than 2 days, it increases the psychological component. You are pressurizing nature to heal fast, which it doesn't do. And that is why we say don't take bed rest for more than 2 days. At least do something within pain limits. Belts and collars. People cannot even tie a sari without a belt nowadays. And people want to go to the office with the neck collar. I tell them, you go on one day and take 1 week off and go to Pondicherry or Goa, but don't wear the belt or collar. Because we have natural muscular belt that gets wasted if you tie belt and collar around your neck and back. Physiotherapy, although it does not improve any recovery rate, but it does a lot of good to the society. Trust me, friends, I never say no to a physiotherapist because they are the most genuine people who spend 1 hour for 500 or 750 rupees that the patient gives. They still, and you know, in India, at least in places like Jayanagar, Malleshwaram and all that, I think Indranagar, people are in their 70s, 80s, all their children are in US and UK. They think that they are the most successful parents having sent them to US and UK, and they regret later that education is a curse. And having said, nobody to take care, at least the husband will go out to the park for walking and talking to his friends. Lady is only busy making tea, coffee for the husband and his friends who come on and off. And she's not going anywhere and she has back pain and nobody to talk to. And you send a physio, they do such a good job. They come and bless me immensely, not because I have done anything. ಏನು ಡಾಕ್ಟ್ರೆ ಅವಳನ್ನೊಂದು ಕಳಿಸಿದ್ರಿ ನೀವು ನಿಮ್ಮ ಪುಣ್ಯ ಬರುತ್ತೆ ಡಾಕ್ಟ್ರೆ ಎಷ್ಟು ಪಾಪ 1 ಗಂಟೆ ಕೂತ್ಕೊಂಡು ಕೇಳ್ತಾಳೆ ಡಾಕ್ಟ್ರೆ ನನ್ನ ಮಗಳು ಕೇಳಲ್ಲ ನನ್ನ ಮಾತು. You know, it makes so much of a sense to send them. I think kudos to them. I am really very impressed that they do a good job. which we don't do, listening to the patient. What to do, what not to do. Whether we know somebody or not, every one of us has a dictum to tell, rule to tell to the patient. Don't bend forwards, don't lift weights, don't bend forwards, don't go on a two-wheeler. Everything is don't. Lot of negativity around back pain. But what we tell uniformly is complete bed rest. Back pain, complete bed rest ತಗೊಳ್ಳಿ ಸರಿಯಾಗತ್ತೆ. But that is wrong, friends. Today what we believe is patient has to resume normal daily activities at the earliest, but don't do something that increases pain before the injury heals naturally. So who has to decide? Patient has to decide. Neither the wife, nor the mother-in-law, nor the neighbor. So let the patient decide. They know their pain best. And pain is protective. Educate the patient that pain is there to tell that the injury is there, damage is ongoing, and be within pain limits, do everything. Respect pain is the only thing that patient needs to understand. Within pain limits, they can do everything. But today what we do, complete bed rest. Somebody is not comfortable lying down. He says his pain is becoming more on lying down, and we force him to take bed rest. But that is not right. Somebody may be okay in walking, but only sitting he has the problem. Tell him stand and work, it's okay. So you need not put everybody on bed rest. So rest today is equal to rest. What we believe is active rest. Being within pain limits, doing everything and resting your mind. Friends, painkillers, as the name suggests, kills the pain which is your friend. Don't take it unless there is a demanding task. Like you have an important meeting to attend, take a painkiller and go. You have an important wedding reception to go, please take a painkiller. That person may be getting married only once in lifetime, and you don't spoil the album. Antidepressants, friends, there has been enough number of studies which say that more than 2 years back pain, people have more psychological component. They have made studies and proved that more than 80% of people who suffer from more than 2 years of back pain have got mild, moderate or severe depression. You treat depression, back pain disappears. That is the beauty. But how many of us actually go into the psychological aspect? None of us. They come on wheelchair, they go back on stretcher by doing surgery because we have robot. Friends, preventive measures. I always advocate yoga over all the other exercises because anywhere on earth you can do. There is no excuse for not having done. Unless you plan to go to moon or Mars with Elon Musk, I think everywhere on earth you can do yoga. All that you need or don't need also is a mat. Nowadays people don't do because there is no mat. Because that is also promoted by saying that you need a yoga mat for doing yoga, which is not true. Swimming is the next best, but most commonly you have excuses. Rainy season, no heated pool. Went to a native place, no pool. Went to a hotel which didn't have a swimming pool under renovation. Lot of reasons not to do. Jogging, walking doesn't do much to the spine. It only does good to the whole body and mind. 2 lifestyle changes that you can change or reverse, may not be reverse, is smoking. It does damage the disc by deposit of nicotine in the disc. It degenerates fast and it causes permanent damage. Weight gain, for obvious reason, it is pulling your spine forward, which is not a good thing to have. For people who sit, most of them in Bangalore do sitting work. So you tell sit straight, look straight, and more important than that is keep taking breaks, which we forget. They have to get up, do some stretches, drink some water and sit again. But what I saw in my first few years, I used to tell take breaks, but nowadays chairs come with wheels. So they go to the next cubicle, talk to the neighbor and then come back after 5 minutes saying that I have taken a break. So I tell get up and walk. Friends, movement is life. It is not only the heart has to move and it gives life. Every part of the body, whether it is lung, whether it is every joint in the body needs movement. How many of us know that there are 96 joints in the neck and back, 33 bones, 3 joints between 2 bones, and this needs full range of movement in our neck, in our back. But how often do we bend forward and touch the ground? We can count the number of times that we have done since +2 days. PUC ಆದ್ಮೇಲೆ ಯಾರು ಬೆಂಡಾಗಿ ನೆಲ ಮುಟ್ಟಿದ್ದಿಲ್ಲ. You can count the number of times when you have done it. And that is when all these joints are nothing but bearings. You know, the bearing needs only movement. It doesn't need oil and grease. A house fan doesn't get oiled and greased, and it never makes noise. A marriage hall fan, every time you go, 1 out of 10 fans will make kar-kar sound. Not because it is not oiled. It is because marriage season it works. 2 months. Remaining 10 months it is resting and rusting. Friends, bearing needs movement, joint needs movement. It is wrong to say that you have to rest it, you have to oil it. Yeah, you don't move, then it will give karkar sound. You need doctors like me to oil and grease. Friends, don't do MRI unless there is an indication, and our indications are only if you have a indication for surgery. You do an MRI to identify which side is the problem, how big is the problem, and to tackle the problem in the right approach. I think it is a direction that the MRI gives to do an intervention. Then doing MRI is actually a curse, because once before MRI patient is half mad about the problem, after the MRI you are making him totally mad, and after he goes to the doctors, 2 doctors, 2 opinions, 20 will give you 20 opinions. And trust me, one will tell take bed rest, other will tell don't take bed rest. One will tell you take injection, other will tell do surgery. So even as doctors, trust me, it is a curse. You do an MRI, you lose your sleep. And till you get a surgery, you will not be at peace. And it is not that surgery is needed because you have a slip disc or a pain. It is because you would have gone to 20 doctors, and doctors like me today will tell you smaller and smallest surgery, and today even robotic surgery. So we tell, and 1 or 2 of them will scare you. Doctor, the roads in Bangalore, humps and bumps, and one more jerk, one more hump, you are back. It may come out again fully and press the nerve so hard that you lose control over your legs and urine motion. This will hurt hard, because every night after that, wife will cry saying that, "Aapko kuch hoga to mera kya hoga?" So you need to get the disc out to get a good night's sleep, not because you have pain then, because it troubles the whole lot of you. So don't do it, and if at all you are doing it, please tell the patient that it is for infection or malignancy, because spine is the commonest place where malignant deposits are there. 50% of secondaries deposit in spine. So if it is a more than 60-year-old patient with consistent back pain for a couple of months, you do an MRI and tell them beforehand, I am not looking at degeneration, disc bulge, neuroforaminal compromise, ligamentum flavum hypertrophy, because these are the same words which will be there on MRI report, and they will all be now surgeon-friendly reports. They will all write compression of the nerve, which scares the shit out of patient. And they go running from one doctor to the other. And it's actually quite sad that we rampantly do MRI, keep repeating the MRI, and it becomes a big problem. Friends, yoga is like recurring deposit, which we today don't believe in it. We believe in share market and mutual funds, which go up and down like every day, and looking at the charts, you may get neck pain. Yoga is a way of life, it is not an exercise, and it tackles both physical and psychological component of pain. Friends, few tips that I have learned in life in the last 30 years trying to be a spine specialist. It is not because it is a small disc that you need surgery. Even in small disc bulge in a narrow canal can be so symptomatic that you may have to decompress. It is not because you have a large disc that you need a surgery, because a large disc in a large spinal canal may be just floating without causing symptoms. You don't have to do a surgery. Friends, no surgeon can claim to have 100% success rate. Even last week I had my last one. So the more you do, the more complications you have, and definitely no matter how small a surgery is, it will always leave behind a scar. So think conservative, stay conservative. I don't mind you doing thorough workup like I said, but please do ensure to tell the patient that it is for malignancy and infection that you are doing, not for disc bulge. And surgery, only 3 indications: weakness, bowel bladder involvement, or functionally disabling pain for more than 3 months. Friends, everything else is non-surgical. In 3 lines, if I have to summarize what I spoke for last 15 minutes, pain is protective. When you have pain, respect it, be within its limits. Flexibility is the key. When you don't have pain, maintain it with yoga. MRI and surgery both share the same indications. Don't do MRI unless there is an indication for surgery. MRI is it is also diagnostic and a therapeutic tool to direct your surgery to the particular problem. Friends, it is not to say that you have to get married to pain. Then it becomes, if it is more than 3 months, you need to get a cure. Otherwise, it can only be treated intermittently. It becomes like diabetes and asthma. What God wanted us was be like this farmer who sweats it out every day, morning to evening. End of the day, food will get tasting nice. It gets digested, and no matter which mattress, which pillow, he gets a good night's sleep, and next day morning when he gets up, he is fresh, energetic, and most importantly, happy, because he doesn't know how much is the cost of Rolex watch and Audi car. Friends, today we are in this zone wherein we are in AC rooms like this. Body is cold, only brain is heated up. Everything we have extremes of emotions, too happy, too unhappy, too anxious, too apprehensive, too much of everything, nothing in medium level. So that strains the brain. Brain is the headmaster of a school. If headmaster is gone case, all the teachers and students alike will go autonomous and they misbehave. And then you'll have giddiness, dizziness, headache, chest pain, palpitation, breathlessness, neck pain, back pain, acidity, constipation, menstrual irregularities. You name it, you'll have it. Somatic manifestations of stress disorder. And to suit these symptoms, we have symptoms specific, super duper specialists like Vidyadhar. We are 250 of us at Manipal. I'm sure Dr. Sharan Patil is here. He'll have many more hospitals coming up and many more doctors. So we all have symptom specific doctors today. Izzat ke mare for 10 symptoms, even if one gives one medicine, we end up taking 4 tablets in the morning, 6 in the afternoon, and 8 in the night, and we make patient out of a normal human being. Friends, we have 3 choices. Go back to grandfather's farm and do agriculture work if you don't want back pain, or do 1 hour of yoga every day if you don't want to dirty your hands and legs, or stop cribbing, start enjoying pain, keep changing doctors and hospitals for entertainment. Friends, this is the truth. Now comes the commercial aspect, which I am supposed to give a lecture on robotics. As you all know, this will be shorter than the first half. This will be maybe 5 minutes to 7 minutes. So I have timed it. I have got 12 minutes more, so 7 minutes is the talk. Conventional to minimally invasive to navigated spine surgery is the way that we have traveled in the last 30 years. And combination of minimal invasive with navigation is robotic spine surgery. This is simplifying what is robotic. Like going from here to Tirupati, initially we used to use maps, then we used to use GPS, and now we have live GPS. Same is in the OT. We have scan after the patient is positioned. Oh, switch off, huh? No, this is 20 minutes only. I have put the timer here. So scan in the theater after the patient is prone. You plan when the patient is ready, and then you execute in a live manner. As the implants are going in, you can see it. On 15th October last year, 8 months exactly, we started this Manipal Institute of Robotic Spine Surgery at our comprehensive spine care center at Manipal Hospital, Old Airport Road. And it was for the first time in South India that we did have a complete setup of robot with O-arm with radiolucent operating table. We so far have done 407 cases in 245 days, most of them being thoracolumbar spine, but we have gone up to occiput and pelvic trauma. We did implant 2,500 implants in the spine at various areas, and we have treated patients between 8 and 97 years of age. So these are the few cases. I'll give you one example of one case. This was the first case that we did on October 15th last year. Despite the company saying that you do smaller cases first, I was too excited and I was waiting for nearly 10 years to get the robot to India. And this was a scoliosis, double major curve, 45 degrees each. And we planned with 2 spins. And we put the pedicle screws and done a good correction, and patient walked 6 hours after the surgery. This was the first full robotic scoliosis surgery done in India. Kyphosis, he is a congenital scoliosis child with 1 or 2 degree angulation with cord compression. We did place the screws, and then one side we put the rod. We did the navigation again, and we used the navigated bar to do the posterior vertebral column resection, completing the removal of anterior vertebra in a live fashion, wherein you will see the monitor and you do the drilling and removing the bone. And you get a good correction of kyphosis and patient walks. in 6 hours. A neuromuscular scoliosis, kyphoscoliosis, operated meningomyelocele elsewhere, having Arnold Chiari and severe kyphoscoliosis at the lumbosacral junction. You plan, I have done the foramen magnum first, and then I have planned the 9-level in the thoracolumbar spine and 4 iliac screws and a good correction of the kyphoscoliosis. Again, this is the first neuromuscular scoliosis being done in India. S2LR iliac screws series, failed back syndrome, operated 13 years back, retired professor of Ambedkar Medical College. So he had a 6-level compression again, and we planned S2LR iliac screws for the first time. Although there is no workflow, we devised it on our own, and these are perfectly positioned screws, and in 6 hours the patient at 72 years walking after 6 hours of a revision surgery. Kyphoplasty, as you all know, vertebral fractures, today we do plan balloon kyphoplasty. Gone are the days wherein you say complete bed rest for 3 months because it is known to increase osteoporosis. And here, putting guide wires in patients who are complete collapse of vertebra, or in thoracolumbar kyphoscoliotic patients with fractures, or in severely morbidly obese patients wherein getting a C-arm image is becoming difficult, you use the balloon guidance to place the needles. Using robotic guidance, you can accurately place them and direct the cement to either superior or inferior end plate, whichever area is the fractured area. We have a series of 38 cases so far, and we have sent it for publication. It is accepted for publication. Insufficiency fracture of sacrum, failed conservative treatment. We have done double balloon sacroplasty. Again, it is the first one in the world that has been done, and we have already, it is published in Asian Spine Journal. A fracture with one side hemipelvectomy because of vascular injury, the other side is a vertically unstable sacral fracture. We reduced it with distal femoral pin, and we used iliosacral screws using robotic guidance, percutaneous, because the other side there is a raw wound. Risk of infection is high. You have achieved a good reduction, and it is first time. Again, we have done 2 of sacral fractures, and we have sent it for publication. Again, lumbar scoliosis with anterior fixation. We have used robotic guidance to put anterior screws. Here, all the things are live and in real time. As you can see here, you can look at the monitor and do the drilling of the vertebra. And there is no wobbling, because if you wobble, a cancellous screw can become loose. And, oops. And you have a good correction of scoliosis here. Again, that is done for the first time in the literature. The workflow is not there, we have done it on our own. Cervical posterior surgeries, pedicle screws are deadly. As you can see here, this is the spinal canal, and this is the vertebral artery foramen. In between, if you have to pass the pedicle screw, it is very demanding. And with this, you can see here, this is the beauty of this. As you drill, you can see that the drill is going between the vertebral artery foramen here and the spinal canal. And the gap is actually, it should be millimeter perfect. And we have so far done 18 cases of cervical pedicle screw fixation. This was the first one actually in India, and we have done many more with accuracy of 100% placement of screws, and it is doing good. Again, 2-level disc, you do disc replacement. There is no workflow. We have done our Indian jugaad, and this is 2-level disc replacement that we have done, and we are done. And this is again occipitocervical fusion, first one in the country that we have done. And in summary, take-home messages are very simple, friends. Technique and technology helps, but indications and principles of surgery don't change. I don't think it will change even after another 30 years. If surgeon doesn't understand this, I think technology is here to hurt us. Embrace and engage technology responsibly. Be patient. I think for all the new doctors, it is all the more important to learn old ways of doing things, because computer may crash down anytime. And patient first attitude should not change. This is a short video of 1 minute about the robotic. Actually 2 hours surgery, they have condensed it into 1 minute. Patient is on the table, the robotic parts are prepared. You have a lot of fixtures. It has got shoulder, elbow, and wrist. And it will see how much of movement is allowed without any obstruction. Again, still they are placing the parts of the robot. Reference frame is being put. The pin into the posterior superior iliac spine will fix the robot to the patient's body. Now you are fixing. So it becomes one unit, robot and the patient. Now predefined scan to see whether the robotic arm can access the area of interest, the region of interest. The snapshot will give the orientation of the sleeve with the base of the robot. Then the star marker region of interest is marked. And then you have this intraoperative CT scan, which is O-arm. It's a big elephant in the theater, which comes into the operating room, takes a CT scan in 3 dimensions, axial, coronal, and sagittal views. And the images are directly ported to the robot live. And in the robotic console, the images are getting transferred, and then you plan all the screws that you want to put. And this is actually the time-consuming part, wherein getting these screws. So actually, as a surgeon, it saves a lot of your time because all this is done by your team. And then you come and putting screws, 4 screws will take less than 5 minutes. You see, you make a stab wound, you don't have to look at the operating area. Through the sleeve, you drill, you tap, and you put the screw. So 1 screw will take less than a minute. If you have any number of screws, you can just go on putting. I think that is the beauty of it. It is like having manual car, you change to an automatic car, that comfort you will get. Quickly, we have evolved in the last 16 years at Main Manipal, having developed this comprehensive spine care center, incrementally building complex capabilities. Today we are 6 consultants, 4 FNB fellows, we have 1 Manipal fellow, and in robotic spine, we have a fellow which is only 1 in the country and 1 in the world, which is there, a formal training for 1 year. We have started a separate spine anesthesia department and a spine physiotherapy department. Spine anesthesia has got 4 consultants and 1 fellow, which is again a unique concept in the country. And spine physiotherapy, we have 3 consultants and 2 PhD people. And we have a big team of doctors. It is 16 years so far at MHB for me. We treat 80 to 100 patients daily, 15 to 20 injections to the spine daily, 3 to 5 surgeries daily, and we are on call throughout the year, 365 days. Success rate is at par with the world. We were first for doing a lot of things, and a lot of things came in 2023 after we got the robot. Thanks to the hospital support, and we are future ready. Thank you one and all.
Just, you can have 1 or 2 questions, not more than that. Anyone?
I think we have exceeded the time of question, and
Yeah.
I don't know much
Yeah.
more than what is written there.
Correct.
Thank
Okay.
you.
Okay, I think we'll conclude this session.
Thank you, Dr. Vidyathar, for a very entertaining and informative talk. I'm sure everyone enjoyed it thoroughly and would have picked up a lot of points to take home.
Credit goes to my parents who are teachers. I wish I could do a good teaching job. Thank you.
I would request Dr. Aleem to please honor sir.
We just conclude the session, and we now request our president to honor the chairperson. So after this session, we don't have any breaks. We just go on directly to the inauguration function.
So good morning everyone. Awaiting our inaugural function, we have a small this thing from Microlabs. Microlab has taken an initiative to protect the Mother Earth for us and our future generation. To share more information about this, I call upon Yash Mehta from Microlabs. So we request our senior founder member, Dr. B.C. Rao, to unveil this.
Thank you, doctors. Greetings of the day from Microlabs. I am Yash Mehta. I represent Dolo 650 as the brand manager. And today I wish to share with all of you initiative that we all are very proud of, that is called the Dolo 650 Plastic Neutral Initiative. To sum it up, I'm sure you all are aware that the world's biggest problem today is plastic and the harmful impacts of plastic. Everywhere, wherever we go, there is plastic around us. And for plastic to dissolve or disintegrate in the environment takes a lot of years. Probably one bottle takes around 100 years in the environment to mix up with the soil and to disintegrate and be dissolved in the soil. So concerns of plastic has been alarming because of various reasons across the globe. And today Dolo 650 is India's first plastic neutral pharmaceutical brand, wherein we in 2024 this year we are removing 350 metric tons, that is 3.5 lakh kilos of plastic from the environment. So this is our, way to give back to the society. Being one of the biggest paracetamol brands in India, we feel that it is our moral duty to give back to the society. And this is not only because we are the biggest brand, but it is because of all your support in terms of the prescription and the trust and the love in the brand that you have, that we have been capable enough and we feel that we are deserving enough to take up this initiative to help India reduce, recycle and reuse 350 metric tons of plastic from the environment. So we have a small clipping about what this entire initiative is. So I would request the team Skyline to please play the video to show more about our entire initiative on plastic pollution. So in the year 2024, we are removing 350 metric tons, but definitely with all your support in terms of prescription and the trust in the brand, in the coming years, we would want to remove more and more amount of plastic from India so that we can help fight against plastic pollution. So thank you for all your support, and I hope being nation's pride, being a very popular brand, I'm sure, we have taken up this activity and the initiative to preserve our environment, and we hope that your support continues for this brand so that we can always, increase our share to remove so much plastic from the environment. Also to add, I request all of you to visit Microlabs' stall. We have a souvenir for all of you, so I humbly request all of you to come and have a look and take our souvenir, that is the Dolo Fevometer. It is a thermometer which we have recently introduced. So I request all of you to visit our Microlabs stall at the exit, at the entrance of the venue. Thank you so much.
Hello. Yash Gupta to come on stage to receive the honors. So hearty welcome to the 33rd Family Fusion Conference held at Hotel Capital. So welcome all the delegates, guests of honor, and chief guest, our Sharan Shivraj Patil, for the event. So it gives me pride and privilege, being an organizing secretary of the organization, to start the inaugural function. So I call upon the chief guest, so Dr. Murli, to accompany the chief guest to the dais. I call upon Dr. B.C. Rao, guest of honor, Dr. Shivanna to accompany to the dais. I call upon Dr. Ravindra Mehti, DHO Bangalore, Dr. Ramesh to accompany. I call upon our National FFPA Secretary, Prajnesh Vacharajani, to the stage. I call upon our President, Harish Kumar. I call upon Dr. Abdul Alim, our Secretary of the Association. So, we start the program with the invocation by our senior member, Dr. Geeta Gururao.
Hello. Good morning, everybody. गजमुखने सिद्धिदायकने वंदिपे शरणो शरणो त्रिजगवंदितनाद देवदेवने शरणो त्रिजगवंदितनाद देवदेवने शरणो सुजनरिगे विघ्नवनो परिहरिसे शरणो गजमुखने सिद्धिदायकने वंदिपे शरणो शरणो ಮಂದಮತಿಯನು ಬಿಡಿಸಿ ಚಂದ ಜ್ಞಾನವನಿತು ಇಂದಿರೇಶನ ಪಾದ ಹೊಂದಿಪತೆರದಿ ಸುಂದರಾಂಗನೆ ನಿನ್ನ ಪದತೊಂದ ಕೆರಗುವೆನು ಸುಂದರಾಂಗನೆ ನಿನ್ನ ಪದತೊಂದ ಕೆರಗುವೆನು ಸಂದೇಹ ಮಾಡದಲೆ ಇಂದು ಕರುಣಿಪುದು ಗಜಮುಖನೆ ಸಿದ್ಧಿದಾಯಕನೆ ವಂದಿಪೆ ಶರಣೋ ಶರಣೋ ಸಿದ್ಧಿದಾಯಕ ನಿನ್ನ ಹೊಂದಿ ಮೆರೆವೆನು ನಾನು ಅಬ್ಧಿಶಯನನ ಮಹಿಮೆ ಬದ್ಧದಲ್ಲಿ ಪೇಳ್ವಾ ಶುದ್ಧಮತಿಯನ್ನು ಕೊಟ್ಟು ಉದ್ಧರಿಸಬೇಕೆನ್ನ ಶುದ್ಧಮತಿಯನ್ನು ಕೊಟ್ಟು ಉದ್ಧರಿಸಬೇಕೆನ್ನ ಮಧ್ವಬಲ್ಲಭವೇಣು ಕೃಷ್ಣ ಗತಿ ಪ್ರಿಯ ಗಜಮುಖನೆ ಸಿದ್ಧಿದಾಯಕನೆ ವಂದಿಪೆ ಶರಣೋ ಶರಣೋ ಥ್ಯಾಂಕ್ ಯು.
So now we will move on to the important inaugural function. Lighting of the lamp by the dignitaries.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः दीपब्रह्मरूपस्त्वं ज्योतिषा प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
So the next, honoring our chief guest, Dr. Sharan Shivraj Patil. So to introduce Dr. Sharan Shivraj Patil, Dr. Manju Suneja, please come.
Good morning, friends. So it is my great privilege to introduce Dr. Sharan Shivraj Patil, who is the Chairman and Chief Orthopedic Surgeon at Sparsh Hospital. Dr. Sharan Shivraj Patil completed his medical school with an academic distinction from MR Medical College, Gulbarga, after a brief stint at St. Martha's in Bangalore. His postgraduate education was at Kasturba Medical College, Manipal. He was awarded D. Ortho in 1990, followed by the MS with a gold medal in 1992. He moved to the UK for further training. He worked in some of the premier teaching institutions in Northwest England, including Alder Hayes Children's Hospital, one of the largest pediatric hospitals in Europe. This institution, known for many firsts in the world of orthopedics, gave him extensive training in operating on challenging orthopedic problems in children. The other renowned organizations where he gained valuable experience were Royal Liverpool University Hospital, Hope Hospital, Manchester, and Warrington District General Hospital. His career comes with a long list of recognitions. The highest civilian award by the state of Karnataka, Kannada Rajyotsava Award in 2007. Nominated for the CNN IBN Indian of the Year 2007 in the public service. The Suvarna Kannada Rajyotsava Prashanti 2007 by Karnataka Cultural Academy. The Belly Chukki 2007, the Suvarna Kannada Rajyotsava, Prabhashasti, the prestigious Aryabhatta Award, the Vinoya Vaidya Ratna Award, Dr. P.S. Shankar Vaidya Shri Award, and Karnataka Orthopedician Association 2012, Dr. Shyam Sundar Shetty Oration Award. Thank you, sir.
So I now request our chief guest, Dr. Sharan Shivraj Patil to address the gathering.
Good morning, everybody here. Thank you for inviting me. The dignitaries on the dais, the president, organizing secretary, the office bearers of this prestigious Family Physicians Association, my dear friends and colleagues in the audience. It's an absolute honor for me to be here. Thank you for the invite. Suddenly today I'm feeling a little old for some reason. The main reason is I've seen this Dr. Vidyadhar as a young, bright boy coming to from KMC Manipal, coming to Manipal Hospital Airport Road for a 3-month stint or something like that. This bright young man has become such a thoroughbred professional, and he is scaling heights in the profession, and he's become such a good leader. It's lovely to see. And only one change I have noticed him is that as he's growing bigger, he's becoming more and more humble, which is a fantastic thing for you, Vidyadhar. Thank you so much. So I keep saying the pillar of healthcare is such a true definition of family physicians. It truly means every word it says. The reason is, like Vidyadhar showed all the robotic work we are doing, and we do a lot of robotic joints, and everything is getting technology oriented, and so much more precision in what we do and how we achieve things. As we take this direction, which is inevitable, we are doing more and more of the precision science. Invariably, we take the help of technology to do this. In my younger days, I could never dream of executing a plan as well as we can do it today. And it has taken me 30 years to get that precision. But today, the younger people can do this as good as me because the technology is there to help them to be as precise as I do after 30 years of working. I keep saying this all the time, and I never get tired saying this. When we take a flight to any part of the world, we never check what is the experience of the pilot or who's the pilot. We just board the plane because we are so sure we'll land there reasonably safely. That's because he has got all the aids, the landing gear, the technology is so well equipped to do that, and that's how we don't worry about who's the pilot. And that's what is going to come to medical science. The young people, experienced people, each one of us should be able to deliver the healthcare. Why should some patients be the subject of somebody's learning curve? It's very unfair on the society. And to produce a 30 years experienced surgeon, it takes a lot of time. There is no time in this world for that kind of investment into people's talent and skill sets. We do not have the same quality of healthcare 100 kilometers from Bangalore as we have in Bangalore. That's very unfair as well. Forget the Raichurs and the Gulbargas and the Africas of the world. There's only one way we can deliver consistent, good quality healthcare is by use of technology, and we can produce multiples of doctors who can deliver this as effectively with the help of gadgets and technology. And that's the only way to scale, and that's what this world needs, not 30 years of experience. It doesn't work anymore. So the reason why I'm saying all of this is when Vidyadhar does the robotic surgery, because it's all the scans and everything prepares the images. You sit in your office and do all the planning, how I'm going to execute this. And pretty much once the planning is done, except for the small changes, the technician can execute the whole plan. So when you can do that, that's when you are developing a lot of AI and machine learning and intelligence. All this data of what Vidyadhar did with this data and how he arrived at a plan and how it was executed, this is not going away. All this data, what we do every day with robotics, or anything we collect as image data, as data of investigations, all that gets collated. And with large data, you can arrive at algorithms which will tell you what to do. You know where I'm going. You might not need Vidyadhars and the Sharan Patils in the future, because it is going to be algorithm driven. This is what you're going to deliver. That brings back to the point of family physicians. So the risks of Vidyadhar's and Sharan Patil jobs are at risk, but family physician's job is never at risk. Why I'm saying that is, the nurses' jobs are not at risk. The family physician's job is not at risk because it's not all about the science, it's about the personal connect, the empathy, the 360 degrees of knowing your patients and delivering what they need is going to be the pillar of healthcare, and you are there to stay. We may be extinct. So what I'm trying to emphasize here is please take your job with the greatest amount of vigor, and it is, in my opinion, patients look up to you for the solutions. You may not provide the solution at certain times because you don't have the wherewithal to do it, but ultimately the solace, the 360 degrees view, the family, each one of them depend on you. So do the hospitals depend on you to refer patients at appropriate time, to be part of the story, because it becomes more and more mechanical when they come to the hospitals, but they need a connect. So your role is dual. Your role is to build the communities, healthy communities, and be part of the community and the connect. Also to connect with the hospitals so that you know what is best available and how to get the best out of it. And ultimately, you are the anchor of healthcare. You are the pillar of healthcare. Thank you so much.
So thank you for your inaugural speech, sir. So the next is honor of the guest, Dr. B.C. Rao, founder, member FPA, and Dr. Subramaniam to come to stage and introduce B.C. Rao.
Good morning, dear friends. I was asked to introduce Dr. B.C. Rao, Captain Dr. B.C. Rao. He requires no introduction to this family. I don't call this as a family physician organization. This is one family built by founders like Dr. B.C. Rao, Dr. S.K. Srinivasan. We are blessed today, after so many years. Dr. S.K. Srinivasan is here, he is 90 plus, and Dr. B.C. Rao also here today. We are really blessed. Today is a memorable day in history of FPA. And to tell about Dr. B.C. Rao, it requires volumes. He by self a military man, disciplined and fitness conscious. It goes without saying. If not, he was here today, he would be in golf course. That is his hobby. He is a role model for each one of us about how to be a complete personality. He is a teacher of teachers, mentor of mentors. There was a day I used to feel shiver to stand up and ask a question. He has mentored us to stand on the stage and speak. And today I'm fortunate to speak about him, my teacher, my mentor. Thank you, sir. He's an extraordinary family physician by knowledge, by experience, by humanity, humbleness, and any word you have in dictionary to fit into a personality of a gentleman practitioner, family physician, that is Dr. B.C. Rao. If I have to put it in one word, all these qualities, can I say the complete man? Sir, your enthusiasm and spirit, dedication to FPA Bangalore is invaluable. You have trained so many leaders, future organizing committee members, which is being carried forward even today. I thank the executive committee, directly or indirectly. You are all chain of continuity from what Dr. B.C. Rao, Dr. Srinivasan has started this organization. To the best of my knowledge, there are very few organizations which are carrying forward principles and philosophy of educating family physicians. Where are they? Who is teaching us after our college? No. Only organizations like FPA Bangalore and many organizations. So, with these few words, my dear friends, and I want to mention this word, Dr. B.C. Rao has written a book on life of a family physician that will describe his journey as a family physician, the ups, downs, happy days, other things. It gives guidance to all the newcomers to take up this family medicine as a choice, not as a last resort. And it is going to happen, as Dr. Sharan, Doctor said, family medicine is going to stay. Let other specialties come and go. Family medicine will continue. Please encourage your children, your fellow colleagues, youngsters to take up medicine and to become family medicine. It is the need of our dear friends. Thank you very much.
Okay. Thanks, Pa Subramaniam, for a nice gesture and talk on B.C. Rao. So I request our founder member, our FPA is for 45 years old. I think in the first half of 1979, this organization was formed under B.C. Rao with a couple of members. I think many of them are deceased. With the blessings of them, this is going on. So I request Dr. B.C. Rao to address.
Dr. Harish Kumar, Dr. Prabhakar, and others on the dais, and my friends and colleagues sitting in the audience. You should never ask a close friend of yours to introduce you. Subramaniam has highly exaggerated my achievements. Should I thank you or should I curse you? I'm not sure. Thank you. In fact, when Harish Kumar asked me for my biodata, I told him just to tell the audience that I'm a teacher of family medicine. This brings me to the question, and he also told me to tell you guys about how we started and why we started this Family Physicians Association. Has SK come back here? Okay. You see, it was in mid-70s that SK Srinivasan and I were very active with the IMA. IMA has a wing called IMA CGP. I was the secretary there, and Dr. SK Srinivasan, whom I call as SK, was the secretary, and Dr. Parameshwara was the president. 3-4 years, we worked closely, the IMA CGP and the IMA main jointly worked very well. Then, we started getting problems in getting speakers and promoting family medicine per se, even under the auspices of IMA CGP. See, IMA CGP not necessarily always will be managed by family doctors. In fact, we found a physiology teacher becoming the secretary of IMA CGP. His approach to family medical practice was very different. So was the president who preceded or came after Dr. Parameshwara. He was different altogether. Then SK and I decided that we must start a dedicated organization exclusively to take care of the interests of the family medicine doctors. You see, this is a very broad-based, you can call it a specialty. Now everyone calls family medicine a specialty. My friend Mohan Kubendra, where is he? Yeah. Mohan Kubendra is the national selected, he is the next president of National Academy of Family Physicians. He and Dr. Mohan Kumar has been the pivotal persons who promote family medicine at the national level. And we are fortunate to have him in Bangalore. That apart, what happened next was how to start this organization. SK and I and some friends met and decided to start this. Initially, we were very few. There was no money. Those days, everyone was poor, and we were no exception. So what happened was we met and had tea. I don't know whose place it was. And then that is how it began. Initially, the numbers were few. And as it went on, the numbers grew. And then it became more popular amongst general practitioners and also among some consultant friends of ours. And the IMA did help us. And most of our meetings used to be held in the present IMA hall in Bangalore branch. So it started, and it continued to grow. And when the numbers became sizable, then what happened was the pharma companies got interested in us. Some pharma companies more than the others. And it became a problem for us how to manage our finances and also do a CME without much dependence on the pharma companies. So it was a kind of a seesaw battle. Some of us had different approaches, some had different approaches. But then we sort of fought on and came to a stage wherein the pharma companies agreed to our terms, and then the CMS went on with primary objective of promoting family medicine. And occasionally we had, for knowledge sake, speakers like my friend Dr. Vidyadhara, you should know what's happening. You need not actually participate in whatever he is doing, but at least know when to refer, and maybe after they get discharged, look after them in their homes. This most consultants forget that a large number of us are capable of managing the post-op patients and discharged patients at home. So that is how today we are here. And it's been a journey, very successful and very nice journey from an organization point of view. And also I must thank one pharma company which has stood by us and at our terms. And largely due to the effort of some of us and primarily due to Dr. Subramaniam, that micro labs have been our major supporters. So just to say that pharma companies are not there for their sake, but for our sake also. So please remember that when you write a prescription, think of micro, because they have been promoters of our organization for a number of years now. That is about the organization. If you have any more queries, I will talk to you at the recess. Next comes, what about family medicine? Where are we heading? See, most of you are successful family doctors. As a profession, where are we heading? See, what happens in medical school, most of us are exposed to consultants and mostly to curative medicine. There's a lot of glamour in curing a person, but there's no glamour in preventing a disease. If you look at the scenario of illness, it is said, there are a lot of published papers, I haven't brought them, but the evidence is nearly 88% of all illnesses can be handled in the community by family doctors. I would say competent family doctors. It's only 12% who will need consultant help. In that, only 3% need hospitalization. If 3% of hospital-based doctors hog 90% of the status, the money, and the treatment of illnesses, then you can understand and find out the real illness prevention and incidence scenario in this country. So a lot of money is being spent on looking after curative medicine doctors and hospitals, and very little is spent on primary care doctors, epidemiologists, and public health doctors. While stressing on the importance of family medicine, the only way to promote family medicine is to promote it in medical schools. Get young doctors exposed to family medicine doctors, and most of the learning should also take place in the community. If the learning is confined to hospitals, then what happens is that naturally the youngster would like to emulate a hospital-based doctors, and he doesn't even know what's happening in the community. So how will he become a family medicine doctor? At the present scenario, I find hardly any takers. Colonel Kubendra knows about it. Any takers for family medicine DNB? Those who take family medicine DNB, their numbers are virtually stagnant. I have been an examiner to family medicine DNB, and the enthusiasm I see has quietly, either it is status quo or it is waning. It's not a very good sign if you look at family medicine's progress in future. We are producing 100,000 medical graduates. There are 40,000 odd PG seats. The remaining 60,000, what will they do? Huge question. So tomorrow's, if you, maybe 10 years from now, if you order an Ola cab, the driver is most probably going to be a medical graduate. It's a pathetic prediction, but it might come true if we don't reverse this trend of everyone running to become a specialist. You see, today, soon after MBBS, an intern and the house surgeoncy days, one should really learn surgery and various aspects of medicine, different aspects of medicine. He is trying to become a specialist, trying to get into NEET, pass the exam, so they don't even do their basic internship and house agency. They don't take it seriously. So that is the scene, and unless we wake up, especially those in power, see, while not criticizing, but most of the powers that be administrators, even the health department in central and state, they are influenced by hospital-based doctors. Very few of them have the knowledge and the ability to deliver care in the community. And that is why our PHCs are in such bad shape. And so someone said, Subbu said, that you tell all your children to become family medical doctors. If I ask you, not even one hand will go up in this audience. That is the state today. I'm sorry I'm putting a sort of a dismal picture, but that has been my experience. And lastly, I must tell you, if someone becomes a family doctor today, the scope is enormous. A bit of risk-taking is required, like any other profession. And there is a crying need for family doctors in the community. I see a lot of gray hair here. A few of you I see with dark hair. That means what? That means there is a kind of a vacuum that is being created, which is not being filled. So the community needs you, and the future of family medicine depends on the governmental policies, and the only way to do that is to encourage family medicine in our medical schools and afterwards. And also paint a good picture of family medicine. You know, it's not all too bad. You have a reasonably good living, and the community loves you, and generations together you are their doctor. And who has this chance of leading such a wonderful, good life? So, with these few words, let me again thank you guys for taking this up, for making me feel good about starting this. And SK, when I was talking about you, you were not here. I owe a lot to him. But for him, you know, without his encouragement and late Dr. Parameshwara's support, I don't think this organization would have come up. Thank you, gentlemen.
So thank you, sir. You have given a valuable advice to our family physicians and young budding doctors. So it is a very good advice. So now we have an important task. The book release function by A Family Physician's Life, authored by Dr. B.C. Rao. The book release function will be done by Dr. S.K. Srinivasan, founder member FPA. It is a very happy occasion to release book by our own senior founder member of Dr. B.C. Rao by Dr. S.K. Srinivasan. It is one of the happiest moment of APA. So I, S.K. Srinivasan, we need to facilitate Dr. S.K. Srinivasan kindly. So I next invite our next guest of honor, Dr. Ravindra Methi, DHO, Bangalore, to come for facilitation, and to introduce Dr. Ravindra Methi, Dr. Ramesh to come to the dais.
Friends, it gives me great pleasure to introduce our guest of honor, Dr. Ravindranath Methi, today. He did his MBBS from BLDE Medical College. He did his post-graduation from Davangere, and you will not be surprised that he has been a general surgeon qualified. And other than that, he is also a trained EMOC surgeon, which has helped in the saving of hundreds of pregnant women. And he has finished 23 years in the health department from the posting as a medical officer in Sindhigi Taluk in Vijaypura district, and present he is a district health and family welfare officer, Bangalore Urban. He has another 12 years to go in the department, and definitely is going to occupy the pinnacle post in the health department, that of the Director of Health and Family Welfare Services. Other activities, he is a very good organizer. He is the immediate post secretary for the Karnataka Government Medical Officers Association, which is a premier organization of about 8,000 doctors in the health department. And I am also happy to announce that he is the president-elect for the same Karnataka Government Medical Officer Association, and he has got a key role for liaising between the public, including our doctors from FPAB and all other doctors, and also with the government. And wherever I have talked to him sometimes about some problems which other doctors, my colleagues, are facing, he has responded, and within a few days or sometimes maximum a week, he has seen that the jobs are addressed. So he has promised that anybody, doctors, can directly approach him and get the things done. Thank you, Dr. Methi, for one of us and continuing to be one of us. Thank you.
So thank you, Dr. Ramesh, for the kind words. So I call upon Dr. Ravindra Methi to address the gathering.
ಪ್ರಪ್ರಥಮವಾಗಿ ನನಗೆ ಕರೆದು ಈ ಫ್ಯಾಮಿಲಿ ಪ್ಲಾನಿಂಗ್ ಅಸೋಸಿಯೇಷನ್ ಸಮ್ಮೇಳನದಲ್ಲಿ ತಾವೆಲ್ಲರೂ ಸತ್ಕರಿಸಿದ್ದಕ್ಕೆ ತುಂಬ ಧನ್ಯವಾದಗಳು. ನಿಮಗೆಲ್ಲರಿಗೂ ಟೀಚ್ ಮಾಡೋಷ್ಟು ನಾನು ಭಾಳ ಜೂನಿಯರ್ ಇದ್ದೀನಿ, ಇಲ್ಲೆಲ್ಲರೂ ಸೀನಿಯರ್ಸ್ ಇದ್ದೀರಿ. ನಿಮಗೆಲ್ಲರಿಗೂ ಅಡ್ವೈಸು ಅಥವಾ ಟೀಚ್ ಮಾಡೋಂಥ ವ್ಯಕ್ತಿ ನಾನಲ್ಲ. ಆದರೂ ಈ ಒಂದು ವೇದಿಕೆಯನ್ನು ಬಳಸ್ಕೊಂಡು ನನ್ನ ಕೈಲಾದಷ್ಟು ಅಡ್ವೈಸ್ ನಾನು ಇಡ್ತೀನಿ. ನಮ್ಮವರೆಲ್ಲರೂ ಸೀನಿಯರ್ ಬಿಜಿ ಪ್ರಾಕ್ಟೀಷನರ್ಸು, ಭಾಳ ಬಿಜಿ ಇರ್ತೀವಿ ನಾವು. ಪೇಷಂಟ್ಸ್ ಭಾಳ ನೋಡ್ತೀವಿ. ಡಾಕ್ಟರ್ಸ್ ಎಲ್ಲ ಮಿಸ್ಟೇಕ್ಸ್ ಏನಾಗ್ತದೆ ಅಂದರೆ ರೆಕಾರ್ಡ್ ಕೀಪಿಂಗು. ನಾನು DHO ಆಗಿ 1 ವರ್ಷ ಆಯ್ತು ಬಂದು, 1 ವರ್ಷ 1 ತಿಂಗಳಾಯಿತು. ನಮ್ಮವ್ರು ಫುಲ್ ಬಿಜಿ ಇರ್ತಾರೆ. ಯಾವ ಥರ ಅಂದ್ರೆ ಯಾರೋ ಕನ್ಸಲ್ಟೆಂಟಿಗೆ ಕೊಡ್ತಾರೋ, ಮೀಡಿಯೇಟರ್ಸ್ಗೆ ಹೇಳ್ತಾರೋ, KPMB ಮಾಡಿಕೊಟ್ಬಿಟ್ರಿ, ಅಥವಾ PCPNDT ಇರ್ಬೋದು. ನಂದು ಒಂದು ಪ್ರಾಕ್ಟಿಕಲ್ ಎಕ್ಸ್ಪೀರಿಯೆನ್ಸ್ ತಮ್ಮ ಹತ್ರ ಶೇರ್ ಮಾಡ್ತಿದ್ದೀನಿ. ಏನಾಗುತ್ತಂದ್ರೆ ಅವರು ಇವಾಗ ನಮ್ಮ ಹತ್ರ ಬೇಕಾಗಿರೋ KPMB ಒಂದು ಕರ್ನಾಟಕ ಪ್ರೈವೇಟ್ ಮೆಡಿಕಲ್ ಎಸ್ಟಾಬ್ಲಿಷ್ಮೆಂಟಿಗೆ ಇಂಪಾರ್ಟೆಂಟ್ 4 ಡಾಕ್ಯುಮೆಂಟ್ಸ್. ಒಂದು ನಮ್ಮದು KMC ರಿಜಿಸ್ಟ್ರೇಷನು ಅಥವಾ ನಮ್ಮದು ಕ್ವಾಲಿಫೈಡ್ ಏನಾದರೂ ಇದ್ದು ಸರ್ಟಿಫಿಕೇಟು, ನಂತರ ರೆಂಟ್ ಇದ್ದರೆ ರೆಂಟ್ ಅಗ್ರಿಮೆಂಟು, ಅಥವಾ ಓನರ್ ಇದ್ದರೆ ಓನರ್ದು ನಮ್ಮದು BBMP ಟ್ಯಾಕ್ಸ್ ಪೇ ಇಡೋದೆಲ್ಲ ಕೊಡಬೇಕು. ನಂತರ ನೆಕ್ಸ್ಟು ಫೈರ್ ಸೇಫ್ಟಿ ಮೋರ್ ದೆನ್ 21 ಮೀಟರ್ಸ್ ಇದ್ದರೆ ಫೈರ್ ಸೇಫ್ಟಿ ಡಿಪಾರ್ಟ್ಮೆಂಟಿಂದ ಸರ್ಟಿಫೈ ಮಾಡಿ ನಾವೆಲ್ಲ ಸಬ್ಮಿಟ್ ಮಾಡಬೇಕು. ಅದೇ ಥರನಾಗಿ ಪೊಲ್ಯೂಷನ್ ಕಂಟ್ರೋಲ್ ಬೋರ್ಡಿಂದ ಸರ್ಟಿಫಿಕೇಷನ್ ಆಗಬೇಕು. ಎಷ್ಟು ಬೆಡ್ ಇರುತ್ತಾ ಅಷ್ಟು ಬೆಡ್ಡಿದ್ದು ಅವರು ಫಾರಮ್ 3 ಕೊಡ್ತಾರೆ. ಫಾರಮ್ 3 ಅಟ್ಯಾಚ್ ಮಾಡಬೇಕು. ಕ್ಲಿನಿಕ್ ಇದ್ದರೆ ಅವ್ರು ಕ್ಲಿನಿಕ್ಕಿಗೆ ಸರ್ಟಿಫಿಕೇಟ್ ಕೊಡ್ತಾರೆ, ಅದನ್ನು ಅಟ್ಯಾಚ್ ಮಾಡಬೇಕು. ಅದಾದ ನಂತರ ಮರ್ಡಿಯವ್ರ ಹತ್ರ ನೀವು MOU ಮಾಡ್ಕೊಂಡಿರ್ತೀರಿ, ಎಲ್ಲ ಇರ್ತೈತಿ. ಇವತ್ತು ಯಾವ ಯುಗ ಇದೆ ಅಂದರೆ ರೀಸೆಂಟಾಗಿ ನಾನು 2 FIR ಮಾಡಿದ್ದೀನಿ. ಒಂದು ಯಾವುದೋ ಒಂದು ದೊಡ್ಡ ಹಾಸ್ಪಿಟ್ಲು, ಹೆಸರು ಹೇಳೋದು ಬೇಡ, ದೊಡ್ಡ ಹಾಸ್ಪಿಟ್ಲು. ದೇ ಹ್ಯಾವ್ ಗಿವನ್ ಕನ್ಸಲ್ಟೆಂಟ್ ಯಾರೋ ಕೊಟ್ಟು ಎಲ್ಲ ಸರ್ಟಿಫಿಕೇಟ್ ಮಾಡ್ಲಿಕ್ಕೆ ಕೇಳಿದ್ದಾರೆ. ಅವರು 21 more than 21 ಮೀಟರ್ ಅದು ಹಾಸ್ಪಿಟ್ಲಿದೆ. ಅವರು ಫೈರ್ ಸೇಫ್ಟಿ ಸರ್ಟಿಫಿಕೇಟ್ ತೊಗೋಬೇಕು. ಅದನ್ನು ಯಾವುದೋ ಹಳೆಯ ಸರ್ಟಿಫಿಕೇಟ್ ಮೇಲೆ PDF ಮಾಡಿ ಸಬ್ಮಿಟ್ ಮಾಡಿದ್ದಾರೆ ನಮ್ಮ ಆಫೀಸ್ಗೆ, ಡೂಪ್ಲಿಕೇಟ್ ಮಾಡಿ. ಅದನ್ನು ಇನ್ನೊಬ್ರು ಯಾರೋ ನಮ್ಮ KPMB ನೋಡಲ್ ಆಫೀಸರ್ ವಿಸಿಟ್ ಮಾಡಿದಾಗ ನಮ್ಮ ಡೌಟ್ ಬಂದು ವೆರಿಫೈ ಮಾಡಿದ್ವಿ. ಆ ಡಾಕ್ಟ್ರು ಅವ್ರಿಗೆ ಬೇಕಾಗಿರೋ ದುಡ್ಡು ಎಲ್ಲ ಕೊಟ್ಟಿದ್ದಾರೆ. ಗೌರ್ಮೆಂಟ್ ಫೀಸ್ ಎಲ್ಲ ಕಟ್ಟಕ್ಕೆ ದುಡ್ಡು ಇಸ್ಕೊಂಡು ಅವರು ಡೂಪ್ಲಿಕೇಟ್ ಮಾಡಿ ನಮ್ಮಲ್ಲಿ ಅಪ್ಲಿಕೇಶನ್ ಹಾಕಿ ಲೈಸೆನ್ಸು ಇಶ್ಯೂ ಆಗಿದೆ. ನಾನು ಅದನ್ನು ಭೇಟಿ ಕೊಟ್ಟು ಪರಿಶೀಲನೆ ಮಾಡಿದ. ಪಾಪ ಡಾಕ್ಟ್ರು ಮುಗ್ದ್ರು, ಅವರು ಗೊತ್ತೇ ಇಲ್ಲ ಅವ್ರಿಗೆ. ನಾವು ಹೋಗಿ ವಿಸಿಟ್ ಮಾಡಿ ಕೇಸ್ ಹಾಕೋವರೆಗೂ ಅವ್ರಿಗೆ ಗೊತ್ತೇ ಇಲ್ಲ. ದೇ ವಿ ಆರ್ ನಾಟ್ ಅವೇರ್. ನಾವು ಇಮ್ಮಿಡಿಯೇಟ್ DC ಹತ್ರ ಮೂವ್ ಮಾಡಿ ಅದು ಫಸ್ಟ್ ಲೈಸೆನ್ಸ್ ಕ್ಯಾನ್ಸಲ್ ಮಾಡಿದ್ವಿ. ಕ್ಯಾನ್ಸಲ್ ಮಾಡಿ ಇವಾಗ ನಾವು ಒಂದು FIR ಹಾಕಿದ್ದೀವಿ ನಮ್ಮ ಆಫೀಸಿಂದ. ಸೊ ಆ ಕನ್ಸಲ್ಟೆಂಟೂ ಸಿಗ್ತಾಯಿಲ್ಲ. ಪಾಪ ಡಾಕ್ಟ್ರಿಗೆ ಲೈಸೆನ್ಸ್ ಕ್ಯಾನ್ಸಲ್ ಆಯಿತು. ನಾವು ಅವರು ಓಡಾಡ್ತಿದ್ದಾರೆ ಈಗ ಪೊಲೀಸ್ ಸ್ಟೇಷನ್ಗೂ ಕೋರ್ಟು. ಅದಾದ ನಂತರ ಈಗ ಇನ್ನೊಂದು ಲೈಸೆನ್ಸ್ ತೊಗೊಂಡ್ರು ಅವ್ರಿಗೆ ಮಾಡಿಕೊಟ್ವಿ. ಇದು ಒಂದು FIR. ಇನ್ನೊಂದು FIR ತಮಗೆಲ್ಲರಿಗೂ ಗೊತ್ತಿದ್ದಂಗೆ ಈ PCPNDT ಸರ್ಟಿಫಿಕೇಟು ನೀವೇನೇ ಸ್ಕ್ಯಾನ್ ಮಷಿನ್ ತೊಗೋಬೇಕಂದ್ರೆ ಅಥವಾ ಚೇಂಜ್ ಮಾಡಬೇಕು, ಶಿಫ್ಟ್ ಮಾಡ್ಬೇಕಂದ್ರೆ DHO ಆಫೀಸು, DHO ಇಂದ ಒಂದು ಸರ್ಟಿಫಿಕೇಷನ್ ತೊಗೋಬೇಕಂದ್ರೆ ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಅಪ್ರಾಪ್ರಿಯೇಟ್ ಅಥಾರಿಟಿ. ಸೊ DC ಅದಕ್ಕೆ ಚೇರ್ಮನ್ ಇರ್ತಾರೆ. ಇಲ್ಲಿ ಒಂದು ವಿಚಾರ ಏನಂದ್ರೆ ಅದು ನಮ್ಮ ಗೌರ್ಮೆಂಟ್ ಹಾಸ್ಪಿಟ್ಲಿಗೆ, ನಮ್ಮ ಗೌರ್ಮೆಂಟ್ ಹಾಸ್ಪಿಟ್ಲು BBMP ಗೌರ್ಮೆಂಟ್ ಹಾಸ್ಪಿಟ್ಲಿಗೆ ಅವರು ಇದೇ ಥರನಾಗಿ ಯಾರೋ ಕನ್ಸಲ್ಟೆಂಟ್ ಮೊರೆ ಹೋಗ್ಯಾರ ಅಥವಾ ಈ ಸ್ಕ್ಯಾನ್ ಮಷಿನ್ ಕೊಡೋರು ಅವ್ರು ಅರ್ಜೆಂಟಿಗೆ NOC ತೊಗೊಂಡು ಅವರು ಇನ್ಸ್ಟಾಲ್ ಮಾಡಬೇಕಾಗ್ತೈತಿ. ಅಲ್ಲಿ ನಮ್ಮ DHO ಅವ್ರ ಸೈನೇ ಡೂಪ್ಲಿಕೇಟ್ ಮಾಡಿದ್ದಾರೆ. ದೇ ಹ್ಯಾವ್ ಸೈನ್ಡ್ ಅವರ್ ಪ್ರೀವಿಯಸ್ DHO ಸೈನ್ ಡೂಪ್ಲಿಕೇಟ್. ದೇ ಹ್ಯಾವ್ ಸೈನ್ಡ್ ಅವರ್ GA ಸೈನ್ ಡೂಪ್ಲಿಕೇಟ್, ಗೆಸ್ಟೆಡ್ ಅಸಿಸ್ಟೆಂಟ್ ಆ್ಯಂಡ್ ಕ್ಲರ್ಕ್ ಸೈನ್. ಸೊ ಈ ಥರನಾಗಿ ಅದನ್ನು ನಾವು ಒಂದು FIR ಮಾಡಿದ್ದೀನಿ. ಅದೇ ಥರನಾಗಿ ಟೋಟಲ್ ಈ ಬೆಂಗಳೂರಲ್ಲಿ ಸುಮಾರು 8-10 ವರ್ಷದಿಂದ ಯಾವ ಸ್ಕ್ಯಾನ್ ಮೆಷಿನ್ಸು ಸರಿಯಾಗಿ ತಪಾಸಣೆ ಆಗಿರಲಿಲ್ಲ ಅಥವಾ ಮಾಡಿರಲಿಕ್ಕಿಲ್ಲ. ಬಟ್ ನಾವು ಆ್ಯಸ್ ಎ DHO ಆಗಿ ಬಂದ ನಂತರ ಒಂದು 9ರಿಂದ 10 ಸ್ಕ್ಯಾನ್ ಮಷಿನ್ ಸೀಸ್ ಮಾಡಿದ್ದೀನಿ. ಟೋಟಲ್ ನಮ್ಮ ಹತ್ರ 14. ಎಲ್ಲರೂ ಆಲ್ ಡಾಕ್ಟರ್ಸ್ ಆರ್ ಬಿಸಿ. ಅವರು ಆ ಸೆಕ್ಷನ್ನಿಗೆ ಕಾನ್ಸಂಟ್ರೇಟೇ ಮಾಡಲ್ಲ. ಫಾರಮ್ F ಇರಲ್ಲ, ಕ್ಲರಿಕಲ್ ವರ್ಕು. ಅದಕ್ಕೆ ಈ ವೇದಿಕೆ ಮುಖಾಂತರ ನಾನು ಏನು ಹೇಳ್ತೀನಿ ಅಂದರೆ, ಪೇಷಂಟ್ ನೋಡೋದ್ರ ಜೊತೆಗೆ ನಮ್ಮ ರೆಕಾರ್ಡ್ಸ್ ಕೀಪಿಂಗಲ್ಲಿ ದಿನಕ್ಕೆ ಒಂದು 15ರಿಂದ 20 ನಿಮಿಷ ತಾವು ಸ್ಪೆಂಡ್ ಮಾಡಬೇಕು. ರಿಕಾರ್ಡ್ಸು ತಾವೇನು ಮಾಡ್ತೀರಿ, ಕ್ಲರ್ಕು, ಮ್ಯಾನೇಜರ್ ಯಾರೋ ಒಬ್ರಿಗೆ ಹೇಳಿರ್ತೀರಿ, ಅವ್ರು ಮಾಡಿರಂಗಿಲ್ಲ ಸರಿಗೆ, ಏನೋ ಒಂದು ಮಿಸ್ಟೇಕ್ ಇರುತ್ತೆ. ಆ ವಿಸಿಟ್ ಬಂದಾಗ ಪ್ರಾಬ್ಲಮ್ ಆಗುತ್ತೆ. ಆಮೇಲೆ ಮೊದಲು ಒಂದು ಕಾಲ ಇತ್ತು ನಮ್ಮದು, ನಾವು ಹೋಗ್ಬೇಕಾದ್ರೆ ಡಾಕ್ಟ್ರ್ ಅಂತ ಗೊತ್ತಿದ್ರೆ ಯಾರೋ ಪಕ್ಕಕ್ಕೆ ಬಂದು ಕೊಡ್ತಿದ್ದಿಲ್ಲ ಒಂದು ಡೇನಾಗ. ಅಷ್ಟು ಗೌರವ ಇತ್ತು ಡಾಕ್ಟ್ರಿಗೆ. ಇವಾಗ ಆ ಥರ ಎಲ್ಲ ಚೇಂಜು. ನಾನು ಪರ್ ಡೇ ಈ ಹಾಸ್ಪಿಟಲ್ ಮೇಲೆ ಕಂಪ್ಲೇಂಟ್ ಪರ್ ಡೇ ಮಿನಿಮಮ್ 10 to 15 ಅಂತ ಬರುತ್ತೆ ನನಗೆ. ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಅಪ್ರಾಪ್ರಿಯೇಟ್ ಅಥಾರಿಟಿಗೆ 10ರಿಂದ 15 ಕಂಪ್ಲೇಂಟ್ಸ್ ಬರ್ತಾವೆ. 10ರಿಂದ 15 RTA. ಇವ್ರ ಕ್ಲಿನಿಕ್ ಡಾಕ್ಯುಮೆಂಟ್ಸ್ ಕೊಡ್ರಿ, ಇವ್ರದ್ದು ಹಾಸ್ಪಿಟಲ್ ಡಾಕ್ಯುಮೆಂಟ್ಸ್ ಕೊಡ್ರಿ, ಇದೇ ಥರ ಬರ್ತಾವೆ. ಸೊ ಅದಕ್ಕೆ ನನ್ನ ಈ ವೇದಿಕೆ ಮುಖಾಂತರ ಎಲ್ಲರಿಗೆ ರಿಕ್ವೆಸ್ಟ್ ಮಾಡೋದಂದ್ರೆ, ತಾವು ಮಧ್ಯವರ್ತಿಗಳ ಅಥವಾ ಇನ್ನೊಬ್ರು ಯಾರೋ ಸಪೋರ್ಟ್ ತೊಗೊಳ್ದೆ ತಾವು ನೇರವಾಗಿ ಬಂದು ನಮ್ಮ ಡಾಕ್ಯುಮೆಂಟ್ ಸಬ್ಮಿಟ್ ಮಾಡಿದರೆ ನಾವು ನಾನು DHO ಇರೋವರೆಗೂ ನಮ್ಮ ಗುರುಗಳಾದ H.C. ರಮೇಶ್ ಸರ್ ಅವ್ರು ಹೇಳಿದೆ, ಸರ್ ನಾನು ಬಂದು ಅಲ್ಲಿ ಏನು ಮಾಡಲಿ, ಎಲ್ಲ ಸೀನಿಯರ್ ಡಾಕ್ಟರ್ಸ್ ಇರ್ತೀರಿ ಅಂದು. ಅವರೆಲ್ಲ ನೀವು ಬರಲೇಬೇಕು ಮೇಟಿ ಅಂದರು. ಸೊ ಅವರು ನಮಗೆ ಕರೆದು ಇಲ್ಲೆಲ್ಲ ಸರ್ಕಾರ ಮಾಡಿ ನನಗೊಂದು ಈ ವೇದಿಕೆಯನ್ನು ಎಡೆ ಮಾಡಿ ಕೊಟ್ಟದಕ್ಕೆ ಅವರಿಗೂ ಮತ್ತು ಎಲ್ಲರಿಗೂ ಹೃತ್ಪೂರ್ವಕ ವಂದನೆಗಳು. ಥ್ಯಾಂಕ್ ಯು.
ಸರ್ ಧನ್ಯವಾದಗಳು ಸರ್ ತಮ್ಮ ಅನಿಸಿಕೆಗಳನ್ನು ಹೇಳಿದ್ದಕ್ಕೆ. ನಮ್ಮ ಈ ಫ್ಯಾಮಿಲಿ ಫಿಸಿಷಿಯನ್ ಅಸೋಸಿಯೇಷನ್ಗೆ ತುಂಬ ಈ ರಿನಿವಲ್ ಪ್ರಾಬ್ಲಮ್ ಇದೆ ಸರ್, ಅದನ್ನು ನೀವು ದಯವಿಟ್ಟು ಸಾಲ್ವ್ ಮಾಡಬೇಕು ಸರ್. ಯು ವಾಂಟ್ ಟು ಸ್ಪೀಕ್? ಅಲ್ಲೇ ಮಾತಾಡಿ.
ಸಮಸ್ಯೆ ಇದ್ದರೆ ಬನ್ನಿ, ಪರಿಹಾರ ಮಾಡ್ತೀನಿ ಇದ್ದಿದ್ದು ಸಂತೋಷ ಆಯಿತು. ಈಗ ನೀವು ನಮ್ಮೆಲ್ಲರ ಜೊತೆಯಲ್ಲಿದ್ದೀರಿ ಸರ್. ನೀವು ಹೇಳಿದ್ದು ನಿಯಮಗಳನ್ನೆಲ್ಲ ಪಾಲಿಸೋದು ಕರೆಕ್ಟು ಸರ್. ಅದು ಸರಿ ಇಲ್ಲ ಅಂದರೆ ಅದ್ರ ಬಗ್ಗೆ ಸೂಕ್ತ ಕ್ರಮ ತಗೊಳ್ಳೋದು ಸರಿಯೇ. ನಾವು ಅದು ಬೇಡ ಇದು ಬೇಡ ಆದರೂ ನಮಗೆ ಇದು ಮಾಡಿಕೊಡಿ ಅಂತ ಯಾವತ್ತೂ ಕೇಳಲ್ಲ ಸರ್. ನಾವು ನಿಯಮಬದ್ಧವಾಗಿದ್ದು ನಿಮಗೆ ಅಗತ್ಯದ ಏನೇನಿದೆ ಎಲ್ಲ ಪೂರ್ತಿ ಮಾಡಿದ ಮೇಲೆ ಕೂಡ ನಾವು ಮಾಡಲಿಕ್ಕೆ ಒಂದು ಕಷ್ಟ ಆಗ್ತಿದೆ. ಒಂದು ಅಪ್ಲಿಕೇಶನ್ ಫಾರ್ಮ್ಯಾಲಿಟೀಸ್ನ ನಾವೆಲ್ಲ ವೈದ್ಯರು, ವಯಸ್ಸಾಗಿರೋರು, ನಾವು ಟೆಕ್ ಸೇವಿ ಇಲ್ಲ ಸರ್. ಈವನ್ ನಮ್ಮ ಮಕ್ಕಳು ಐ ಟಿ ಪ್ರೊಫೆಷನಲ್ಸ್ ಕೂಡ ಅದನ್ನು ಅಪ್ಲಿಕೇಶನ್ ಸಬ್ಮಿಟ್ ಮಾಡಲಿಕ್ಕೆ ಕಷ್ಟ ಬೀಳ್ತಾ ಇದ್ದಾರೆ. ಸೊ ನನ್ನ ಸಜೆಷನ್, ನಾನು ಈ ಆರ್ಗನೈಸೇಷನ್ ಪಾಸ್ಟ್ ಪ್ರೆಸಿಡೆಂಟ್ ಕೂಡ, ಅದನ್ನೊಂದು ಸಿಂಪ್ಲಿಫೈ ಮಾಡ್ಬೋದು ಅಥವಾ ಒಂದು ಥರ್ಡ್ ಪಾರ್ಟಿ ಮಾಡಿಕೊಡ್ಲಿಕ್ಕೆ ವಿತ್ ಪ್ರಿಸ್ಕ್ರೈಬ್ಡ್ ಫೀಸ್ ಆರ್ ನಿಮ್ಮ ಆಫೀಸಲ್ಲೇ ಒಂದು ಸೆಕ್ಷನು ನಿಮ್ಗೇನು ಅಗತ್ಯ ಇದೆ ಅವೆಲ್ಲ ನಾವು ತರ್ತೀವಿ ಹಾರ್ಡ್ ಕಾಪೀಸು. ಅದನ್ನ ಅಪ್ಲಿಕೇಶನ್ ಸಬ್ಮಿಟ್ ಮಾಡೋದಕ್ಕೆ ನಮ್ಮ ಕೈಯಲ್ಲಿ ಆಗ್ತಾಯಿಲ್ಲ. ಅದು ನಮ್ಮ ಎಲ್ಲ ಮೆಂಬರ್ಸು ಹೇಳ್ತಾ ಇದ್ದಾರೆ ಸರ್, ಇದು ಬಿಯಾಂಡ್ ಅವರ್ ನಾಲೆಡ್ಜ್ ಆ್ಯಂಡ್ ಲಿಮಿಟೇಷನ್. ಅದನ್ನು ಹೆಲ್ಪ್ ಮಾಡಲಿಕ್ಕೊಂದು ಹೆಲ್ಪ್ ಮಾಡಿ, ಒಂದನೇದು. ಎರಡನೇದು ಸರ್, ಕೆಲವರಿಗೆ ಇನ್ಸ್ಪೆಕ್ಷನ್ ಆದಮೇಲೆ ಕೂಡ 1 ವರ್ಷ ಆದ್ರೂ ಅವರಿಗೆ ಇನ್ನೂ KPME ನಂಬರ್ ಬಂದಿಲ್ಲ. ಭಾಳ ಜನ ಕಾತರದಿಂದ ಕಾಯ್ತಾ ಇದ್ದಾರೆ. ಇದೊಂದು ನೀವು ಪರಿಶೀಲನೆ ಮಾಡಬೇಕು. ಮೂರನೇದು, ಈಗ ನಾವು ರೀಸೆಂಟಾಗಿ ಬೋರ್ಡ್ ಬಗ್ಗೆ ಸರ್ಕ್ಯುಲರ್ ಬಂತು. ನಾವು ಅಲೋಪೆಥಿಕ್ ಡಾಕ್ಟರ್ಸ್ಗೆ ಒಂಥರ ಬೋರ್ಡು, ನಾನ್ ಅಲೋಪೆಥಿಕ್ ಡಾಕ್ಟರ್ಸ್ಗಳೇ ಒಂದು ಬೋರ್ಡು. ತುಂಬ ಸಂತೋಷ ಸರ್, ಇದು ಒಳ್ಳೆಯ ಪ್ರಗತಿ. ಇದು ಜನಸಾಮಾನ್ಯರಿಗೆ ಇದು ಅಲೋಪತಿ ಕ್ವಾಲಿಫೈಡಾ ಅಥವಾ ನಾನ್ ಅಲೋಪತಿನ ಅನ್ನೋದು ಒಂದು ಗೊತ್ತಾಗುತ್ತೆ. ಅದನ್ನು ಮಾಡೋದು ತುಂಬ ಸಂತೋಷ ಆಯಿತು. ಅಲ್ಲಿ KPME ನಂಬರ್ ಇರಬೇಕು. ಅದಿಲ್ಲ ಅಂದರೆ ಸೂಕ್ತ ಅಲ್ಲಿ ಸಂಬಂಧಪಟ್ಟ ಅಧಿಕಾರಿಗಳು ಸೂಕ್ತ ಕ್ರಮ ತಗೊಳ್ತಾರೆ ಅನ್ನೋ ಒಂದು ಅದರ ನೋಟಿಸಲ್ಲಿ ಇದೆ. ಈಗ ನಾವು ಅಪ್ಲೈ ಮಾಡಿದ್ದೀವಿ, ನಮ್ಮ ಹತ್ರ ನಂಬರ್ ಇಲ್ಲ, ಇನ್ಸ್ಪೆಕ್ಷನ್ನು ಆಗಿದೆ ಭಾಳ ಜನಕ್ಕೆ. ಅವ್ರು ಬಂದಾಗ ನಾವು ಏನು ಹೇಳೋದು? ಇದು ದಯವಿಟ್ಟು ನೀವು ಒಂದು ಉತ್ತರ ಕೊಟ್ಟರೆ ಸಂತೋಷ
ಸರ್. ಅಂಥವೆಲ್ಲರೂ ಚೆಕ್ ಮಾಡಿ ನನಗೆ ಕೊಟ್ಟರೆ ನಾನು ಅದನ್ನು ಸರಿಪಡಿಸ್ತೀನಿ. ನಂಬರ್ 1. ಇವಾಗ ತಾವು ಹೇಳ್ದಂಗೆ ಸರ್, ಸಾಫ್ಟ್ವೇರ್ದು ಪ್ರಾಬ್ಲಮ್ ಇದೆ. ನಾನು ಇಲ್ಲಿ ನಾನು ಮೊದಲು ಫುಡ್ ಸೇಫ್ಟಿಯಲ್ಲಿ ಕೆಲಸ ಮಾಡ್ತಿದ್ದೆ. ಫುಡ್ ಸೇಫ್ಟಿಯಲ್ಲಿ ಏನು ಯಾವ ಥರ ಇದೆ ಅಂದರೆ, ನೀವೊಂದು ಸತಿ ಅಪ್ಲಿಕೇಶನ್ ಹಾಕಿದ ನಂತರ ಇವಾಗ ಏನು ನಾನು ಡಾಕ್ಯುಮೆಂಟ್ಸ್ ಹೇಳಿದ್ದೆಲ್ಲ 4 ಡಾಕ್ಯುಮೆಂಟ್ಸ್ ಯೂಶ್ವಲಿ ಏನು ಮಾಡ್ತಾರೆ, ಹಾಕಲ್ಲ. ಒಬ್ಬೊಬ್ರು 1 ಮಿಸ್ ಮಾಡ್ತಾರೆ, ಒಬ್ಬೊಬ್ರು 2 ಮಿಸ್ ಮಾಡಿರ್ತಾರೆ, ಅಥವಾ ಅದು ಅಪ್ಲೋಡ್ ಸರಿಯಾಗಿರುತ್ತೆ, ಅದು ಬ್ಲರ್ ಆಗಿರುತ್ತೆ, ಏನೋ ಒಂದು ಆಗಿರುತ್ತೆ. ಈ ಥರ ಈಗ ಯಾವ ಥರ ಇದೆ ಅಂದರೆ, ಈಗ ನೀವು ಒಂದು ಸರಿ ಅಪ್ಲೋಡ್ ಮಾಡಿದ ನೋ ಕರಪ್ಷನ್, ಈಗ ಕರೆಕ್ಷನ್ ಆಗ್ತಾಯಿಲ್ಲ ಅದು. ಸೊ ಅದನ್ನು ಫಸ್ಟು ಎಡಿಟ್ ಆಪ್ಷನ್ ಕೊಡಬೇಕು. ಸೊ ಈಗ ಫಾರ್ ಎಕ್ಸಾಂಪಲ್ ನೀವು ಇವತ್ತು ಕುಂತು ಒಂದು ಅಪ್ಲಿಕೇಶನ್ ಅಪ್ಲೋಡ್ ಮಾಡ್ತೀರಿ, ಒಂದು ಯಾವುದೋ ಈ ಕ್ಲಿನಿಕ್ ಅಂತ, ಮಂಜುಳಾ ಕ್ಲಿನಿಕ್ಕು ಯಾವುದೋ ಕ್ಲಿನಿಕ್ ಮಾಡ್ತೀರಿ. ಅಕಸ್ಮಾತಾಗಿ ನೀವೆಲ್ಲ ಡಾಕ್ಯುಮೆಂಟ್ಸ್ ಕರೆಕ್ಟ್ ಅಪ್ಲೋಡ್ ಮಾಡಿದರೆ ಇನ್ಸ್ಪೆಕ್ಷನ್ ಆಫೀಸರ್ಗೆ ಹೋಗುತ್ತಾ, ಹಿ ವಿಲ್ ವೆರಿಫೈ ಆ್ಯಂಡ್ ಹಿ ವಿಲ್ ಪುಷ್ ಟು ಮೀ ಆ್ಯಸ್ ಎ DHO. ಅಥವಾ ರಿನ್ಯೂವಲ್ ಇದ್ದರೆ ಡೈರೆಕ್ಟ್ ನಿಮ್ಮಿಂದ ನನಗೆ ಬರುತ್ತೆ, ಡೈರೆಕ್ಟ್ DHOಸ್ ಬರುತ್ತೆ. ಇವಾಗ ಅದು ಎಡಿಟ್ ಆಪ್ಷನ್ ಇಲ್ಲ. ಈ ಒಂದು ಎಕ್ಸಾಂಪಲ್ ಹೇಳ್ತೀನಿ. MS ರಾಮಯ್ಯ ಹಾಸ್ಪಿಟಲ್ದವರು, MS ರಾಮಯ್ಯ ಸೂಪರ್ ಸ್ಪೆಷಾಲಿಟಿ ಹಾಸ್ಪಿಟ್ಲ್ ಇದೆ, ಅವರು 2 lakhs ಕೊಟ್ಬಿಟ್ಟು ಅವರು KPME ಲೈಸೆನ್ಸ್ ತಗೊಂಡಿದ್ದಾರೆ. 2 lakhs ನಾನ್ ಟೀಚಿಂಗ್ ಅಂತ ಬಂದ್ಬಿಡ್ತು. ಅದು ನಾನ್ ಟೀಚಿಂಗ್ ಅಂತ ಬಂದ್ಬಿಡ್ತು. ಅವ್ರು ನೋಡಿಲ್ಲ ಅವಾಗ, ನಾನು ಬರೋಕ್ಕಿಂತ ಮೊದಲಾಗಿರೋದು. ನಾನ್ ಟೀಚಿಂಗ್ ಅಂತ ಬಂದ್ಬೇಡ, MC ಇನ್ಸ್ಪೆಕ್ಷನ್ ಬಂದುಬಿಟ್ಟಾರೆ, ನಾನ್ ಟೀಚಿಂಗ್ ಅದು ಇಟ್ ಈಸ್ ನಾಟ್ ವ್ಯಾಲಿಡ್, ದೇ ಕಾಟ್ ದೇರ್. ಅವರು ನೋಡಿಲ್ಲ ಅವಾಗ. ಸಡನ್ಲಿ ದೇ ಕೇಮ್ ಟು ಮೀ. ನಾನು ಹೇಳಿದೆ, ಈ ಥರ ಆಪ್ಷನ್ ನಮ್ಮ ಹತ್ರ ಇಲ್ಲ, ಯು ಹ್ಯಾವ್ ಟು ಗೋ ಫಾರ್ ನ್ಯೂ. ಆವಾಗ ಮತ್ತವರು 2 ಲಕ್ಷ ಕಟ್ಟಿದರು. 2 ಲಕ್ಷ ಕಟ್ಟಿ ಮತ್ತೆ ಇನ್ಸ್ಪೆಕ್ಷನ್ ಮಾಡಿ ಮತ್ತೆ ಮಾಡಬೇಕು. ಸೊ ದಿಸ್ ಈಸ್ ನೌ ಹ್ಯಾಪನಿಂಗ್. ಅದನ್ನು ನಾನು ಬಂದು 1 ತಿಂಗಳೊಳಗೆ ಕಮಿಷನರ್ ಸರ್ಗೆ ಒಂದು ರಿಕ್ವೆಷನ್ ಕೊಟ್ಟು ಎಲ್ಲ ಡೀಟೇಲ್ಸ್ ಹೇಳಿದ್ದೀನಿ. ಎಡಿಟ್ ಆಪ್ಷನ್ ಬಂದರೆ ಏನಾಗುತ್ತೆ ಸರ್, ನೀವು ಅಕಸ್ಮಾತಾಗಿ ಯಾವುದಾದ್ರೂ ಡಾಕ್ಯುಮೆಂಟ್ಸ್ ಮಿಸ್ ಆದರೆ ನಾನು ನಿಮಗೆ ವಾಪಸ್ ಸೆಂಡ್ ಬ್ಯಾಕ್ ಮಾಡ್ತೀನಿ, ಕ್ವೈರೀಸ್ ರೇಸ್ ಮಾಡಿ. ಸೊ ಯು ಆರ್ ನಾಟ್ ಸಬ್ಮಿಟೆಡ್ KMC, ಪ್ಲೀಸ್ ಸಬ್ಮಿಟ್ ಇಟ್ ಅಂತ ನಿಮಗೆ ವಾಪಸ್ ಕಳಿಸ್ತೀನಿ. ನೀವೇನು ಮಾಡ್ತೀರಿ, ಇಮಿಡಿಯೇಟ್ ವಾಪಸ್ ಮಾಡಿ. ಸಾಫ್ಟ್ವೇರ್ ಚೆನ್ನಾಗಿದ್ರೆ ಎಲ್ಲ ವರ್ಕ್ ಆಗುತ್ತೆ ಸರ್. ಸಾಫ್ಟ್ವೇರ್ ಎರರ್ ಇರೋದ್ರಿಂದ ನಿಮ್ಗೆ ಅಪ್ಲೋಡ್ ಮಾಡೋಕ್ಕೆ ತೊಂದರೆ ಆಗ್ತಾಯಿದೆ. ಆಮೇಲೆ ಮಾಡಿಫಿಕೇಷನ್, ಫಾರ್ ಎಕ್ಸಾಂಪಲು ನೀವು ಇಲ್ಲಿ ಕ್ಲಿನಿಕ್ ಇರುತ್ತೆ, ರೆಂಟ್ ಅಗ್ರಿಮೆಂಟೋ ಇನ್ನೊಂದು ತಕರಾರಾಗಿ ಬೇರೆ ಕಡೆ ಶಿಫ್ಟ್ ಮಾಡ್ಕೋಬೇಕಾಗತ್ತೆ. ಆವಾಗ ಆ ಮಾಡಿಫಿಕೇಷನ್ ಆಪ್ಷನ್ ಇಲ್ಲ ಇಲ್ಲಿ. ಇವಾಗ ನೀವು ಮತ್ತೆ ಹೊಸದು ಅಪ್ಲೈ ಮಾಡ್ಬೇಕಲ್ಲಿ. ನಿಮ್ಮದು ಇನ್ನೂ ಈಗ ಒಂದು 5-10 ಸಾವಿರ ಫೀಸ್ ಕಟ್ಬಿಟ್ಟು 5 ವರ್ಷ ತಗೊಂಡಿರ್ತೀರಿ. ವಿತಿನ್ 1 ಇಯರಿಗೆ ಏನೋ ಪ್ರಾಬ್ಲಮ್ ಆಗುತ್ತೆ. 1 ಇಯರಿಗೆ ನೀವು ಅಲ್ಲಿಂದ ಚೇಂಜ್ ಮಾಡಬೇಕು, ಇದು ನಮ್ಗೆ ಇಷ್ಟ ಆಗಿಲ್ಲ ಅಂತ ಹೇಳ್ಕೊಳ್ರಿ. ಇನ್ನೂ 4 ಇಯರ್ಸ್ ಇರುತ್ತೆ ನಿಮ್ಮ ಲೈಸೆನ್ಸು. ನೀವು ಬೇರೆ ಪಕ್ಕದ ಸ್ಟ್ರೀಟಿಗೆ ಹೋಗ್ಬಿಟ್ಟು ಮಾಡಬೇಕಾದ್ರೆ ನೋ ಆಪ್ಷನ್, ಯು ಹ್ಯಾವ್ ಟು ಗೋ ನ್ಯೂ, ಮತ್ತು ಹೊಸ ಸ್ಟಾರ್ಟ್. ಸೊ ಆವಾಗ ಮಾಡಿಫಿಕೇಷನ್ ಆಪ್ಷನ್ ಕೊಡಬೇಕು. ಮಾಡಿಫಿಕೇಷನ್ ಆಪ್ಷನ್ ಕೊಟ್ಟಾಗ ಯು ವಿಲ್ ಕ್ಲೇಮ್ ಫಾರ್ ಚೇಂಜ್ ಆಫ್ ಅಡ್ರೆಸ್. ಚೇಂಜ್ ಆಫ್ ಅಡ್ರೆಸ್ ಕೊಡ್ತೀರಿ. ಚೇಂಜ್ ಆಫ್ ಅಡ್ರೆಸ್ ಕೊಟ್ಟಾಗ ನೀವು ಈ ಕಡೆ ಅಡ್ರೆಸ್ ಕೊಟ್ಬಿಟ್ಟು ಮಾಡಿಫಿಕೇಷನಿಗೆ ಫೀಸನ್ನ ಕಡಿಮೆ ಇಡಬೇಕು. ಕಡಿಮೆ ಇಟ್ಬಿಟ್ಟು ಮಾಡಿಫಿಕೇಷನ್ ಆಪ್ಷನ್ ಕೊಟ್ಟಾಗ ನೀವು ಈ ಪ್ಲೇಸಿಂದ ಈ ಪ್ಲೇಸ್ ಮಾಡಿಫೈ ಮಾಡ್ಬೋದು. ಇದೊಂದು ಆಪ್ಷನ್ ಸರ್. ಇನ್ನೊಂದು ಎಕ್ಸಾಂಪಲ್ಲು ನಮ್ಮ ನಾರಾಯಣ ಹೃದಯಾಲಯದ್ದು ರೀಸೆಂಟಾಗಿ ಆಯಿತು. ಯಜಮಾನ್ರು ಅವ್ರು ತೀರ್ಕೊಂಡು ಹೋದರು. ಯಜಮಾನ್ರು ಈಗ ಅವ್ರ ಮಗನ ಹೆಸರಲ್ಲೇ ಎಲ್ಲ ಲೈಸೆನ್ಸ್ ಅದು. ಅದೇ ನಾರಾಯಣ ನೇತ್ರಾಲಯ ಅವ್ರ ಮಗನ ಹೆಸರಲ್ಲೇ ಎಲ್ಲ ಚೇಂಜಸ್ ಅದು. ಅವ್ರು ಮತ್ತೆಲ್ಲ ಹೊಸವು ತೊಗೊಂಡ್ರು. ದಿಸ್ ಈಸ್ ಪ್ರಾಕ್ಟಿಕಲ್ ಪ್ರಾಬ್ಲಮ್. ಈಗ ಅವ್ರು ಮಾಡಿಫಿಕೇಷನ್ ಆಪ್ಷನ್ ಇದ್ದಾಗ ಅವ್ರ ತಂದೆಯವ್ರ ಡೆತ್ ಸರ್ಟಿಫಿಕೇಟ್ ಹಚ್ಚಿ ಈಗ ನಮ್ಮದೆಲ್ಲ ಮಗ ಇವರೇ ವಾರಸ್ದಾರು ಇವ್ರ ಪರ ಅದಕ್ಕೆಲ್ಲ ಚೇಂಜಸ್ ಮಾಡಿ ಕೊಡ್ರಿ ಅಂದರೆ ವಿ ಕುಡ್ ಹ್ಯಾವ್ ಡನ್ ಮಾಡಿಫಿಕೇಷನ್ ಡೈರೆಕ್ಟ್ಲಿ. ಮತ್ತು ಇನ್ಸ್ಪೆಕ್ಷನ್ ಪ್ರೊಸೆಸ್ಸು, ಆಮೇಲೆ ರೀಇಶ್ಯೂ ಪ್ರೊಸೆಸ್ಸು, ಇಷ್ಟೆಲ್ಲ ಲೆಂಗ್ದಿ ಪ್ರೊಸೆಸ್ ಇರೋದ್ರಿಂದ ನಾನು ಕಮಿಷನರ್ಗೆ ಆಲ್ರೆಡಿ ನಮ್ಮ ಹೈಯರ್ ಅಥಾರಿಟಿ ಅವರು ಇರೋದ್ರಿಂದ ಅವ್ರಿಗೆ ನಾವು ನಾನು ರಿಕ್ವೆಸ್ಟ್ ಕೊಟ್ಟಿದ್ದೀನಿ. ಮಾಡಿಫಿಕೇಷನ್ ಆಪ್ಷನ್ಸು, ಎಡಿಟ್ ಆಪ್ಷನ್ನು, ಆಮೇಲೆ ಈಗ ನಮ್ಮ ವೆಬ್ಸೈಟಲ್ಲಿ ನಿಮ್ದು ಹೇಳಿದ್ರಿ ಈಗ ನಮ್ಮ ಹತ್ರ ನಾವು ಇನ್ಸ್ಪೆಕ್ಷನ್ ಆಗಿ ಭಾಳ ದಿವಸ ಆಯ್ತು ಅಂತ. 90 ಡೇಸ್ ನಮ್ಗೆ 90 ಡೇಸ್ ಟೈಮ್ ಇರುತ್ತೆ. 90 ಡೇಸ್ ಅಂದ ನಂತರ ರೆಡ್ ಪಾಪಪ್ ಬರಬೇಕು. ಬೇರೆ ಎಲ್ಲ ಲೈಸೆನ್ಸಿಂಗ್ ಆಫೀಸಲ್ಲಿ ಪಾಪಪ್ ಬರುತ್ತೆ. ಅದು ಇಲ್ಲಿ ನಮ್ಮಲ್ಲಿ ಬರಲ್ಲ. KPM ಅಲ್ಲಿ ನಿಮ್ಮದು ನಂಬರ್ ತೊಗೊಂಡು ಓಪನ್ ಮಾಡಿದಾಗೆ ನಿಮ್ಮದು ಸ್ಟೇಟಸ್ ಗೊತ್ತಾಗುತ್ತೆ ನನಗೆ. ಈ ಒಂದು ನಿಮ್ಮ ನಂಬರ್ KPMಗೆ ಅಪ್ಲೋಡ್ ಮಾಡಿ 1 ವರ್ಷ ಆಗಿದೆ ಸರ್ ಆಗಿಲ್ಲ ಅಂತ ನೀವು ನನ್ನ ಹತ್ರ ಬಂದಾಗ ನಿಮ್ಮ ನಂಬರ್ ಹಾಕಿದಾಗ ಅಷ್ಟೇ ಓಪನ್ ಆಗುತ್ತೆ. ನನಗೆ ನಿಮ್ಮ 90 ಡೇಸ್ ಆಗಿದ್ದು ಗೊತ್ತೇ ಆಗೋದಲ್ಲ. ನಾನು ನನ್ನ ಲಾಗಿನ್ ಐಡಿಯಿಂದ ಓಪನ್ ಮಾಡಿದಾಗ ಎಷ್ಟು ಮಂದಿ 90 ಅಬೋವ್ ಇದೆ, ಲೆಸ್ ದೆನ್ 90 ಎಷ್ಟು ದಿನ ಐತಿ ಅದು ಏನೂ ಗೊತ್ತಾಗ್ತಾಯಿಲ್ಲ. ನಂಬರ್ 2 ಇವೆಲ್ಲ ಇರೋದ್ರಿಂದ ನಮ್ಗೆ ಡಿಲೇ ಆಗ್ತಾಯಿದೆ. ಸೊ ಇವೆಲ್ಲ ರೆಕ್ಟಿಫೈ ಮಾಡಲಿಕ್ಕೆ ನಾವು ಆಲ್ರೆಡಿ ಕಮಿಷನರ್ ಸರಿಗೆ ಮಾತಾಡಿದ್ದೀವಿ. ರಮೇಶ್ ಸರಿಗೆ ಗೊತ್ತು ಕಮಿಷನರ್ ಎಷ್ಟು ಬ್ಯುಸಿ ಇರ್ತಾರಂತ. ಸೊ ಆಮೇಲೆ ಇನ್ನೊಂದೇನು ಡಿಲೇ ಆಗ್ಲಿಕ್ಕೆ ಕಾರಣ ಅಂದ್ರೆ ಈ ನಮ್ಮ ಪೋಸ್ಟ್ಗಳು ಚೇಂಜ್ ಆಗ್ತಿರ್ತಾವೆ. ಒಬ್ಬರು DHO ಇರ್ತಾರೆ, ಇನ್ನೊಬ್ಬರು DHO ಬರ್ತಾರೆ, ಟ್ರಾನ್ಸ್ಫರು, ಹಿಂಗಾಗಿ ಸ್ವಲ್ಪ ಲೇಟ್ ಆಗಿರ್ಬೋದು ಸರ್. ತಮ್ಮ ಕಡೆಯಿಂದ ಯಾವುದೇ ನನ್ನ ಹತ್ರ ತೊಗೊಂಬಂದರೆ ಡೈರೆಕ್ಟಾಗಿ ಬಂದರೆ ನನ್ನ ಕೈಲಾದಷ್ಟು ನಾನು ಎಲ್ಲರಿಗೂ ಹೆಲ್ಪ್ ಮಾಡ್ತೀನಿ ಅಂತ ಅಂತ ಹೇಳ್ತೀನಿ.
ಥ್ಯಾಂಕ್ ಯು ಸರ್ ಫಾರ್ ಯುವರ್ ಕೈಂಡ್ ವರ್ಡ್ಸ್. ಸರ್ ನಮ್ಮ ಫ್ಯಾಮಿಲಿ ಫಿಸಿಷಿಯನ್ ಅವ್ರಿಗೆ ಯಾರಿಗೆ ಏನೇ ಗ್ರೀವೆನ್ಸಸ್ ಬಂದರೂ ಸ್ವಲ್ಪ ಆದಷ್ಟು ನಿಮ್ಮ ಸಲಹೆ ಮತ್ತು ಅದನ್ನು ಇದು ಮಾಡೋದಕ್ಕೆ ಪ್ರಯತ್ನ.
ವಂದನೆಗಳು ಸರ್. ಥ್ಯಾಂಕ್ ಯು ಸರ್.
Dr. Raju here, a small suggestion to our President, Mr. Harish Kumar. Those who have, so many people we have submitted to KPME, all those names and the details, you can as well collect it from the FPA. In one sheet, it can be submitted to the sir, so that there is no need for us to each and every member to go there and get it done. So when we consolidated members, list has been given to him, he can take his own sweet time and deliver the goods. Thank you.
Okay. So we shall move on to the, so next, it is a pleasure, our Dr. Prajnesh Vacharajani has come from Ahmedabad. He is a young and dynamic secretary of FFPA. So to introduce Dr. Prajnesh, to Preeti to come to the stage.
Respected dignitaries on the stage, and it is my proud privilege to introduce Dr. Prajnesh Vacharajani. Dr. Prajnesh Vacharajani is the Honorary Secretary of the Federation of Family Physicians Association of India. He was the past president of FPA Ahmedabad, and he is a tech specialist. I have to tell you all that he is a dynamic, versatile secretary which the FFPA has had. We have not had such a dynamic secretary from FFPI. Dr. Prajnesh Shah and the president and Dr. Prajnesh Vacharajani have been doing excellent work. Thank you all. It is a proud moment for us, and I have some memories with Dr. B.C. Rao and Dr. H.K. Srinivas. I don't know if sir will remember, but when Dr. Surya and me were EC members, he used to tell me, you ladies should become office bearers. You should take up some posts. And I bow to you, sir. With your blessings, I have been the past president. I know you are aware of it, but I take this opportunity to take your blessings again. Thank you very much, sir.
Okay, thank you, Preeti. And now I request Dr. Prajesh Vacharani to address.
Don't worry, I know I am the last batsman between you and the next scientific session. But what has happened to me in the discussion with the DHO sir and Dr. Subramaniam sir, I was in the position of a Sunil Gavaskar facing the bouncers from the West Indies fast pacer. I couldn't understand anything because you were talking in local language. So good afternoon all, and once again, thank you very much for the team FPA Bangalore, especially Dr. Harish, Dr. Aleem, Dr. Prabhakaran, Dr. Preeti, and all the colleagues for inviting me from all the way from Ahmedabad to be here in this your precious annual conference. Last year, my president, Dr. Pragnesh Shah, was here, and he was very much happy with the hospitality and the warmth that you people have welcomed him. So he definitely suggested this time when I received the invitation from Dr. Harish that we must go and we must meet our colleagues. I'll be very quick on the topics that what are the things that at FFPI, I hope everybody knows what FFPI is. FFPI is, you are all are members of FFPI, that is Federation of Family Physician Association of India, and we have got 31 units across India and around 10,000 strong member base of qualified, IMA qualified family physicians in India. Now, there was a recent major change of guard in FFPI and the new team has taken over. Every 2 years this is happening, and this time the headquarters is also shifted to Ahmedabad, Gujarat now. So, in broad terms, what will we like to work now more on academics, because it's an ever-changing world, and a lot of the learned speaker has told us that science is an ever-changing thing. We must keep ourselves updated. So we family physicians are lifelong learners, and I know in most of the specialty conferences, again, the maximum audience comprises of family physicians. There is a tag on our head that we are a constant learner and we must learn. And that's the hard fact, that's with that. So for upgrading the knowledge, we are planning various certificate programs, various courses, along with collaboration with various leading organizations like IAP, Gastro Society of India. And yesterday we had a very fruitful meeting with our new generation family physician colleagues, AFPI. I acknowledge the presence of Dr. Mohan and all. So looking forward to, we are in a mission mode to collaborate with all the leading organizations across India and took the family physician practice to a next level. See, there are challenges will come, like new regulations, and till then, we family physicians were immune from a lot of regulations, like this fire safety, clinic registration and all. But things are changing. Everything that is coming to the hospitals and now coming to the family physicians, the challenges will increase. But with the help of friends like DHO sir has already told, our associations must take the lead in supporting our members to get through this. And let me tell you, friends, we all are telling that there are no new family physicians are coming, new family doctors are coming. Yes, that is the bare fact. That is the fact. But let me tell you, the next decade is of family physician. But the family physicians who changes themselves with time, who upgrade themselves, who change the way they practice. It is not a typical that 10 by 10 clinics offering, dispensing this lal, pili, lili, dawai and all. That's the time we have to change with time. We have to upgrade with time. And as Sir had lightly mentioned, maintenance of data, good quality data and compliance with the regulations will be need of the hour. So I think the time of group practice or something special or doing something in a different way has already come. And if we want to survive and if we want to do something, we have to change ourselves. As far as FFPI is concerned, please join in the various programs that we organize. Please support us and please be there whenever there is a program. Your suggestions are always welcome. We also run a scheme called Family Security Scheme, where you and your spouse below 65 years can join, and we provide that fraternity benefit to the unfortunate death that is happening among our fraternity, and we support their families, not only in case of death, but only again in case of permanent disability. We also provide financial assistance to the members. So I request more and more members. I think there are very few members from Bangalore as of now. So I request more and more members to join the family security scheme. So future is ours. Challenges are going to be there, but time is to do smart practice and time to have MSI, that is multiple source of income. Do not rely on single source of income that you do. You see a patient and go home and collect decent amount of money. Time has changed. And I think, let me tell you, and we are the only professional who get money to listen to the patient. Most of our patients, including many of the senior citizens, they're only coming to us because we are listening to them patiently, which nobody is doing at their home. So we are essential part of the society. We are very important part of the society. We are not an extinguished species. We are the future. So keep your head up, be future ready, and do something and change the way. And again, in the end, I would like to thank the team FPA Bangalore for inviting me here today. And at this juncture, I would like to invite you all in our national convention that is happening in Vadodara on 4th and 5th of January 2025. Please participate in our national convention in larger numbers. Please join FSA scheme and please keep supporting us in FFPI. Thank you. Thank you very much.
So the inaugural function comes to a close. So I request our President, Dr. Harish Kumar, to address.
Yeah, dear friends, it's a proud privilege for me to share the dais with the distinguished guests and the founder members, Dr. B.C. Rao, Dr. S.K. Srinivasan, and also thank all the delegates for attending today's program. I request them to stay back till the vote of thanks in the evening. And I thank today's chief guest, Dr. Sharan Shivraj Patil, and guest of honor, Dr. B.C. Rao, and Dr. Ravindranath Bedi. And thank once again. I think due to lack of time, I think I'll stop here and wish you all the best.
So I thank everyone on the dais and off the dais and all delegates who are assembled here for this lovely conference. So the dignitaries, already two of them left. They have spared their valuable time in addressing us. And Dr. B.C. Rao and S.K. Srinivasan, it is a very happiest moment to us having come on the stage. So we'll close the inauguration. National anthem to follow.
Punjab, Sindhu, Gujarat, Maratha, Dravida, Utkala, Banga, Vindhya, Himachala, Yamuna, Ganga, Utkala, Jaladi, Taranga, Tava Subha Name Jahe, Tava Subha Asisa Mahe, Jahe Tava Jaya Gata, Jana Mangala Dayaka Jaya He, Bharat Bhagya Vidhata, Jaya He, Jaya He, Jaya He, Jaya 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 He, Jai Hind.
So we will move on to our next academic session. The next academic session will be chaired by Dr. Padma and Dr. Manju Saneja. finish off, doctor. Speakers have come. So when we get prepared for the second session, I request Dr. Mohan Kupendra, who has come, who is the AFI President-elect. So he's going to speak on the WONCA conference, which is going to take place.
Good morning, ladies and gentlemen. It's been an absolute pleasure being part of this event. As you all may be aware, that we all are part of the global organization of family doctors called WONCA. So AFPA is one of the member organization. I think FFPA was earlier a member organization. So it's my pleasure and honor to announce that we are hosting the next South Asia Regional Conference, WONCA South Asia Regional Conference in Bangalore. I am the organizing chairperson for the conference. So we are still doing the groundwork. So this is just an initial flyer. So just to inform you and so that you can block your dates. So we want your support, and Dr. Pragnesh, we have discussed yesterday, and FFPA is going to be our conference partner. So please block your date. It's going to be on 4th, 5th and 6th of April 2025. Thank you so much. Thanks for this opportunity, ma'am. Thanks to Dr. Preeti. Thank you, everyone. Thank you.
So we'll move on to the session 2 conference. We have the cardiologist on board, Dr. A. Gopi, who is the popular cardiologist in Fortis Hospital. Now I request the chairpersons, Dr. Manju Soneja and Padma, to take over and introduce the speaker.
Good afternoon to one and all. It's my proud privilege to introduce Dr. Gopi. We have interacted with him in our previous conferences, which was held under the esteemed President, Dr. Raju, where I was the moderator for the panel session. So I really am honored to introduce Dr. A. Gopi. Dr. Gopi is head of the Department of Cardiology, Fortis Hospital, Bangalore, and he holds a DM degree in Chitra Tirunalar Institute, Trivandrum. And his professional work and teaching experiences are, at present, he is a consultant interventional cardiologist, coordinator and head of the Department of Cardiology, Fortis Hospital, Bangalore, guides the fellow in cardiology training by National Board of Examinations from May 2010. He is life member of various organizations, and he holds the posts of Honorary Joint Secretary, Cardiological Society of India, Bangalore, and Honorary Secretary of Cardiology Society of India, Bangalore, Chapter 2004 and 5. Also, he is the Vice President of Cardiology Society, Honorary Secretary in 2007-8, Vice President 8 and 9, President-elect from 12 to 13, President from 13 to 14, and elect from 14 to 15, and at present, President of Cardiology Society of India, Karnataka Chapter. Over to you, sir.
Thank you, sir. Thank you, ma'am. Thank you for having me here and giving me an opportunity to be again with you once again. So I'm going to talk to you about risk stratification and management of acute coronary syndrome. Now, we know that cardiovascular disease is the major, killer in the world, and so hence it's important for all of us to understand and know how to manage the acute coronary syndromes. Now, the acute coronary syndrome actually involves a spectrum of illnesses varying from, like ST elevation MI, non-ST elevation MI, and unstable angina. The basic pathology in this is that you have a stable plaque which is formed by cholesterol, by fibrous tissue, smooth muscle cells. Now, as long as it remains this way, it will be stable, where the patient might come to us, tell us that when I go for a walk or when I exert myself, I get some discomfort. Then for some reason, the plaque gets disrupted. More common in patients in who the plaque is lipid, a lot of fat content is there, a lot of inflammatory cells are there, they get ruptured and you get a clot formation because the body recognizes that there is a disruption in its intimal layer, and as a protective mechanism, a clot comes and forms over there. Depending upon the size of the clot, we get different types of clinical presentations, which is, if it is a small clot with still a lumen over there, they may present us either with non-ST elevation MI or unstable angina. If there is a complete occlusion of the blood vessel with the clot, they would present to us with an ST elevation MI. So, I'll just quickly go through the risk factors I think we are all aware of. Smoking, hypertension, dyslipidemia, diabetes, obesity, psychosocial stress, heredity, lack of physical activity, adverse diets. These are all the common risk factors for coronary artery disease. Because of that, some inflammation happens in the coronary arteries and you get atherosclerotic plaque formation. And I told you, if the plaque rupture happens, they get into an acute coronary syndrome, and depending upon that, we have different types of presentations. So if you look at acute coronary syndromes, you have two major categories. One is called the ST elevation, and then you have the non-ST elevation as per the ECG. If you have ST elevation, they come to an ST elevation MI. In non-ST elevation, it could be two scenarios where there is a normal cardiac enzymes, which meaning that there is no damage to the cardiac tissue. We call them unstable angina. When you have elevated cardiac enzymes, they come under the category of non-ST elevation MI. So, how do we differentiate these types of acute coronary syndromes? Your ECG is of pivotal in diagnosing the situations where you can distinguish between ST elevation and non-ST elevation. You have an ECG here with a Q wave or an ST elevation over here. Non-ST elevation MI could have either an ST depressions or it could be T wave inversions. After the ECG, the next important thing for the diagnosis would be you need to know the cardiac biomarkers. If the most commonly that is used at present is troponin. In the past, we used to use CPK, then it became only CPKMB. So now, primarily troponin, and CPKMB still does have a role. So if you, in a patient who comes to you with an ST elevation MI, cardiac biomarkers are not very, very important because the diagnosis is already made. But it is important in prognostication to know how big was the MI. So depending upon the quantum of release of these biomarkers, we can tell is it a large MI, large tissues involved. But for NSTEMI, non-ST elevation MI, if you have cardio biomarkers which are increased, they classify as NSTEMI, non-ST elevation MI. If the cardio biomarkers are normal, that the troponin is normal, CPKMB is normal, they are classified as unstable angina. Now, what is the universal definition of an acute myocardial infarction? One is you should have a rise and or fall of biomarkers with at least one of the following. They should have symptoms of ischemia, chest discomfort, breathlessness, sweating, these things. Then new significant ST changes or new left bundle branch block. If you see the ECG here, I'm sorry, I think the curves are not well seen, but anyway, that is the left bundle branch block pattern where you have a broad QRS complex with mainly negative complexes from V1, V2, V3 and a positive complex like an M pattern in V5, V6 is classical of left bundle branch block. The next one would be you can have pathological Q waves. So what do we mean by pathological Q waves? Q waves are thought to be pathological when they are wider than 40 milliseconds, that is wider than one small square, they're deeper than two small squares, or else if they're at least 25% of the R wave height, they're called as pathological Q waves. The next criteria is loss of viable myocardium on imaging or new regional wall motion abnormalities. When we do an echocardiography, we find a certain part of the wall is not moving. That again means that the new regional wall motion abnormalities. Or an angiogram or at autopsy, you find thrombus. You see a right coronary artery over here. This light portion is because of a thrombus. So this is the universal definition of MI. You need to have the biomarker change and at least one of these things, then we can define this patient as having an acute myocardial infarction. Now, 1 of 3 acute MI patients die before reaching the hospital. So that is 1/3 of patients don't even reach the hospital. And I told you it is the #1 killer in the world. So the amount of people who we lose every year is significant. So here the role of primary care physicians in terms of prevention, early recognition is significant to reduce this number. And at present, once you reach the hospital, the care has progressed over the last 2 to 3 decades. And now the ratio of out of hospital to in-hospital death has been increasing due to improvement in in-hospital care. And so we already lose 1/3 of patients with an acute MI before they reach the hospital. And those who survive, 20 to 30% of people develop heart failure in the next 6 months. So almost somebody who has a heart attack, almost 40% of patients, either some of them are no more or many of them are disabled to a significant degree. So this is where prevention takes a big role in trying to prevent this. And we know that many of them are all lifestyle related and a significant number of them can be prevented with proper lifestyle measures. The pathophysiology I already alluded to earlier. You have a plaque which gets ruptured, thrombus forms. If it is complete, it becomes a STEMI. If there is still some antegrade flow, you get small platelet thrombi which go and block the microcirculation. So that is called N-STEMI. So you have minimal microscopic tissue damage, that is N-STEMI, and major damage is STEMI. Now, what do the outcomes of a STEMI depend upon? They depend upon the territory supplied by the affected artery. So you have a proximal coronary artery obstruction, a large part of the myocardium will get affected, and the consequences are worse. A distal occlusion, the consequences are less. Then whether it is totally occluded or not, which will differentiate between STEMI and non-STEMI. Duration. So we all have heard about the golden hour. So the duration exactly means if a patient is re-perfused within the 1 hour, there will hardly be any tissue damage. That is why this golden hour is important. In addition to the fact that many of the people who die following an MI, many of them die within the first hour before they reach the hospital. And as the time goes, more and more tissue gets damaged and a lot of them gets permanently damaged. So you get into a significant LV dysfunction. So duration of coronary occlusion is important. Then collateral vessels. Suppose some patients have got a total occlusion, but it has developed gradually. There have been adequate time for collaterals to supply, so the damage becomes lesser. The demand for oxygen. So after the patient gets an event, what does he do? How are his blood pressures? Is he been being restless, or has he been kept quiet, reducing oxygen demand? All these things will also determine how much of tissue gets damaged. Then some people are lucky to get spontaneous lysis. They have an occlusion. You have seen an ECG outside which shows an ST elevation. By the time they reach the hospital, the ECG is normal. The patient's pain has come down. This is because our body does have lytic mechanisms. Some of them get into, so spontaneous lysis saves the day for them. And then how much of perfusion we are able to re-establish after the MI. These are all the factors that determine what is going to be the outcome for the patients after a STEMI. Clinical presentation. Chest discomfort is the most common. Sometimes it may be pain, it may be a pressure, it may be some squeezing sensation, crushing. Now location, it could be the center towards the neck, center of the left arm, center both arms, neck. Sometimes it could only be at the neck, both the arms or shoulder, or sometimes even the back. So location can be varied. So unless we have a suspicion that it could be this, we might tend to lose. So many times patients may get discharged from the clinic or from the emergency room because we don't suspect it. Especially women, diabetic patients, they have atypical presentation. So unless we are very careful and we have a low threshold to suspect it, we might miss it. So this should never happen. We should try and make sure that we pick up all the patients who come to the medical care. Then they may be accompanied by nausea, vomiting, anxiety, and sometimes a sense of doom. Physical findings, it could be they may be anxious, restless, pale, sweating, coolness of extremities. Pulse and blood pressure may be normal in some patients. It may be abnormal, like tachycardia, hypotension, bradycardia. Depending on the different MIs, it could be there. On examination, we might have a S3 or an S4. If they are in failure, there could be crepitations. Rarely we can have murmurs because of any mechanical complication after an MI. Like I told you, it could be atypical in women and diabetics. So the key to diagnosis is the ECG, where you have an ST elevation MI. Again, if you look at the evolution pattern, in the early phase, hyperacute phase, you have something called hyperacute T waves, where the ST is upsloping and merges with the T wave. In the next phase, you have the STs become prominent, and third phase, you have a pathological Q wave developing ST elevations, and then finally the T wave inversions, and over a long period of time, the STs may become normal in a majority of these patients. Now, what are the diagnostic criteria for STEMI? You have a new or a presumed new ST elevation at the J point in two contiguous leads. It has to be more than 0.1 millivolt, that is more than one small square in leads in all the leads except V2 and V3. In V2, V3, the criteria is slightly different. In men who are more than 40, you need to have more than 0.2 millivolts or 2 squares. In men below 40, it has to be 0.25 millivolts. In women, anything above 0.15 is considered to be significant. Other ECG things like a new left bundle branch block, or sometimes in an isolated posterior wall MI, you may just have a tall R wave with ST depressions in V2 and V3. So recognizing this again is very important so that we make a diagnosis as early as possible. Now we can diagnose the artery that is involved based upon the location of the ST elevation. If you have it anterior wall, generally in V1, V2 or V4 to V2 to V4 will be anterior wall MI, V1 to V6 is an extensive anterior wall MI, 2-3 AVF inferior wall MI. Now important, AVR means left main coronary artery may be involved. So these are the different leads where we should look for, and based on that we can decide which wall or which artery is involved. Now this is different ECGs of showing ST elevation MI for anterior wall. You look at the chest leads, you find a hyperacute anterior wall MI here. Here it is associated with the bundle branch block. Here an evolved MI, and here this pattern is called the tombstone appearance, where you have a gross ST elevation, and this is how the ST elevations can look in an anterior wall MI. Now, in an angio, if you see, this is the left anterior descending artery which is totally occluded in a patient who's come with an anterior wall MI. And when we do a primary angioplasty in these patients and stent it, you can see the whole artery is reappeared. So because a large artery is involved over here, this patient would have come to us with a large acute myocardial infarction, and once we treat it appropriately, we can re-establish the blood supply in these patients. These are examples of inferior wall MI. You would get changes in lead 2, lead 3, and AVF, and also we may get changes in the V3, V4, V5 over here. So these are two examples of inferior wall MI. This is an example of a posterior wall MI where there are no ST elevations, but you have a R wave and ST depressions in V2 and V3. A similar patient who comes, you do an angiogram, you find that the right coronary artery is completely occluded, and after an angioplasty, you can see that the whole artery is getting reperfused. Now, cardiac markers in MI. In STEMI, I told you the biomarkers have a limited role for diagnosis, significant role for prognostication. To differentiate between NSTEMI and unstable angina, a positive markers, we would say it is NSTEMI, negative markers, it is unstable angina. Again, the most commonly used are troponin and CPK-MB. They start elevating about 2 to 4 hours after an MI. They peak at around 24 hours. CPK-MB is something which gets to normal within about 48 to 72 hours, while troponin remains high for almost 8 to 10 days. This can help us. So suppose if a patient is come to us with a chest pain after 4 to 5 days, if you do a troponin, we can make a diagnosis that this patient had an MI, but a CPK-MB may be normal. So delayed presentation, troponin can help us. Now, if the patient has a reinfarction, say after 5 to 6 days, at that point, a troponin will not help you because even the old MI troponin will continue to be high, but a CPK-MB elevation will help us to know that this patient had a reinfarction. So, knowing how these biomarkers are released into the blood, how long they stay, we can differentiate between acute MI, reinfarctions, old myocardial infarctions. So they are important as. Now, management, early arrival in hospital and initiation of therapy improves the survival. So if you see, if the patient who comes to within 1 hour, the mortality rate is about 4 to 5%. If it's after 12 hours, your mortality reaches almost 8 to 10%. So the time is muscle. Earlier treatment is started, it is much better. So what is the first aid measure that we get when we suspect an acute coronary syndrome? Soluble aspirin. So we should give Disprin to them, or of course Ecosprin is most commonly available, but making them swallow Ecosprin does not serve the purpose because it takes a long time for absorption. So we should, if you have only Ecosprin at your disposal, ask them to chew the tablet and then give them some water. The next drug we would like to do is give clopidogrel, 150 milligrams can be given to them, and a high dose statin. So high dose statin would mean atorvastatin 80 milligrams or rosuvastatin 40 milligrams. So these are the emergency measures that we could give in the clinics as an early first aid measure for these patients. Now, once the patient reaches the hospital, what are the goals? One is, if it is for PTCA, if you think that the patient is able to reach a PTCA capable hospital within half an hour, we should transport them to a PTCA capable hospital. We find that survival is better in those situations. And once a patient reaches a PTCA capable hospital, within 90 minutes of the patient reaching the hospital, we should be able to re-establish blood supply. It's called the door to balloon time. Now, what does this achieve? One is, by revascularization early, we reduce death. Second, during an angioplasty, the complete block is removed, so reinfarction rates are reduced. Third is, we reduce intracranial bleeding because we are not using thrombolytic agents. As a result, intracranial bleeding is better. So PTCA scores over medical treatment for all acute ST elevation MIs. If PTCA is not available, you are in a remote place, the nearest hospital is 1.5 to 2 hours away, it doesn't make sense to transport the patient. You should thrombolize the patient, so that otherwise that 2 hours gap is, or 1.5 to 2 hours gap is too long, the muscle starts dying. So we should thrombolize the patient and then shift the patient. So if the patient reaches an hospital which is not PTCA capable, they should be able to thrombolize the patient within half an hour of the patient reaching the hospital. Now, in addition to that, in the emergency room, other than giving these medications, if the oxygen saturation is less than 90%, you should administer oxygen. There are some indicators which say that giving oxygen in patients who have already got a good saturation, because of some vasospasm, we may actually worsen the prognosis. We can control pain with sublingual nitrates or morphine. A caution when we use morphine: for inferior wall MI, morphine may cause hypotension, so we should be very, very careful. And then, of course, today I think in most clinics it may not be available because of the legal hassle of having morphine in your setup and the documentation, sometimes it may not be there. So sublingual nitrate would suffice. Once a patient reaches any hospital with chest pain, the ECG should happen within 10 minutes. We should rapidly identify patients who are eligible for reperfusion, and at the same time identify low-risk patients so that we don't subject them to unnecessary investigations and treatment procedures. Now, we need to remember what are the major complications of STEMI. Electrical complication, that is ventricular arrhythmias. The patients who do not reach the hospital and die on way to hospital, most of them die because of acute ventricular tachycardia or ventricular fibrillation. That is why we say reaching the hospital as early as possible is very, very important. The other dreaded complications are because of pump failure. They can have heart failure, they get acute pulmonary edema, then it could be like acute myocardial regurgitation, ventricular septal rupture or free wall rupture. We know that with ventricular septal rupture or free wall rupture, the mortality rate is almost 90%. Even with treatment, we are able to save only about 50% of patients. So they are all very dreaded complications of a ST elevation MI. Now, in terms of other medical therapy, we have already antiplatelet therapy they need, thrombolytic agents in a patient whom we are planning to thrombolyze, and anticoagulants. Aspirin, I've already mentioned 160 to 325 milligrams loading, wherever you give Disprin or chewable entry-coated tablets. Aspirin itself reduces mortality by 23%. Clopidogrel is an oral thienopyridine which irreversibly inhibits the P2Y12 receptor, and in acute myocardial infarction, it is known to reduce mortality by 7%, and a very important component of the dual antiplatelet therapy post-acute myocardial infarction or post any procedure. Prasugrel, faster onset of action and more consistent antiplatelet action as compared to clopidogrel, but the problem, higher bleeding events, and it is only used for patients who undergo an angioplasty. For medical treatment, it is not used because it has higher bleeding risk. It is contraindicated in patients above 75 years of age, people who are less than 60 kgs in weight, and people who have ever had any history of a cerebrovascular accident or a TIA, it is contraindicated. So today, ticagrelor is the next antiplatelet agent which has become very popular now. It is an oral, reversible P2Y12 antagonist. It is direct acting, not a prodrug, and it is reversibly bound. So after 4 to 5 days, the platelets become active again. So as a result of which bleeding complications are much lesser. You have a plateau STEMI trial where they compared clopidogrel versus ticagrelor, and they found that effectiveness of ticagrelor was better than a clopidogrel. The good thing is it can be used in patients whom we are managing medically, and STEMI on conservative treatment, post-angioplasty, all of them, ticagrelor is a very useful drug. The one side effect with it is breathing. The patient give history of breathlessness, though the oxygen levels are all okay. So in about 20% of patients we get this breathing difficulty. We need to be aware of that. Dual antiplatelet, all patients with ACS, we put them on dual antiplatelet agents. Aspirin is a component in all of them. The others, it could be clopidogrel, ticagrelor, or prasugrel, depending upon the clinical situation. Reperfusion therapy, the goal of reperfusion is to restore flow, salvage myocardium, and improve outcomes. We have options of fibrinolysis, primary PTCA, or something called pharmacoinvasive. So suppose you are in a peripheral center, you have facility for thrombolysis, but the angioplasty facility is much further away. We can actually thrombolyze the patient. Nowadays we have thrombolytic agents I'll talk to you about, which are very effective with much lesser side effects. We can thrombolyze them and then start the transfer. They will reach the hospital within 3 to 4 hours, and they can do an angioplasty and complete what you have started. So thrombolytic therapy, if PCI is not available and patients are not giving consent for PCI, we can give thrombolytic therapy. Most effective within the first 12 hours of an ST elevation MI. After 12 hours, if there is symptoms of ongoing ischemia, we can thrombolyze the patients, or if the patient is having a large area at risk or the patient's heart failure, we can still thrombolyze even if the time is elapsed. What agents do we use? I think most commonly streptokinase is what was being used commonly, but now in all the larger hospitals, most of us use tissue plasminogen activators. I'm sure in many of the smaller hospitals they use tissue plasminogen activators because safer, allergic responses are much lesser, it is more effective. You have alteplase, retiplase, tenecteplase. Alteplase is used as an infusion, while retiplase and tenecteplase are used as bolus injections, so very convenient for it to be used. The other drugs that are used are anticoagulants. You have unfractionated heparin, low molecular weight heparin, depending upon the, your familiarity, depending upon what procedure we can use this for anticoagulations. Now, primary percutaneous coronary intervention is the most important treatment for an ST elevation MI. There are a number of studies which have very clearly shown that outcomes are far better with an angioplasty as compared to thrombolytic agent. The reason being, we completely remove the block, so reduces the chance of reinfarction. We can do it very quickly within an hour of the patient reaching the hospital, and we don't use thrombolytics, so bleeding are much lesser. So in this scenario, the primary angioplasty has far outperformed thrombolytic agents. But the problem, availability, it may not be available in all centers. So still, from a community point of view, thrombolysis still holds a significant role. Then there are some other terms we use called rescue PCI. If a thrombolysis is not effective within 1 to 2 hours, then we do a rescue PCI. Sometimes we combine both. Like I told you, you need to transport the patient to a PCI-enabled hospital, so you thrombolyze and start. That is called pharmaco-invasive treatment. So these are the different types of treatment that we do for a STEMI. Now, coming to the topic of NSTEMI and unstable angina, symptoms are almost similar. The main difference between these two is that they don't have ST elevation on ECG. It is either ST depression or T wave inversions. And NSTEMI has elevated cardiomyomarkers, while unstable angina does not have elevated biomarkers. Now, risk stratification. In these conditions, risk of death varies from 1 to 10% at 30 days. So it is important to identify high-risk ACS. We have different types of score called as TIMI score, GRACE score, looking at different patients' parameters, and we can have a scoring system to know high risk, low risk, intermediate risk. So let us look from a history point of view. Patient having rest angina in the last 48 hours comes under high risk, and if the pain is more than 20 minutes of rest pain, high risk. Intermediate risk could be prior MI, peripheral vascular disease, cardiovascular disease, prior bypass, aspirin use. Rest angina more than 20 minutes but relieved with rest or with NTG. Nocturnal angina, new onset angina come under intermediate risk. Low risk could be increase, like a patient who's having stable angina now suddenly says that his frequency has increased. Like I used to walk 5 rounds in the park. For the last 1 week, when I walk 3 rounds, I get chest pain. So this is increased frequency. Then angina provided at a lower threshold. I used to walk for 20 minutes, I used to get pain. Now at 10 minutes, I get pain. Or new onset angina with onset of 2 weeks to 2 months prior to presentation. They come under low risk. Now, from finding point of view, patients with pulmonary edema, new worsening murmurs, new S3, crepitations, hypotension, bradycardia, tachycardia, age more than 75 years. These are all come under high-risk patients, while intermediate risk could be age more than 70 years, having T-wave changes, and cardiac enzymes are not as increased. They would come intermediate risk. Patients with normal ECG and normal biomarkers would come under normal risk. Now, ECG, in addition to diagnosis, it's also a major stratification tool. We know that patients with STT changes do worse than compared to only T-wave changes. And also, patients with ST elevation have a long-term mortality compared to ST depressions. Now, these are the different scoring systems that are there, based on which we can say higher scores, they tend to do worse. So if we have an idea about the score, based on that we can decide what sort of strategy we should follow for patients with NSTEMI or unstable angina. Medications, again the same things, dual antiplatelets, anticoagulants, anti-anginals, high-dose statins. Now, when they come with NSTEMI, if they come into the high-risk category, it is recommended to do either an invasive approach for these patients. Who do not come into high-risk, conservative strategy, we can manage them with medications, and then later on, depending upon inducible ischemia testing, we can decide whether these patients need to undergo angiogram or further treatment as such. So, in whom do we advise an early angiogram at angioplasty? Those who have recurrent angina, shock, electrical instability, immediately we need to do something. Early invasive in people who have dynamic changes with a high GRACE score, delayed in patients who are much more stable. So based on that, we can decide who should go for an immediate invasive management. Long-term management, hospital after discharge, in addition to medications, lifestyle is important in terms of smoking cessation, appropriate diet, controlling hyperglycemia, weight management, drugs, beta blockers and statins, ACE inhibitors, antiplatelets. So these are all the long-term management measures. So now the take-home message is, STEMI management involves early diagnosis and management. Speed of diagnosis is extremely important as death occurs out of hospital and can be reduced by early medical contact. Early diagnosis is also important to salvage myocardium. There's the term called as time is muscle. Invasive monitoring with ACLS and defibrillation facilitates are mandatory. Loading therapy with antiplatelets, atorvastatin, followed by immediate reperfusion by primary PCI, thrombolytics, pharmacoinvasive treatment is a cornerstone of treatment, and post-reperfusion care is very important. ACS, other than STEMI, can have varied presentations and diagnosis. Cardiac enzyme positive cases are classified as NSTEMI. Risk stratification is based on scoring systems is key to triaging these patients. High-risk patients need aggressive treatment, initiate medical treatment, followed by catheterization, and most cases are best treated by medical passivation first in the low-risk patients. Thank you for your attention.
Thank you, sir, for that elaborate and extensive and enriching talk. Any questions? Due to paucity of time, only one question permitted.
Of course, I have not really touched upon the imaging as such because part of this thing. But what happens is that with any sort of imaging, either intravascular ultrasound or what we call as OCT, we put these probes into the coronary artery. We can know what is the type of plaque, how much of fat is there, how much of calcium is there. Based on that, we can decide what is the appropriate strategy. Do we need to use high pressure balloon? Do we need to use specific devices like cutting balloon, rotablator, IVL, those sort of things? We can know the exact size of the stent that we need to use. And after we have stented, we can know have we done a perfect job or not. So if the long-term outcomes of imaging directed or guided angioplasty is much better than only angiography guided angioplasty. I think it almost makes about 5 to 10% difference in terms of long-term outcomes. But in very straightforward, simple cases, the role may not be there. But so why don't we use it for all patients? Because it adds on to the cost. That is a significant cost there. But in complex cases, it makes a significant difference. So today in our practice, I think about 20 to 30% of patients we use intravascular imaging. As compared to, let us say in Japan, almost 95 to 98% of cases are used in imaging. But most of the world, it is around 10 to 20% for various reasons that I have mentioned. So it is an excellent tool, needs to be used where appropriate as such, and has a better outcome if you use it.
So one small basic question. When do you use aspirin 75 and aspirin 150?
So actually, madam, at present, in an acute loading dose, it is 350 as such. But for maintenance doses, at present, in the cardiology scenario, we feel 75 milligrams loading is sufficient. And nowadays, the other effects of aspirin is coming, like bleeding risk and everything. So we are trying to get the minimum because the patient is going to be on aspirin on some other bleed. So we don't want them to come with bleeding so that kind of thing. At present, maintenance dose, 75 milligrams is sufficient. But though the neurology community still, if there's a CVA, they still stick to 150 milligrams. As cardiologists, purely cardiac, I think 75 milligrams is sufficient as maintenance dose.
Thank you, sir.
Thank you very much.
Our next speaker is Dr. Rajshekhar Mais. He's a senior colorectal surgeon and chairman of Chirag Global Hospital, MBBS and MS from General Surgery from KMC Kurnool, Andhra Pradesh, worked as district surgeon in Iran, returned to India and started Chirag Institute of Proctology in JB Nagar. He's participated in Berlin on lasers and proctology, the first exclusive technology-driven proctology unit in Karnataka since 1998. He is the first to start in Karnataka. Over to you, sir.
My dear family members, I always feel at home whenever I attend Family Physicians Association meeting. At the same time, I also feel bad that we can't become members. I have two ideas for this. One is, can we become associate members and attend only the conferences without any voting rights and that sort of things? Because I feel every specialist or super specialist, first he must be a general doctor first. A surgeon or a neurosurgeon, if he refers a small cold or a viral fever a case of his son or his daughter to a specialist, he is not a good doctor. Because no disease or no system in the body act exclusively. They always have some import, not only on the body, on the mind. So every specialist, we should know complete body, mind, and our specialty. So we also need a forum where we can learn so many things. Each time I come to Family Physicians Association to give a talk, I learn more than what I deliver. So this is such a wonderful association. And one more thing what I have noticed is, for the past, I think, 5-6 years I'm attending, I'm presenting myself here. The people who are there, they are all still young, active, and very actively participating. Probably they are forced to become young because the next generation is not taking over. You see Dr. Subramanian, now 70-year-old person looking like a 30-year-old guy. He is carrying the burden. All of you are carrying the burden of the family physicians, which the society is in dire needs. I have come here not only, I want family physicians to survive and flourish. It's not that they will refer to us. Tomorrow when I become a patient, I want to go to a family physician first rather than going to directly to, because none of us know by symptoms. It's a very common thing. Some headache, patient go directly to a neurosurgeon in a corporate hospital. Hundreds of investigations done, something found out in the brain, some cyst, something, and about to get operated. These are all I'm telling from my practice. Getting operated, somehow patient his pain is gone. So he came back to me saying that, should I undergo this surgery? Then I was wondering when I simply asked him few questions, I knew it is a simple sinus headache. He had cold, cough, a little mild fever and headache. And CT scan, MRI scan showed something else. So what I learned, Dr. Vidyadhara's this one speech, wherever I go, he's a wonderful human being and a great surgeon. So whatever I wanted to tell, he had already told in a very nice manner. So what I have seen, see, there are at least more than 100 specialties in our medicine now. Minimum 100. You can count on that. And even from each speciality or subspecialty, one topic you take, you will not be able to cover even in once a week in a year. So as family physicians, can we expect that you must know all the details of biochemical this one and then our MRI findings, all that in detail? Why should you know about all those things? And if all of us will come and bombard you with so many details, what is use of it? At the end of the day, when you are going back, you can't even remember one point, take-home message, whatever, you won't remember. So what should be the approach of a family physician? Where are they needed? See, in any dire emergencies, nobody accepts that a family physician has treated and delayed and something catastrophic happens. We know one of the major this one, what happened. So if they have gone to a family physician, by the time he takes ECG and he refers to a place, it is already late. So we have to educate our patients that in any case of chest pain, that sort of unconsciousness, directly take them to the nearest corporate hospital, whichever hospital is nearest. When somebody calls me in the morning and says, I am having chest pain, I am coming to your hospital to show, I tell, no, I can't manage it. Directly go to Jaydeva. For us, Jaydeva is nearest. So one is how to manage the emergencies to avoid emergencies. Avoid emergencies. In your clinic, never try to start treatment because people will not accept it. I had problems. Because owning a nursing home and having a hospital, we have to treat every patient. So I went to some ECG classes and learned how to read, how to differentiate between normal and abnormal ECG. That's enough. We do not know the complete of what is the ST elevation, all that. You see, it is abnormal. Take a picture, send it to cardiologist. Make him ready, call an ambulance, send off, finish. So that is what you have to do to be on the safer side. Because gone are the days where symptomatic treatment or tentative diagnosis are accepted. No more they are accepted. People will question us. Gone are the days where our knowledge was confined only to specialists or a group of people. In any field, whether it is legal, medical, engineering, anywhere, the knowledge is no more in the confines of the specialists. Everybody knows what it is. So it is not possible for us to update all the knowledge. It is impossible. Let us be very, very frank. In our own department, what has happened last month, I may not be knowing. So it is not wrong that, or you should not feel bad that I don't know. It doesn't matter. When a patient can search on Google and come and teach you, can't we do that? So when somebody asks, this is some sort of diagnosis, they come and tell, or some sort of treatment, I'll tell them, okay, wait, I'll check in Google, give them a better explanation. We can understand. So we must be open for that. So these are the simple methods of managing emergencies first. Second is, you must know how to connect to the patient. So my talk starts from there. I have divided it into 3 parts. One is tomorrow's today, bottoms and beyond. What is the meaning of it is, we must all think whatever has been taught or whatever we have learned is nothing. Because in no time, AI and robots and all are going to take over, both our knowledge as well as skills. So we saw that just to put screws by a surgeon is required. Within a minute, if you want to put, everything is arranged. Say some cataract now. So they need, you don't require ophthalmologist. Everything is done by computers. So many procedures like that. So that is going to be taken over by the robots, and engineers will start working on it. So we have to have a good connect with the patient, and we must have empathy, and that should be trained. All of you must take the onerous responsibility of training people. I have not seen a single person who have finished medicine and who come for a job offer or something like that. I want to work for 6 months. I am appearing for NEET. When I ask them, why don't you become a general practitioner? Why don't you start a family physician? This one, it is really important. It is going to be the future. They don't understand. So we have to give importance for family physicians. They should be respected. They should be respected because a specialist can treat only a small part of a body. However great he is, however best he is, he can treat only a small part of the body. But a physician is required for the whole. So in fact, you have to call yourself as a whole body mind physicians. Body and mind also you have to treat. Whole body mind physicians. I want you to put that modern scientific whole body mind physicians. You put on your clinics that we belong to that class. Otherwise, we are all being taken over by some other systems of medicine, as we know. That's what. So now we have to make the people know what is the difference between other systems. And I have nothing against it. I am not against any other systems. But people have got a right to know that what they are getting. So that is what. So now I am going to start my why tomorrow's today. In the modern day, if you want to survive, if you want to simply survive, you must be always ahead of what is going to happen tomorrow. If you know only today's, you already belong to yesterday. So you must always think tomorrow what is going to happen, whether it is in our personal life, family life, or in social life, or in our professional life. We must all strive to be ahead of our times, to be relevant. If it is the repetitive work, robots and AI will take over in no time. Now, coming to the theme, the pillars of healthcare. I think I want to change this a little. I am sorry. The role of pillars in any building. Do you see any pillars here? Previously, this big hall, 10 pillars used to be there. Now, people don't want to see pillars. They are all hidden. There was a time when we used to go to some temples to see the pillars. Hazar Ramalaya, 1,000-pillar temple, 100-pillar this one. Very well decorated, incarnated pillars. Pillars had value that time. Now let us not call pillars carrying the burden. No. We should be the walls and doors. We'll confine, people will come into us, we'll confine them, give them knowledge, and wherever it is required to refer, we'll open the doors for the higher level of treatment. Let us call ourselves as the doors and windows and walls of the medical system. Now, how to go about? Physicians have to redefine their roles. You should be always doing. If I was stuck up as a general surgeon and had learnt only laparoscopy like many of our colleagues, I would have retired by this time. Because there are thousands of youngsters will be coming, our skill level will be going down, everybody doing the same thing, and if they quote 50,000, I have to quote 30,000, and just for survival. So we have to always redefine our roles. Positioning, the family physicians should position themselves on equal footing with specialists. No feeling of less, we are less, no. We are as good or rather greater than others. You are treating all the diseases, you are omnipotent physicians. The infrastructure, the problem is the infrastructure and facilities available at the clinic should be modern. Please, whoever has not done it, please do it. Because the world has changed. They have no more accept a bench for sitting, waiting, or a fan. They want AC rooms, they want good sofas, all those things. We have to do that, posh, as per current trends. Drinking water, good seating, a good receptionist, all those things are, because it gives us a wow feeling. Would like to go to a restaurant where you want to stand and eat? We don't. So, portray proudly as a modern medical practitioners, as I already told you, in contrast to other systems of medicine. So we are modern and we are professional medical practitioners. Then, latest technologies like clinic management software, online consultations in emergencies should be adopted. These are all very important. We will be struggling so much And if you get a call, simply they'll be calling. Charge for that. Tell the online consultation, this is the format. You pay. You know, anybody can pay. They can't tell, I can't come and pay. Pay it, immediately we'll have a consultation, guide them. Medicines can be dispensed at the clinic for the patient's convenience. That will also an additional income also. Arrangements for blood samples to be collected. Many of you are doing all that. Make it whatever you are already doing, don't be happy with that. There is always a room for improvement. You see in a restaurant what they are providing, in another hospital what they are providing. In any organization, when you go, hey, why can't I do this? Then tie-up with home care services can be made. Similarly, charge well. That is very, very important. If you charge less, they feel that we are less. Really, I am telling, don't be worried at all. You first initially will think that they won't come, they'll all go to somebody else. No. Charge well. Minimum, a novice who has started his family physician's practice must charge 500. This is my thinking. Minimum is 500. A plumber, electrician, when he comes for 2 minutes job, he will give a bill of 2,000 rupees. And we do all those things and let the patient's number come down. There is nothing wrong. Why should we treat 100 patients? It is wrong to treat 100 patients per day. If somebody says that doctor has got roaring practice, every day he sees 100 patients, he is doing injustice. We are doing injustice. So we have to spend time with them, talk to them, understand them, make a proper diagnosis, then treat. Then you will have respect for that. Simply write something, oh, next case, all injection kudu, it kudu, that is gone. There are certain, this one, let the other systems do that thing. We leave it to them. Let them also survive. We will position ourselves at a different level, where comfortably you sit with the patient, talk to them, upgrading in all the subjects to as what is going in all the departments. Latest available treatments in every hospital and facility. That's it, not more than that. How do they do that? Where do they prick? And what is the nanometers? How many nanometers of energy? Why are we bothered about it? As a family physician, don't bother about it. You know that now this is treated differently in the different hospital. This is the best hospital for this thing. Then do not hesitate to search in Google for any latest information or protocols. You need not ask any questions. Questions asked should be removed from this. You will get answers for any question in the world if you search in Google. And what the specialist or anybody tells may not be really the latest or the correct. I will express my opinion. That may not be the last word. So search on Google. Even when anything, a patient calls and tells, so I am having this sort of symptom, you search, you will get some different diagnosis also, you will know, by the time patient comes. Get the feedback after the treatment. You have treated and get the feedback. Specialists should also promote the family physicians. I insist. In fact, I have written a book, Health or Health, Choice is Yours. In that I have written that there are different levels of hospitals, clinics, all that, each meant for different purposes. Simply don't go up directly to a particular hospital. For an emergency, you go to a clinic. For a simple loose motion, you go to a corporate hospital. So how to select a doctor, how to select a clinic, everything I've written in that. Specialists should then, they treat only specific disease and send them back to the patient, wherever it is possible. In surgical, this one, we may not be able to send you back much. Whereas in medical cases, whenever you treat, once the main part of diabetes, first you have sent a complicated diabetic case, you have sent a diabetologist. It need not be going to diabetologist permanently. Once a proper diagnosis made, what treatment is given, how to make small changes, advise them on diet, all those things is your responsibility. And you should be known for making a good clinical diagnosis. Very important. Pain abdomen, refer to surgeon. Throat pain, refer to ENT. That is it gives a very bad impression. We may be wrong in our diagnosis. There is nothing wrong. But not making a diagnosis, it's wrong. And once you make a diagnosis, you explain all your findings. See, your tonsil is like this, it should be like this, is enlarged and there is some issue here. So that is why I'm thinking in terms of a tonsillitis, and when I'm pressing here, I have some pain. And all those things you explain, patient will get, oh, he knows something. Simply write up some query pharyngitis. So you must spend time. You must have patience, spend time, charge well. They'll pay. People are ready to pay. Now only paisa vasool means whether I'm getting back for what I have spent. That's what patients want. It's not that the cheaper you give, the better it is. Then very poor patients are who demand that they can pay less, charge them less, no problem. Enter your clinical findings, diagnosis in all your prescriptions. The trend of people going directly to specialists and the super specialists is directly is dangerous. Patients not only end up with unnecessary investigations, but uncalled for treatment, unnecessary surgeries. Patients won't get wholesome treatment when they directly go to a specialist. So now, the second part of my talk is my medical journey. So it is exactly 50 years back I joined a medical college, just 50 years back. Now, from 84 to 98, I was practicing as a general surgeon. Then in 98, I started the Chirag Institute of Proctology, which was the need of the hour. Because that was the most neglected area. Proctology, the word proctology didn't exist in the minds of the physicians and surgeons. Even surgeons were not aware that what is proctology. So I started it as a specialty. And first 5 years single-handedly persuaded patients not to go to quacks. My issue was to wean the patients away from quacks, telling that no, we have got better treatment, we'll assure you, we'll take no complications, no problem, no. All that, and for the GPs also. One senior doctor went to a quack and was getting treated, then he came to me. So I came to know there were some issues with our surgeons' attitude and our approach. So then adopting new technologies to make surgeries in proctology as daycare procedures, under local anesthesia, and faster recovery, all that made an impact on the patients. Next 5 years started participating in colorectal conferences, and then learning and giving back. Developed new techniques along with adopting the new latest technologies. Almost every technology that is available in the world are available with us. All the new technologies in Karnataka at least are introduced by me for the first time. Some of them at all India level. Very recently we introduced a machine called CEREG, circumferential endoanal endorectal echo-guided procedures. That is ultrasound. In the OT will use. I'll show all that. So that is the first machine to be installed in India in our center. So a few young surgeons later, next decade, a few young surgeons joined me and encouraged me to start training and teaching. So we have trained more than 200 general surgeons, including some of the professors of surgery and all. They have attended our training programs. Then later, general surgeons started referring at least complex and complicated cases to me. Till that, no surgeon was willing to. Piles ಏನಿದೆ ಅದಕ್ಕೆ ಯಾರಿಗೆ specialist ಕಲಿಸ್ಬೇಕಾ ನಮ್ಗೆ ಬರಲ್ವಾ fistula ಏನಿದೆ. So then once they came to know our results are far superior, then they started. It's not that I am great. I don't claim that. In any particular field, if you are working for 20, 30 years, you become expert in that. That's it. Later, a team was formed consisting of different systems of medicine, complementing our efforts. Then, now we have a surgical gastroenterologist, a general surgeon, an anesthesiologist working full-time with me, and oncosurgeons, physicians, dermatologists, gynecologists, urologists, working as an on-call consultants. As a wholesome this one, any bottom issue, we'll take care of it. With this now we have mastered the art of treating hemorrhoids, fistulas, simple, complex, and recurrent cases. And we are known to treat recurrent fistulas. So actually 70% of the cases what we do, surgeries what we do, are already done somewhere else. And they are coming back for repairs or some other issues. So complex fistulas should always be tackled very carefully and very diligently. It is not that technology alone will take care of the things, as our Dr. Vidyadhara was telling. When to use the technology. that intelligent usage of technology is important. Just because you give a robot or a laser machine for somebody, it causes more damage, more dangerous things. Recently, I heard one doctor telling in Delhi, they were doing some robotic surgery for a gallbladder, and there was a damage to the vessel. By the time they decoupled the machine, because in robotic this one, it is all fixed. You can't change the position of the patient. By the time they decoupled and opened, patient died. What I'm telling is that dangerous it is. Technology itself will not solve the problems. So now, with this now we have mastered, and then now, so what we do differently? What do we differently? We have developed different protocols, definitive protocols for history taking, elaborate history taking. No, nothing will be missed. Similarly in clinical examination, we assess sphincter assessment. We have developed all this in-house, how to assess sphincters. There is one more sign, clinical sign, to detect the intersphincteric infection before it becomes a fistula, how to clinically make a diagnosis and confirm with MRI. And then a video rectoscopy. In-house, we have developed this gadget. It is such a simple, like a pen-like thing. We just put it into the proctoscope, capture this one through your mobile phone. I have engineered and developed it. I got the cameras imported from China, and in-house we have made it, and we have distributed to many surgeons. So this, I call it as Antarnetra, because you can see, I've given to some of the members also here last time. So it can be kept into your ear, nose, wherever you can put, and then you can capture it and enlarge and see, you can explain to the patient. So this is also developed in-house. So these are all some of the images which you, if with naked eye proctoscopy, simply put a proctoscope, and with torch, if you see, you can't find these details. And we have a different approach to preoperative protocols. We avoid this shaving, enema, all those things are removed. Every painful anal condition, we do MR fistulogram to exclude any deep-seated abscesses. And one surgeon is responsible for one patient, so that he will make a diagnosis, he will do surgery, he will take care of the post-operative care, so that nothing will be missed. So from history to post-operative follow-up, one single surgeon will be responsible for that. OT table is custom made. Even during surgeries, we are using a different camera to capture the images. And under video guidance, we are doing the procedures, include positioning of the patient, anesthesia, all those. Recently, we have got one more machine called Ubersonic, that is a harmonic scalpel to excise external hemorrhoids and are very deep-seated rectal tumors and all that. So surgical techniques, intelligent usage of cutting-edge technologies like lasers. We have lasers. We have Doppler-guided hemorrhoidal arterial ligation, we have infrared coagulator, as I told you that CEREG, we have RF, we have Ubersonic, and we individualize the treatment. And the procedure you can see is a perineal approach to rectal prolapse. We don't open the abdomen at all for rectal prolapse. Everything done from below, morning patient comes, next day morning patient is discharged. And definitive post-operative protocols. See, any surgery needs to be first a proper diagnosis, and then a proper planning of what sort of procedure, who will do, when it is to be done. Then during the procedure, what are the things to be done, what technology is to be used. Post-operatively, again, following it. All that forms a part of surgery. It's not simply somebody did operation, it's over. So, and what are the things? We have to prevent incontinence and we have to prevent recurrences. These are the two choices. If you overdo, you end up with incontinence. If you don't do properly, then you will end up with recurrence, especially in fistulas. And reduce post-operative complications, post-operative severe bleeding, pain, all those things. And we have to ensure faster healing. A small disease, as simple a disease as a hemorrhoid, if it takes 1 month for the patient to go back to his work, what is that we are doing? Well, on one side we say heart is transplanted, spine, scoliosis, everything we are fixing, brain tumors we are removing. On the other side, for piles, hemorrhoidectomy done, and patient has to take rest for 1 month. He can't move, he can't sit, urine blocked, all those things. So we have to always progress. So introduced for the first time in India that, as I told you, circumferential endoanal real-time echo-guided surgeries. So this is how it is being done. Here we are introducing, and then there on the screen you can see the tracts and all. We inject a hydrogen peroxide, completely track the tracts and completely clear that under the guidance. So this is how it is seen, circumferential. You can see all the layers of the anal canal. This is infrared coagulation, very simple procedure just to seal the vessels, second degree hemorrhoids. It takes 3 minutes to finish the procedure. Do and send. Then this is harmonic scalpel, as I told you, ubersonic. This is to excise the tissues without any heat, without any damage to the adjacent tissues. These are all lasers which are being used, different varieties of lasers we have. So laser ablation of pilonidal sinus, excellent results with for pilonidal sinus. Lasers are the best indication is for pilonidal sinus. No wounds, nothing. We'll do in the morning under local anesthesia, send them home. They come for 2-3 times for inspection of the wound, finish. Doppler guided procedures. We use a Doppler to locate the vessel and close the supply. RF coagulation. Laser in the wrong hands and the wrong way causes more problems than the disease itself. Right hand and the right way, anal stenosis and all that sort of thing can be prevented. This is a case of anal stenosis caused by laser surgery somewhere else, and we are doing now. The same laser we are using to correct the. So rectal prolapse approach. These are all complex fistulas were known for that. So now these pile fissure, fistula, rectal prolapse, all that are being done. For the past 20 years, if I am doing the same thing, what is that? So now we have established a new hospital, one of the largest in the world, exclusively meant for the anorectal diseases, with the aim of developing newer surgeries, newer techniques, newer this one, not only for these diseases. There are so many other symptoms. Patients come with, there's something called ODS. So ODS is obstructive defecatory syndrome, chronic constipation, Leber-Trans syndrome, pelvic descent, vague pelvic pain, so many which we don't know how to manage. So now we are developing a research into it and find out new treatment options. So to be successful, right time, right place and right procedures are the keys. We have created the right place and right procedures. Referring at the right time is in your hands. Let us together give the best to our patients. Thank you very much.
Thank you, sir, for this presentation where we came to know what are the needs of this pelvic surgeries and other things. I think time is over and you can ask questions. You can ask questions to sir as and when needed during lunch break.
Thank you very much.
Call upon Dr. Padma to honor Dr. Rajshekhar.
So we'll move on to the next session due to. Oh, I call upon Manju Soneja and Padma. For chairing the session and doing. Okay. Okay. So we'll go to the next. This is a guest lecture from Neura, that is on preventive health screening. The guest lecture is by our own known member, founder member, past president, none other than Dr. S. Subramaniam, who is all well known to us. So he will be speaking on preventive health screening. Over to Dr. Subramaniam. I call upon the chairpersons, Dr. M. Jaiprakash and Dr. Rajashri MB, to take their respective chairs and introduce the speaker.
Thank you. This is a high time before the lunch. We are late. It is my pleasure to introduce S. Subramania. He is our senior member and a past president of FPA, and he is a very active and a knowledgeable person, particularly in the field of tuberculosis and diabetes. He is a masterminded and is upgraded all the recent developments in the treatments of tuberculosis. What we have studied in our MBBS, the tuberculosis, the treatment, it is now far, far, far better and modified and updated. Our Prime Minister has assured to eradicating this tuberculosis is another 7 years. Whether it is possible or not, only the Subramania has to acknowledge or to certify it. Over to Subramania. He is a very active member, and among the few members, he is a very active in giving the lectures of our FPA forum. Thank you, and over to Subramania, sir.
Thank you, Dr. Jaiprakash, for your kind words. It's really heartening to be in the family, and that's why I didn't give my details to be printed in the place of guest speaker, because I am not a guest here. I am at home, I am part of you. I am here to share some of the information about preventive screening. Excuse me? Show me. Previous either. Preventive screening.
Sir, it's my pleasure, sir.
It's my I'm really my pleasure you are sharing this session. Load ಮಾಡಿಲ್ವಾ ಇದೆಯಾ ಇನ್ಫಾರ್ಮೇಷನ್ ಇದೆಯಾ ಪೆನ್ ಡ್ರೈವ್ ಅಲ್ಲಪ್ಪ ಅವ್ರದ್ದು ಪ್ರೆಸೆಂಟೇಷನ್ ಇದೆಯಾ ಇಲ್ಲ ಅಂದರೆ ಕೊಡ್ತೀನಿ ಮತ್ತೆ ಏನು ಮಾಡ್ತೀರಾ ನೀವು ತಗೊಳ್ಳಿ ಅಲ್ಲ ಕರೆದ್ರೆ ಒಳ್ಳೆಯದು ಪ್ರಿವೆಂಟ್ ರೈಟ್ ಇಲ್ಲ ಇದೆ ಓಕೆ It's not coming on the screen. Okay. Dear friends, I am coming in between the lunch and you, and since due to shortage of time, I have to rush through. I will try to communicate the message what I was supposed to. And you are all well experienced senior family physicians. You know most of the information. You know the importance of preventive screening. We all think we are all healthy. When we have no symptoms, we think we have no problem. When we go through screening, we see good number of abnormalities, deviations, which are really useful to prevent further damage and complications. So today, message is prevention is better than cure, and how to go about prevention. So I'll rush through these slides. There are 53 of them. Hope these things we are all familiar. What is health? So this definition we have to revise now and then. It's a state of complete physical, mental, and social well-being, and not just merely absence of disease or infirmity. How healthy we are is a big question mark. Same thing applies to everybody. Are we aware of how healthy we are? We may be asymptomatic, but still we come to know when we do screening. Many problems remain silent till they develop complications. It is here the preventive screening matters. See, I'll skip in the statistics. We are hearing day in, day out, people dying of sudden death. Is this sudden death really sudden death? I don't think so. There's a lot of pathology behind it. It takes quite a long time to cause this endpoint. If properly analyzed, screened regularly, probably these sudden attacks could be prevented in most of the cases. Is the cost of treatment. We were all thinking women are less prone to heart attacks, but I am surprised. Heart disease is #1 killer of women. So these are statistics. These are the prevalence of diabetes in various states of the country, India, highest in Ernakulam and lowest in Manipur, somewhere in between is Bangalore. Top 10 cancer in men in India: lip and oral cancer, lung cancer, stomach cancer, colorectal cancer, esophagus cancer. Top 10 cancers in women in India: breast, cervix, ovary, lip, oral cavity, colorectum, lung, stomach, esophagus, in this sequence. What is the cause of all this? Lifestyle. We all know very well about it. We have heard enough about it. And lifestyle includes processed food, stress, lack of sleep, smoking, alcohol, unhealthy diet, inactivity, lack of socialization. Day in, day out, we keep advising. This is our main topic. Family physician means is a lifestyle doctor. So, I'll keep moving. Cancer is not detected in early stage in India for various reasons, because of facilities, because of ignorance among public, and lack of awareness among professionals. Healthy lifestyle, diet, healthy nutrition, exercise, self-content, I think travel. Screening. What is this screening? Screening for diagnosis, screening for treatment, screening for post-treatment care. At Neura, it is proactive approach, asymptomatic for healthy people. After sickness, yes, definitely we do screening. To prevent sickness is the whole issue we are talking about today. about Neura. Neura is a premium AI-based health screening center, one of its kind in India. It's a collaboration between Fujifilm Healthcare Global DKH Group, bringing you the best of AI-enabled imaging technology to improve your health screening experience. Why Neura? Driven and backed by AI, ultra-low dosage of radiation during scan. Please note this in the few slides later. This gives an idea of difference of what Neura is. Real-time health reports. All tests are done and reports are ready in 2 hours in one center. Ultra-low dose CT scan. Your CT scan radiation is as good as one X-ray. DEXA scan, oral screening, 3D mammography, colposcopy. See, all these things may be done in various centers. Are they having the state-of-the-art equipments, technology, infrastructure? That's a big question mark. We see the reports from various centers, and sorry to say, most treat the reports. Oh, you don't have problem. I think from morning till evening we have been talking about treat the patient. All these things are supportive. If some report says there is no problem, and clinically you are suspecting something, you cannot just leave it as it is. We have to rework on that. It can be technical error, it can be reading error. So probably AI minimizes those errors. See, what is how they are different from others? It's AI-based screening. Screening is based on imaging by radiology and blood metrics. Cancer screening through blood images and AI-based interpretation. Time taken for each screening. Here in Neura is about 120 minutes, and elsewhere it should be more than 5-6 hours. And for different systems, they have to go to different centers. It will go on. And personalized assistance, report, format. This is how an outlook of Neura is. You are entering, waiting area, registration, check-in, RFID, women's dedicated floor. It is truly a 5-star ambience. But what are the tests done? BMI, body composition, lung, heart, abdomen scan, mammogram, cervical health, doctor consultation, eye examination. All these are done within 2 hours. Reports are ready at the end of the last test. What you can see, body composition. We all see ourselves, our belly, and say there is fat here. And when we do these scans, even a slim person has visceral fat. We all know how bad visceral fat is. So it is time we check what are the treasures we are hiding inside ourselves, to be aware of, to take care of it. Oral scan, eye, cervix, audiometry. See, this is a breast scan. More than 50 different AI help the specialist in early detection. That's the main goal, early detection, early detection. See, just watch this. In ultra-low dose scan, you're not seeing any finding of a lesion. In high dose scan, also not visible. Here in AI-enhanced ultra-low dose scan, the lesion is visible. Probably in 1 and 2, in like conventional scans, if done, we would have missed this lesion. Probably only to know, and we would say, patient, you don't have any problem, don't worry. Only to know when patient come and say, sir, I am feeling a lump in the lump, why it was missed. So this is where AI is coming to our rescue. Heart coronary artery calcium. It's a quite useful thing. It may not diagnose exactly the blockage and severity, but it does give a leading clue that there is block somewhere. To what extent? That is the next thing. So calcium score, CT scan is pretty expensive, but here this is a part of the package. This is based on this, we have to suspect and do further investigations like CT, coronary angiogram, or conventional angiogram when required. Heart attack can be avoided by early detection of blockages in periodical annual checkups. We can take preventive measures, giving statins, aspirins. We know very well how to prevent, provided in all these asymptomatic people, we don't know they have any problem until we screen them. We can map coronary calcium plaque deposition in this. This is a body fat analyzer. We know how important is body fat. It is even more dangerous than calcium coronary blocks. It is an atom bomb inside. So it's very useful to screen for body fat and take care to prevent. So it's a case study. Just watch this. In 2011, 2012, 2013, there is no such lesion identified in a conventional study. See this AI-based study. 2 years before that, when it was spot, less than few millimeters, stage 1. At that time, if it was diagnosed, it is 100% cure. Nowadays, cancer means we don't say, oh, gone case, no cure. No. Cancer, there's ocean of advancement. Stage 1, 100% cure. At any stage, there is some life detected well in time. So this is an advantage. Probably in first and second example, we would have said, no problem, don't worry. If that patient doesn't come for a few years, they come in a later stage and we'll say you are too late. Digital mammography. So everybody does mammography. How advanced it is, how accurate it is, we don't know. Whatever report they give, we read. It's a fit, sweet paddle, pain-free technology, putting patient comfort first, designed to fit the natural shape of breast. Early finding, save the life. Okay. Fecal immunochemical test is superior to symptoms in predicting pathology in patients with suspected colorectal cancer symptoms referred on a 2WW pathway, a diagnostic accuracy study. This is from the stool sample, the cancer can be detected. And they are so well planned, they will send a kit by courier to the house. You take the stool sample and a tissue, put it in the diluent, seal, and just give a missed call. The courier fellow will come to your door and take it to the lab for analysis. Everything is state of the art. Visceral fat obesity, we very well know that. Blood test is only one part. Imaging test for clinical disease. See, we are all gone through, I think none of us have got the what do you call this? The children get a scorecard. What do they call? Report card. Like A grade, B grade, C grade, like that. Now Noora is giving a report card of your health about every system, what category it belongs to, and they have explained what is A, what is B, what is C, what is D. And all reports digitally made, sent to you by email, and you get a hard copy also, and you can access anytime from anywhere. And all done in 120 minutes sharp. At the end of 120 minutes, the reports are on the table of a physician, well-qualified physician. Physician will explain every point, deviation in your reports, and good thing what I observed is they will never advise any treatment. They will say, you please go back to your physician who referred you, he will help you. These are the deviations you have to look into. Please go back to your physician. So strike the disease before it strikes you. This is one part of what Noora has given me to give the presentation. I am not here, come here to promote Noora or any diagnostic center. I have just made it a point to know, for you to know what is the advantages of this latest technology. Before last year they participated here. At that time they had given some discount coupons. Just for curiosity, I went for a screening. Till that time, every year, I used to go through conventional screening, perfectly normal, no comorbidities, nothing, TMT negative, everything negative, only LDL was 130. I used to think there's no other comorbidity, blood pressure normal, no diabetes, why should I bother? When I went through Noora, I came to know my calcium score was 200. I am running. Now also, I am a runner. 5 kilometers I run without break. I do workout. I have a genetic background too. But this is an indicator that there can be some blockage. Then I went for CT angiogram. It gave an indication of 15 to 20% block. And I consulted. My kids whom I have given polio drops, 5 of them have become DM cardiologists. I called one of them, sir, he said, sir, don't worry, nothing will happen, you just take statin. I was a little reluctant before that. After this, I started taking statin. 1 year later, it came to 100 from 200. I have to wait and see next year. Probably, the so-called we call silent death, nothing is silent. Without giving enough information, we don't get hurt. Strike the disease before it strikes you. Coming to the point, I understand a lot of senior colleagues, my teachers, mentors are here. They are little, maybe smiling behind the hand. What is this? Because they don't believe in all these tests. They believe in patient and parameters. But somewhere, this comes to help. Where? Our duty is to inform our patients. These are the things available. And cost factor. It looks expensive when we hear about the cost. But when you go through the components of the test, types of tests, if you get it done individually in many places, it is more costlier and no comparison to the results we get in an AI-based center. And we all have people who can afford. It is only we underestimate ourselves and our patients. When I brief them, this is a thing, screening modality. Some of the things we can pick up early, and this is better than the conventional things. If this is cost this much, if you are interested, I will refer. I'll take their permission. I'll never insisted anyone to do this test. To my surprise, good number of them agree. not only agree, when they get the reports, I rarely see a normal report. Either visceral fat or coronary calcium or some bone density and 2-3 abnormalities. If you just tell like that, if you're fat and all, people won't take into consideration. When there is documentation and proof before you, they will definitely agree. And some of them have taken their family members. And some of my friends and patients and relatives who come from US and UK and various other countries, I had recommended this center. The feedback they have given is, it is on par or even better than what they see in US. In US, to get a scan done, you have to take an appointment, wait for a couple of months. To get all these tests done, it is next to impossible in foreign countries. In fact, those people who got tested here through my recommendation, they are sending their friends and relatives. When you go to India and Bangalore, don't forget going to Neura. I'm not promoting it. This is what I'm experienced. In my experience, I'm sharing with you. You are the judge. Wherever patient can afford, probably we can take the help of Neura. Definitely a better modality, screening center. Strike the disease before it strikes you. Thank you for your patient hearing.
Thank you, Subramania sir. A wonderful presentation. As a family member of Association of Physicians, you explained so well. It is a unique center where myself, my wife went and got tested. It is the one point that I have noticed there is they will not take much number for their test on the particular day. Only 3 to 4 or 5 or to 6 patients they will take. It is the ambience is so good, the wonderful way they do their tests under the fusy films. It is a unique center which I have been experienced in Bangalore, particularly in Indranagar. It is situated. Any one of our members, please go and get tested. If they are giving some discounts, it's well and good, or otherwise, it is up to their knowledge to go and get it tested. Thank you, Subramania sir, for your wonderful presentation and giving a caution for the lifestyle management of this kind. Thank you.
Just one announcement from Neura. They have given complimentary coupons for all doctors. They can go and get themselves tested. Yeah, and the book launched by Dr. B.C. Roy is given at a discounted price. You can collect it. 400 rupees. 400.
Now we'll break for lunch.
Yeah.
Hello. Due to the paucity of time, most of them have gone to lunch. Now we will break for lunch and we will reassemble at 2:30 for the wonderful session on panel discussion on allergy and allergic rhinitis. Okay. I call upon Dr. Subramaniam. It was a very nice lecture from our past President Subramaniam on health screening. So we had the privilege of being the speaker of the event. Hello, good afternoon everybody. So we'll go on to our academic session. That is the important part of our this today's program, panel discussion on allergy. So it is being moderated by one of the experts in allergy, Dr. Gayatri Pandit. She is an ENT surgeon and allergy specialist at Samarth ENT and Allergic Center. She is a president of Allergy Asthma Network of India, core committee member of Indian Guidelines on Allergic Rhinitis. She is the convener of Allergic Rhinitis Module, IAP chapter. She is a meritorious background. She has a gold medalist in her post-graduation. She is a very lucid speaker and she is a very proficient moderator. Over to Madam, and I call upon the other panelists, Dr. Nataraj, dermatologist, Dr. Shivling Swami Solimet, pulmonologist of Trustwell Hospitals, and I call upon our FPA moderators, Dr. Preeti and Dr. Subramaniam. So over to Dr. Gayatri to take over the proceedings of the session.
Thank you, sir. Thank you for your kind introduction. Pointer. This is forward. Okay. Okay. Well, so we are at a first session of post-lunch. So I was worried that probably that we will have to speak in your hypoglycemic state, but now we have other challenge of speaking in your hyperglycemic state. We have kept it very, very simple so that you can really take home some messages for your day-to-day practice. So I have two wonderful moderators from representing from Family Physician Association, and I have two panelists, Dr. H.V. Nataraj and Dr. Shivalinga Swami. Dr. H.V. Nataraj is a former professor of dermatology in Victoria Hospital, and he also has experience being as an examiner for UG and PG for more than 30 years. And presently he is a professor in Akash Medical College, Devanahalli, and he is also a private practitioner. So we seek to have valuable inputs from you, sir. So both from a private practice and from your institutional practice perspective of it. On the other hand, we have a very dynamic pulmonologist with us who is a consultant pulmonologist at the Department of Pulmonology and who has a very special interest in the interventional pulmonology and sleep medicine, and who is heading the department at Trustwell Hospital. So, your theme I saw was a family physicians, the pillars of the healthcare, right? So sir was also telling that it should not be pillar. So I would put it as you are the first point of contact for many diseases. So I would actually take you as an adenoid of a nasopharyngeal airway. Okay, so how we would consider an adenoid of a nasopharyngeal airway? So you all are the adenoids of a healthcare. So you are the first point of a contact. So let me brief you a little bit on an allergic disorders and then take you through the questions through our panelist. So what is allergy? Allergy is a chronic inflammatory condition, and it's an abnormal reaction to ordinary harmless substances, okay? So allergy is not a dislike. I am allergic to upma, I am allergic to dosa. So the dislike cannot be equivalent to allergy. So allergy is something, an abnormal reactions to very normal substance. A peanut, a cat, we all tolerate it, but only few don't tolerate it. So it is such kind of an abnormal reaction to harmless substances. and it can run across the various spectrum of the diseases. So starting from, it could be just from the rhinitis to a most dreaded, the fatal allergic reactions, which is anaphylaxis, which can lead into mortalities also. So just to mean that the IgE mediated disorders can spread across various allergic diseases. So what exactly happens in the allergic phenomena? Because this would be important for you to understand on the treatment aspect of it, and so also what are the diagnostic tests that we need to do. So when an antigen is entered, it is taken up by an antigen processor cell, which is like an escorting cells to your principal, who is a T lymphocytes. And T lymphocytes presents it to a B lymphocyte and directs it to produce IgE antibodies in an allergic patient. Otherwise, it would have produced an IgG antibody. So this is called as a class switching. And these IgE antibodies will sit on the mast cell to release certain mediators which are early phase, late phase, and you develop symptoms according to that. But just the binding of it will cause its symptoms? No. There has to be a further, this is only a priming. There has to be further exposure of an allergen, and there is a coupling reaction of an antigen sitting on these IgE bodies to sit that. So there are different mediators, like you have in histamine, you have in eosinophils in a chronic inflammations, you have in interferons, you have in IL-10, IL-13. So all our treatment modalities also will be directing here to direct the different modalities of the inflammations that are being modulated. So what are the antigens that are causing this? So they usually come from the category, let me restrict to respiratory here, they come from the category of house dust mite, pollens, fungal spores, animal dunders, and cockroach allergens. So these are the predominant 5 set of an antigens which causes a respiratory symptoms. So it is not the smoke, it is not the perfumes, it is not the strong odors or something. All those belong to a category of irritants, and only these are the category of allergens. The other allergens could also be from a food, some allergens could also be from the insect bite, some allergens could also be from the drugs. So how do we test that what you are sensitized to is by a method called as a skin prick allergy test, which is considered as a gold standard in the diagnosis of respiratory allergic disorders, and also in few cases of a food allergies also. So we can test here only those 5 categories of allergens that I tested. One of my patients came yesterday and told me that, doctor, I think I have allergy to Bangalore. So can you test me for that? So I cannot put a Bangalore drop to that patient and test it, isn't it? So allergies are far more specific disorders where you will be able to test for only specific antigens. So there is a specific pattern in which these allergic disorders can manifest, starting from atopic dermatitis, and concurrently the patients can have a food allergy, and that can actually wean off over a period of time to set in a respiratory allergies like an allergic asthma and allergic rhinitis, which might persist for life. Now this pattern is called as an atopic march. So it is not necessary that everybody gets into this atopic march, and it is also not necessary that everybody follows the same pattern. There could be reverse atopic march also. The respiratory can start first, and then later you can have a food allergy or atopic dermatitis. But this is usually a pattern in which how it presents. If you don't know this, you may not be able to join the dots. If a same patient presents with an atopic dermatitis, rhinitis, asthma, so it is very important to join the dots to understand that this could be a part of an atopic march. If you all think, what is the first way that we all get sensitized? If you're thinking that we are breathing and we are getting sensitized, no, we are wrong. The first mode that we all get sensitized is through skin. The skin is the biggest organ, and skin is a very sensitive organ, and since skin is also very immunologically active organ, so most of the sensitization can occur at the level of skin. So when it affects nose, you have allergic rhinitis. I'm not very sure if you are able to read that. So which typically presents with us 5 symptoms of a rhinorrhea: sneezing, pruritus, nasal congestion, and conjunctivitis. The two more important symptoms, the two very important symptoms which are marked in a red line, the sneezing and pruritus, are histamine mediated and very hallmark of allergic rhinitis. If your patient does not have these two symptoms, you may not be dealing with allergic rhinitis. You may be dealing with a polyps or a nasal spur or something else. You need to reconsider on your diagnosis. Whereas in asthma, so what will be the pathophysiology that is happening is sorry, the video is, the audio is. Yeah, so what exactly happens in an asthma is there is a smooth muscle hypertrophy. So this smooth muscle hypertrophy leading into the obstructions, initially reversible, and there could be further airway remodeling leading into sometimes a partially reversible or a irreversible airway disease too. So you can differentiate that in allergic rhinitis, it was more of a vascular engorgements among your turbinates, whereas when it comes to bronchial asthma, the remodeling was happening more at a smooth muscle hypertrophy. So though the disease is same, the disease is an extension of the same, the target organs seem to be slightly different. Whereas when it comes to atopic dermatitis, which is one of the first disease to appear in an atopic march, the key pathophysiology here is the lack of filaggrin, or there is something called as a cementing material. So our skin is not just like this, our skin is like a big fort. So there are like a joint cells, there is a tight junction between our cell. So in atopic dermatitis, it is a leaky. So it is like there is a deficiency of that cementing material, and because of which the allergens can easily enter into the skin, and that's how even the respiratory allergens can get sensitized through your skin. Another allergic condition, though may not have much association with our respiratory allergies here, is an urticaria or urticarial hive. So it is said that urticaria affect to 15 to 20% of the world population, and at some point of our life, at least 30% of us would have experienced some form of urticaria, whether it is an acute or chronic. So with this brief introduction, let me just take you through different case scenarios, and if our time permits, probably we can have questions from our the questions from the audience and the moderators too. So we will take it like as case scenario. Sir, Dr. Natras sir, this is for you. So you have a mother of a 1-year-old boy baby who presents with a history of dryness over the face and knee, like the picture that I have put earlier. So the boy is also scratching the lesions, which gets worse at night time, and child becomes very cranky. So you see that when you have a patient of suffering from allergic rhinitis or eczema or atopic dermatitis, it is not just the child; it is a whole family which suffers. Nobody is able to sleep here. So what are the treatment goals in atopic dermatitis? When a child presents like this, so what are the intentions of your treatment, and how will you step your treatment, sir?
So as you all mentioned, that the literal meaning of atopy means out of the world. This was the term which was described by a scientist called Koka. So he observed that the people or children who are born to persons of family history of allergies, atopy, urticaria, wheals, and then hives also, they develop at the time of birth, the child will be normal. After 3 months, 6 months, or even before 1 year, the child will have dryness of the skin, especially on the cheeks, elbows, knee joints, and even on the thighs also, wherein it leads to severe irritation, and the child starts scratching, and because of the scratching, there will be inflammatory papules. That is why the term dermatitis. Dermatitis means inflammation of the skin. So they will have a tendency for atopy, and it can transmit genetically also. It runs in families, and the child starts with the reaction, severe allergic reactions. Either it may be precipitated by factors like external factors like allergens, plant allergens, dust mites, dust, and then fibers, especially fabric fibers. And suppose if the curtains are not cleaned properly, surrounding the house there are a lot of plant allergens, the child will have severe atopic dermatitis, or sometimes with the mother also, if she is feeding with the cow's milk, or if the breastfed baby, the chances of reactions are less, but with outside food, the chances of reactions. And better we should avoid them not to use nuts, especially the peanuts, and then egg proteins. These are the things, and junk foods, allergens food, oily food, spicy food, these are the things which can precipitate and exacerbate the conditions. More previely, the child will be highly irritated. Because of that, any amount of treatment, especially during night times, they will have severe itching, and they will cause problem to both the mother and the child. That's why they bring to the doctor with these severe symptoms.
Yeah. So what treatment, how would you step your treatment, sir? So what are the basics of your treatment?
Sometimes if it is very small area and localized, it is very easy to treat, because whatever we say that symptomatic treatment and avoiding these factors, we usually advise them to wet mop the area, floor of the rooms, and then vacuum cleaning the curtains, also very important, and bed sheets, bedspreads, everything. And we ask them to wear proper clothing, cotton cloth, loose fitting cloths. They should not wear synthetic cloths with nylon and woolen, because even if they want to wear because of the cold, we ask them to wear over the cotton cloths, because those already the skin is inflamed. These fibers will cause severe inflammation and irritation. Whatever the amount of treatment to give, it will not be successful. And the other one is they have to avoid all these factors, food. What you said here, peanuts is not so common, because everywhere we see peanuts being consumed. But once I visited America, we can see that even in flights also they have introductory card that peanut allergy, be careful, this food doesn't contain peanut also. But it is widely used everywhere, but that causes severe anaphylactic reactions for peanuts also.
They will get heart attack the way we celebrate Kadlekai Parshi if they
Yes,
see that.
yes. Especially nuts, especially the nuts which are used in chocolates, they should avoid all those things.
So any moisturizing technique or the advice that you would give? So because one of the pathophysiology that we spoke was anophylagrine deficiency.
Say,
so
if
what's
it is
the
mild
moisturizing
if it is mild and the children is comfortable, then we can use moisturizers, which gives very good importance, because the skin is inflamed, there will be dryness. To prevent the dryness, especially there is disturbance in the transepidermal water loss. The child will not be able to conserve the water, inside water. So that's why we have to apply a layer of emollients or moisturizer, which prevents evaporation of the liquids. So that prevention of transepidermal water loss make the skin healthy, moist and supple. So that's why we have to use moisturizers. And for severe itching, we can use sedative antihistamines in children, because most of the time they don't sleep. In adults, we don't advise sedative antihistamines, especially in cities who are driving, doctors or any professions who are working daytime. They should not take sedative antihistamines, but children we advise sedative antihistamines. Yeah. Apart from that, if the severity of atopic dermatitis is very severe, you can prescribe a topical steroids. It's the first drug of choice.
But restricting it for a shorter period.
Short-term period, because topical steroid, clobetasol propionate is there, but that is a high potent steroid. We don't use that. You can use it for adults. But even in adults also on the face, we should not use high potent steroids. Other areas we can use, but children we have to use clobetasol butyrate. That is trade names, if I mention, Umazone is there, Hicar is there, and then hydrocortisone is there. Hydrocortisone these are all safe drugs.
Low potent, it's quite
if
low
we
potent.
use too much potent corticosteroids on the face, especially for children, larger surface area and long term, that it can cause glaucoma. Very important is glaucoma and moon face. Yeah. The child will develop severe moon face and atrophy of the skin, telangiectasia, all these problems are there.
Yeah. Thank you, sir. Very good information on how the distribution of the lesions are, how the clothing has to be, how the moisturizing has to be, how to take care of itching, and you also mentioned about in a very acute and exacerbated lesions, how to use it and how short to use it, and emphasized on using the low potency. Now, if the same little elderly child, you kind of uncovered it quite a bit in your information that you shared. So here the dryness was more in the neck and cubital fossa, and also seems to have a wheezy episode of late, and mother feels that the lesions usually go worse whenever the child eats egg and also eats cakes. So she wanted to know, is it some form of an allergy? I know that all atopic child, you may not probably subject them for a skin prick allergy test or a in vitro testing. So which atopic dermatitis patients that you would usually ask for an allergy evaluation, sir?
Usually in a severe form of atopic dermatitis, and more so if it is due to foods. So foods is the one, because we have to give the foods, and suppose if that particular food is causing, then we have to think of alternate foods which doesn't cause allergy. So that's why. Another one is drugs. Drugs also, it can cause severe reactions in some patients, or not necessarily in children also, even in adults also.
Yeah, some NSAIDs are also
drug
known to
reactions
cause
are very known to cause severe acute anaphylaxis or even toxic epidermal necrolysis, which is a very severe condition and leads to death also. So many cases have been reported, not knowing that this particular disease is due to the drug. They have continued the drugs and the patient has worsened, and by the time they come to the major hospitals, the person would have died. So deciding the factors which is responsible, either it is due to food or any particular drug, to stop the drug or offending food is very important.
Yes.
Unless you stop that, whatever treatment you give, that will not be effective.
So if you have a very specific history, if you have a family history, as sir said, the presence of, in this child, the child was also wheezy, the presence of other IG-mediated disorders, so probably we'll definitely need to plan for allergy test in those patients. Dr. Salimat, this is for you. We have a 25-year-old techie who presents to your clinic and who presents with a history of runny nose, sneezing and itchy throat since last 3 weeks' time. Patient thinks that it's a seasonal flu and he wants some quick fix for that, and he tells that it happens with every change of the season, and most of the time monsoon I have this problem, sir. And your clinic record tells that, past 3 years he has almost visited in a mid-June for you every time. So how do you differentiate whether it's a seasonal cold or allergy? Because patients think that it's just a flu and he wants some short fix.
Good afternoon, everyone. Thanks FPAB for having me here. Thank you, Gayatri Madam. So coming to this particular thing, usually allergies or asthmas are usually seen in younger people, more commonly in younger people. Nowadays it is seen even in elderly individuals because of the external influences. Young fellow having seasonal variation of symptoms is the most common way of presenting of allergic induced asthma, be it allergic rhinitis or be it bronchial asthma exacerbation. So how do we differentiate is usually this seasonal cold, it's usually due to viral infections. Adenovirus is the most common thing which cause. So they come with body pains, they will have fever, they will have thick mucoid or mucopurulent expectorations or nasal secretions, unlike in allergy where they don't have fever, they don't have body pains, they don't have malaise. They have only itchy nose, they have running nose, especially watery, thin watery running nose. They will have associated throat itching, they will have associated running of watering of eyes, and typically seen during the change of weather. It is not seen during the peak of the weather. It is usually seen when there is change of weather. So if there are constitutional symptoms along with these typical prodromal symptoms like fever and myalgia, body aches and mucopurulent secretions, they usually differentiate them from seasonal cold and allergic induced rhinitis.
Yeah, quite well taken. It's said that, so if you take medicine, it will get over in a week time. If you don't take medicine, it will go away in 7 days time.
That's seasonal cold.
Yeah. So sometimes you can even have perennial allergies with a seasonal exacerbation. Say for example, dust mite can have throughout the year symptoms, but with a seasonal exacerbation in the monsoon because of some breeding conditions of house dust mite. So that's also not an unusual pattern to allergic rhinitis. The key message is, so when symptoms are for more than week time, or patient even suffers for 1 month time or 2 months time, please consider it as probably a pollen allergy, and you might need to treat it for a little prolonged time and not just treat it as a common cold. To continue with you, sir, we have a 16-year-old boy studying in a 10th grade who is been known to be suffering from allergic rhinitis. Now he has been diagnosed already with allergic rhinitis. Presently started with early morning cough now, and his tuition class is in the 2nd floor, which he was climbing very comfortably. Now he starts feeling little breathless and he tells that there is a chest tightness. So how common is this one airway, one disease, and what warning sign that we all should think of that this allergic rhinitis patients may be going in for an asthma and I need to look more?
So they are the spectrum of same disease. So it's basically allergic manifestations. Predominantly in the upper airway, we call it as allergic rhinitis. If it is more predominant in the lower airway, we call it as bronchial asthma or allergic bronchitis. In some people, it will be more predominantly upper airway symptoms. Some will have more of a lower airway predominant symptoms. And it becomes imperative and it becomes compulsory that all of us, whenever we see or diagnose a patient of allergic rhinitis, also look for asthma symptoms. Vice versa is also very much right. So when someone comes with wheeze and typical seasonal variation of symptoms, you look for allergic rhinitis symptoms also. Ask them typically, do you have sneeze, do you have running nose, do you have nasal blockade and all those stuff. Typical case is this, a 14-year boy now feels breathless, wheezy, and finds it difficult to walk or finds it difficult to do his daily playing or daily routine activities. And since it is recurrent, always have a keen eye on diagnosing asthma. So how do we actually do in our clinical practice? When patient has predominant lower respiratory allergic symptoms, do a simple pulmonary function test. A spirometry can easily show us what is the severity of obstruction, whether there is obstruction or not, and how severe is the obstruction. And we do post bronchodilator response also. We give them a puff of Astelin or Livolin and wait for 10-15 minutes, or nebulize the patient with salbutamol, levosalbutamol, wait for 10-15 minutes and repeat the same spirometry. This will give us whether there is post bronchodilator reversibility of more than 200 ml and 12% change in the FEV1 value. So it is a simple way of diagnosing lower airway obstruction severity of asthma. And also very simple, you do an absolute eosinophil count in the blood and you do serum total IgE. Now
So
it's
that
very
will be
easily
a
available.
supportive treatment for you for an eosinophilic asthma.
Eosinophilic asthma.
Or
So-
more of a type 2 asthma.
Yeah, and also now we have better, furthermore modalities of diagnosing these things. That is using FeNO, that is a fractionated fraction of expired nitric oxide. So there are multiple ways. So most important warning signs which you ask is if there is increased wheeze whenever there is change of weather, and if a child is going to the school or going through a park by chance, every day he used to take the road, now he's going through a park, and that's when he's having allergic symptoms. So this always shows that he is allergic to pollen or allergic to. So there are some signs which you can certainly pick up by history only. And also increased difficulty in breathing, wheezy cough, and thick mucoid expectoration, which is increasing. And in between symptoms, baby or the child is absolutely fine. These are typical signs of asthma.
Yeah. One very important point that you told at the end also, like it could be like in variable symptoms. You might be seeing the patient to be perfectly normal in your clinic when you are examining in the afternoon, but the patient would have had more symptoms in the night time because it's quite a variable disease. And I tell one simple thinking is, if your roof is leaky for a longer time, your floor is bound to get spoiled. So if you are having an untreated allergic rhinitis for a longer time, so your lungs are bound to get inflamed. PFT is one of the very important tests which the pulmonologist and we as an allergologist also take use of, but just mind that it is an effort-based test, and it requires a proper technician to perform the test, and it has to be always be done with a reversibility. So when you're reading a PFT, please consider these things and just don't go biased by some lab reports where they wouldn't even have blown for 2 seconds and they would have still given a PFT these things.
I'll just simply give you a simple clinical nugget how to read a spirometry. Whenever you see a flow volume loop and a volume time graph, you see one line going like this, like a typical line graph, and one loop going all the way like this. If the size of the loop is smaller, or if there is a good concavity in the upper part of the thing, it says there is obstruction.
Yeah.
Just by looking at the graph, you can make out.
So just look for a concavity.
The concavity of the thing.
The graph. That tells you about the obstructive.
Yeah.
Very
And
nice.
time. You look at the volume time graph, that's also there.
Yeah.
Patient should have blown the air forcefully for at least 4 seconds.
Yeah. So we have just probably a 5-7 minutes left for another 2-3 questions that I have. So we will take just like in one sentence answer for these things. So, sir, this is, Natra sir, this is for you. We have a 15-year-old boy who develops urticaria lesion since 2 days. 2 days history, intensely itchy, and patient feels that he started having that after eating outside in a restaurant that day. Last week, the patient was found to have a viral fever. So my question is, just a simple one-word answer only I want. What is the most common cause of acute urticaria?
See, as mentioned, the diagnosis is acute. Acute means it's a short duration. That is, usually we take it as less than 6 weeks. If it is chronic urticaria, it is more than 6 weeks. Urticaria, the literal meaning of the patients will develop immediately after taking certain foods, day-to-day foods, which he was taking earlier also, but they have not caused any problem, but suddenly they may develop allergic rashes. The urticarial rashes are a characteristic is transient and evanescent. The patients will have severe urticaria and itching and wheals and flares. By the time they come to us, there will not be any lesions. That is the very characteristic of urticarial lesions. Or even if it is very severe, especially angioedema, because of the loose areolar tissue around the eyes and the lips, they will have early morning swelling of these areas, and sometimes it can cause severe angioedema, laryngeal edema, and even anaphylactic reactions also. But most of the time, acute urticaria doesn't cause any severe anaphylaxis or severe life-threatening to the patients. Once they come, we have to assess whether it is due to the offending drug or due to any substances of food which he has been using. And according to that, we have to eliminate those things and then treat accordingly. Most of the drugs, as most of the practitioners or even you might have observed, maybe due to non-steroidal anti-inflammatory drugs, analgins, aspirins, antibiotics, and then any other drug can cause. Even insulin,
the most
penicillin.
common is still of post-viral.
Yes, viral. Post-viral also.
Is the most
so another
common
cause is
that you
infections. Infections can also cause.
So what's the drug of choice for using a treating?
First, elimination of offending drug, and topically we have to give some soothing lotions like calamine lotions, or sometimes if it is very severe, you can advise topical steroid lotions also. And then systemic drugs is very important. Most of because it is due to the H1 receptor antagonist, whatever the drugs which are under H1 receptor antagonists, we can try with this either cetirizine, levocetirizine, loratadine, Avastin, or even hydroxyzine. Hydroxyzine is very good for urticarial lesions, but only problem is hydroxyzine can cause severe drowsy and sleep to the patient. Some patients who take hydroxyzine, they say next day, evening or afternoons also, they cannot get up. And most of the patients who want to be alert driving, and then those who are in the industrial areas, we should not give sedative antihistamines. By and large, the newer second generation antihistamines are very safe, and they doesn't cause much sedation than the older drugs.
So if the same case has to be a chronic spontaneous urticaria, so with a shortage of our time, I'll cut short my question also. Let us just directly jump into a chronic spontaneous urticaria. And if we have to use an antihistamines here, so what is the dose? We usually use it as in, either in Avastin as in 10 mg or fexofenadine as in 180 mg. But how long would you use and how much do you use here?
Now, if it is very severe reactions, we have to admit the patient, then we should not think of either it is sedative or non-sedative. We can give either injections of any drug which is there. Even hydroxyzine injections are there, tablets are there. Tablets in many higher doses, 10, 25 milligram, and even slow reacting, 50 milligrams are also there. Injections are also there. In addition to that, we have to think of other non-sedative antihistamines also. Suppose if they are working or if they say that we want to work, then you can add non-sedative antihistamine in the morning, that is fexofenadine, 180 milligram, morning and afternoon. And night times you can add mildly sedative antihistamines, though not highly sedative antihistamines.
So it's one condition, the chronic spontaneous urticaria is one condition, probably you go much higher on an antihistamines. Like in allergic rhinitis, we usually use only as an OD dosage, right? The recommendations tells that we can go up to 4 times the antihistamines. So correct. This is a one condition where the guidelines recommend on the use of second generation antihistamines up to 4 times also. So you can go up to that much profile and then you think on the
As you said, chronic spontaneous urticarias need antihistamines for longer time. And suppose if they don't respond to the lower doses, you have to either double it or 4 times also you have to increase. And gradually you have to taper the doses. And minimum 2 to 4 weeks we have to give antihistamines for them.
So the last one.
One question rejoinder to that. What is, you said long time, what is the longest duration we can use? And I think we can discuss upon lifestyle management in allergic diseases. These are the 2 questions. We had most of our questions you have asked.
Yeah,
So
yeah.
these are the two additional questions we would like to see.
Okay.
Also, as
You
a
want-
family physician, I feel this system, this allergy can be a secondary to some systemic illness. We should look into general health. We should look into comorbidities, take care of all of them. Probably the frequency and severity of allergy can bring down. In addition, we got used to treat symptomatically. So probably one is to see if there's any associated factors supporting it. Second, in addition to the symptomatic treatment, for every case, irrespective of what reason they come to us for some reason. They should not go away from our clinic without a lifestyle advice. That's what I feel.
And as you mentioned that if the patient is taking any treatment, psychiatric treatment or sedatives or any anti-anxiolytic drugs, then we should not give tablets of highly sedating because they precipitate and cause. And suppose if the patient is having renal and kidney problems and even liver problems, we should not give a combination of certain drugs. See, this antihistamines and other drugs like azithromycin and then clarithromycin and then ketoconazole, itraconazole, they combine and precipitate and increase the level of these drugs, which can cause harm to the patients. And patient may go in for kidney and liver damage also. We should be careful.
Yeah. One very important point that you both have brought up is on a lifestyle. See, everybody thought that during COVID season, the allergic disorders will come down because people didn't go outside, there were less of a pollution. But it was not the case. We did see increased allergic rhinitis, we did see urticaria because the patient's lifestyle became more sedentary. They were spending time more indoors. So, definitely, lifestyle becomes a part of a management of allergic rhinitis. Good exercise, good diet, less of a preservative, less of a coloring agents, yogic breathing techniques are also found to be a supportive treatment for your allergic habits.
Smoking,
yes.
alcohol.
So they are all a supportive treatment that we would consider. I will just put a last question and then I am done. So if you have any more questions, then you could do and then I will end. One of the very common thing that you all will come across is this question from your patients and from your colleagues and also from your relatives sometimes. So here is a 30-year-old boy diagnosed with allergic rhinitis and bronchial asthma. So he has been started on fluticasone furoate nasal spray and formoterol budesonide inhalers on a regular basis. So he's been asked to use it on a regular basis. So now these parents are quite worried about this steroid usage because they will read about the composition. If you don't tell them, they will read it and they will get to know. And they're also worried on this impact of the steroids on the growth. So should I be worried about using this? So how will you counsel that, sir?
First thing, don't worry. It's very clear. These are all inhaled corticosteroids are very safe. They don't even cross first-pass metabolism. And most of the drug gets destroyed in the airways only. They act at the place where they're supposed to be acting. And the dose of what you use inhaled corticosteroids is almost 1/5 or 1/10 of the dose what you use in oral form or injectable form. So this thing has to sit in your mind. Use of inhaled corticosteroids is the mainstay of treatment for allergic rhinitis as well as asthma. Never use only bronchodilators for asthma just with the fear that inhaled corticosteroids will cause pneumonia, inhaled corticosteroids will cause side effects. No, the mainstay of treatment is inhaled corticosteroids and your bronchodilator becomes the second part. Why do we use bronchodilator together is asthma pathophysiology as you were showing. It is not only the airway inflammation, it is also the smooth muscle hypertrophy and bronchospasm. So when we use a combination like inhaled corticosteroid, we call it as ICS, and long-acting beta agonist like formoterol. So an ICS-LABA combination always helps in treating asthma patients. They treat the both cause. One is the bronchospasm, which is taken care by the bronchodilator, that is the beta agonist, and the inhaled corticosteroid takes care of the disease per se, which is the allergic inflammation. So it is very important you never miss out on giving inhaled corticosteroids for both allergic rhinitis patients as well as asthma patients. That is the mainstay of treatment.
Yeah. So the main treatment these are the controller medications and they're meant to be used for long term. Okay, so don't ever tell your patients that these are steroids and you have to stop it in a 15 days. So no, they are meant to be used for longer time. And if you can see in the first table, I don't know how much it is visible there, look at the first column there, which is a bioavailability. So look at the fluticasone furan, less than 2%. Look at a mometazole, minimal. And look at a budesonide, it is slightly higher. But cyclosinide, fluticasone furan, again 1.26. So even if you are using in a microgram, even that, how much can the body can get absorbed to is like a bare minimal, okay? So it is just that we all have a knife at home, but we are not a murderer. So that's an example that I, give for a steroid. It's what way that you use and how you use is very important. And also ensure on the other aspects when the patient is taking an inhaler that always, if you are prescribing a MDI, always do it with a spacer. Ensure a proper techniques because all these are a device-based drug delivery. So patient might just put it like a perfume also. Patient might take 100 and if there is a one right way of taking an inhaler, I bet there is 100 wrong way of taking an inhaler, okay? Ensure that your patient rinses the mouth and spits it out after using it. So all these will further reduce any systemic absorption of steroids. So how long that patient has to take steroids? So for that, as an allergologist, I would want to give one answer is immunotherapy, okay? So we can desensitize for whatever the patient is sensitized to by a wonderful treatment called as an immunotherapy, which goes for 3 to 5 years time. And once we execute a immunotherapy, we will be able to reduce on the medication score, symptom score, prevent the progression of allergy, etc. So it's a team job. It's a multidisciplinary approach. For a patient, it is a multiple disease. As a specialist, when we see, we might just look into lungs, look into chest, but for a patient, it is a whole disease. So we also will need to connect to these disease, and allergic disorders have a significant impact on the quality of life. And since allergic disorders spread across the different systems, multidisciplinary approach is very important. Non-sedating first generation, second generation antihistamines remains to be a drug of choice across different allergic disorders, and intranasal corticosteroids and inhaled corticosteroids are a very important controller medications in allergic rhinitis and asthma, and this would be my take-home message for you all. Of course, with the lifestyle measures on the bottom line. Thank you. Thank you for giving a valuable inputs, Dr. Nataraj and Dr. Salima. Thank you very much.
Thank you,
Thank
Doctor.
you from you all.
Thank you.
So it was a nice talk. Regarding the investigations, we do eosinophil count, absolute eosinophil count, as well as the IG. Then we do come across the dermatologists do the patch test. We go for the blood test, how it differs and how long the medication has to be given.
Yeah, so.
Most of the skin prick test, we advise them to do that. Otherwise, even blood test for food allergens. Food allergens also, but nowadays the rates are high. Sometimes they used to charge 4,000, now it is 6,000, 8,000. It depends upon the number of the food allergens. So after that only, after finding particular food allergens, you can ask them to avoid depending upon the grade of the severity of the allergens or reactions what they give.
I have a comment here because I'm an allergologist who are doing this practice on an every day in and day out. Food allergy test we usually don't prefer to do by a skin prick allergy test because there could be a false negative values on the skin prick allergy test. The patch test that you asked about, dermatologists use it for a contact dermatitis, not for allergic rhinitis or asthma. Yes. So only if your history is very much directed, then only you will be doing a food allergies. Food allergies causing a respiratory symptoms alone is very, very less. It's a patient perception which is high. That the food causes my rhinitis, food causes my kapha, food causes my asthma. That is a patient perception. Whereas when we test it, it is extremely, extremely low. But food causing urticaria is very high. Okay, so when you have in food with an urticaria, food with an GI symptom, that is when you test. And when you are testing for an in vitro testing, the lab testing, there is ELISA test, there is an immunocap test, there is an immunoblast test. ELISA test has a very least sensitivity and specificity, has a very high false positive value. So don't go for it. If at all, if you are going for it has to be immunocap or immunoblast. And that is what is expensive. And that is what is approximately around 8 to 10K.
Now what she has said that we usually do patch test. There is one kit called Contact Dermatitis Federation of India. they have got 20 allergens. Allergens in the sense not foods, especially the foods which are commonly used in day-to-day activities, either in apparels, scents, or even imitate jewelries like nickel sulfate, potassium dichromate, parthenium weeds, like that. There are so many other names, balsam of Peru, and even whatever the essence we are using, they contains a lot of allergens. Cosmetics also, they contain a lot of allergens. Hair dyes, which contains PPD, which is the one which commonly causes reactions to the hair dyes. We advise them to use either lesser strength of hair dye with PPD, or totally avoid PPD and go for a safe plant-derived dyes also. Henna, or even one dye called vegetal dye is there, which is purely made of plant products, which doesn't contain PPD. So with knowing all these allergies, we advise them to avoid that particular, especially in ladies, imitation jewelries, especially because they contain nickel. Nickel is broadly used because it is cheap. The imitation jewelries, they want to go for imitation jewelry because it is cheap. So either it is for bangles, it is for chains, key chains, or even whatever the things they use in the form of articles, chains, they will have severe allergies. Especially some people will have purses or leather, they will have contact dermatitis. The ladies who keeps the purses on the upper left part of the upper chest also, they will have vitiligo, contact vitiligo. Especially observed ladies who are using sindoor or bindis, they will have contact vitiligo, contact dermatitis. Like that, they will have contact reactions.
One last question from my side. We keep doing hemogram or blood counts very regularly on a day-to-day basis. High eosinophil count, what is the role of eosinophilia?
Yeah, very important question, ma'am. AEC is a very routinely asked test in allergic rhinitis or asthma or whenever, as a routine test, right? So eosinophils does not remain as the only cell of an allergic mediator. So you will see many allergic rhinitis patients, when we do any skin prick test, they might be severely sensitized to dust mite, but AEC will still be normal. But on the other hand, higher AECs usually are known to relate, to the severity of the disease, both in allergic rhinitis and asthma. But normal AEC does not rule out allergic rhinitis, okay? And you know that we live in a tropical countries, and there are many more reasons for high eosinophils as in tropical infestations also. Thank you. I think we are quite short and we have taken too much of a time beyond the time that is given to us. Thank you. Thank you very much. Sir, I think I will come there and answer because I think it's already a time.
I thank the organizers, especially the president and the office bearers of Association of Physicians of India for having this session on allergies. I think it has done wonderful information and you all enjoyed it. Thank you.
Thanks a lot. Thank you again for an FPA association. Thanks for considering us.
Okay, thank you, Dr. Gayatri Pandit. You did a very wonderful session. It was very mind-blowing, interacting with dermatologists, pulmonologists.
This is one of the NASA plant, you know. So it is supposed to be air purified.
But NASA ke mere bacteria hogi. How often you use blast too?
We do use.
No, do you use more commonly?
See, among all the second generation antibiotics.
You want to give this to Preeti?
Thank you, sir.
So which is better compared to?
My UT from Tumkur, PG from St. John, sir. Then LSD training from CMC.
So compared to the last time at Fpcon, which do you use more?
Without wasting much time, we'll go on to the next session. We are already running short of time, delay by more than 1 hour. So I request the next speakers to be strictly adherent with the time. It is 25 minutes plus 5 minutes questions. So I request Dr. H.C. Ramesh and Murli Krishna Kore, please come as the chairman and co-chairman for this session. And I request you to take over the session. Thank you. Dr. I think, yeah, Dr. Raghavendra will be the first speaker. You can introduce. You take over the proceedings.
Yeah. Our next speaker is Dr. Raghavendra BK. Dr. Raghavendra BK is a graduate of Mysore Medical College. His post-graduation is in MS General Surgery from Father Muller's, and he has done 2 fellowships, one in liver transplantation from Medanta Medicity in Gurgaon, and the other in BGS Global Hospital, which is in gastrointestinal surgery. His expertise are in complex abdominal surgeries, advanced laparoscopic surgery, colorectal surgery, hepatobiliary and pancreatic surgery. He is the consultant in surgical gastroenterology and minimal access surgery at Sparsh Hospital, Infantry Road. I welcome you, and please take over. Thank you.
Everyone. Thank you, Dr. Murli, and thank you, Dr. Harish, for inviting me to this forum to share my thoughts on one of the most pressing problems that we face today all over the world, is the obesity. At the outset, I would like to thank the Family Physicians Association for giving me this opportunity. So without wasting much time, due to paucity of time, I'll try to make my presentation as concise as possible. So, as I said, obesity is one of the major health problems that the world is facing, and it traverses across the spectrum of the countries, whether it's be the first world or the developing countries or even the third world countries. So my focus would be on obesity causing GI problems. So how do we define obesity? It's quite a challenging to actually define obesity to high accuracy. But I mean, there have been many classifications, but the most accepted one, even by the WHO, is the BMI. Even though it has its fallacies because it does not differentiate the adipose tissue from the fat-free mass like muscle and bone. But still, it is the cornerstone in also formulating guidelines for treatments and managements. So the obesity is, as you know, I think the BMI is weight by height in meter square. So the overweight is between 25 and 30. Class 1 obesity is 30 to 35. Class 2 is 35 to 40. And class 3 or severe obesity is above 40. The other commonly and popular categorization is the waist to hip ratio that many people still follow, and the ideal waist to hip ratio must be 0.9 or less in men and 0.85 or less for women. So, like I said, I mean, each classification has its own fallacies. So, and BMI less than 30 does not mean that the patient is or the person is perfectly healthy. It also depends on the visceral distribution of the fat. Also, obesity is again subdivided into peripheral obesity, which affects more of the hips, buttocks, and thighs, and central obesity, which is around the abdomen, or a combination of both. And type 1 obesity is associated with either excessive calorie intake or lack of physical activity. Type 2 obesity is related to other disorders like hypothyroidism, Cushing's, PCOS. Coming to the prevalence of obesity. So the World Obesity Organization estimates that around 1 billion people across the world are obese. And if you take the BMI classification into the overweight and above category, it comes to almost 3 billion. So it's a very major pandemic and it's a silent pandemic that now people are waking up to. And it causes myriads of disorders. So here, I'm not sure how visible the chart is. So this is a comparison of the increased prevalence from 1975 till, this chart is till 2008. So now out of 1 billion population, it's estimated that 880 million are adults and 159 million are children. So if you see, even the children are now and young adults are having more prevalence of this obesity. So earlier in 1975, 0.7% of the girls had obesity, which is now increased to 6.9%. And with boys, it's increased from 0.9 to almost 9.3%. That's about 65 million girls and about 94 million boys are suffering from obesity. So it is a major pressing problem that needs to be addressed at a global and also a local level. So the causes of obesity, I think you all will be very familiar with. So bad eating habits, sedentary lifestyle habits, poor sleeping patterns, stress, medications like steroids, pregnancy, and medical conditions like Cushing's, hypothyroidism, and genetics. So the non-Hispanic blacks are the most susceptible, whereas the non-Hispanic Asians are the least susceptible. But the prevalence across the races are increasing world over. So these are the different health complications that obesity can cause, ranging from diabetes to metabolic syndrome to osteoarthritis and sleep apnea, depression. So I'll be focusing on the GI disorders that are attributed to obesity. So I'll be categorizing mainly into GERD, gallstones, diverticular disease, non-alcoholic fatty liver disease, which you'll be hearing a lot these days, and pancreatitis and colorectal cancer. So how does obesity impact the GI system? So it mainly has multiple factors. One is the mechanical factor. One is the mechanical, then through the activation of adipokines, through activation of inflammatory cytokines, and increased fatty acid, free fatty acids. And also obesity also alters the gut microbiome. So there is increased production of methane, which can lead to increased risk of diverticular disease. There is also impaired digestion of lactose, which can cause the irritable bowel syndrome. And there is also decreased short chain fatty acid production, which can also impair the integrity of the GI mucosa. So the gut immunity is impacted, which can increase the risk for inflammatory bowel disorders and also the fatty liver disease. So what are the mechanical factors? How does it affect? So it causes increased abdominal pressure. So this is a major attributing factor to GERD, which is one of the most common manifestations of, even overweight or obese individuals. So this because it alters the angle of the lower esophageal sphincter, which causes hiatus hernia and also relaxes the LES. That leads to acid reflux and reflux esophagitis, GERD. Then it also causes chronic low-grade inflammation. So it activates the pro-inflammatory cytokines such as tumor necrosis factor, interleukins 1 and 6. And these play a major role in the development of IBD, NFLD, pancreatitis, and cancer. And obesity is also an independent risk factor for the development of many cancers. This is because of the activation of pro-tumoral factors like insulin and IGF signaling, which are altered, and the adipokines and cytokines, which I'll be dealing with. So what are these adipocytes released peptides or the adipokines? So they play a major role in control of the GI motility. So when that is altered or released, then the GI motility disorders come into play. So these peptides are mainly leptin, nesfatin-1, apelin, and also decrease in the expression of adiponectin. So higher plasma levels of leptin are associated with increased risk of esophageal, colonic, and endometrial cancers because they activate the JAK2 mediated pathway. And adiponectin has inverse relation to BMI. So the higher the BMI, the less the expression of adiponectin. And adiponectin induces apoptosis and inhibits cell proliferation in normal individuals. So a decrease in adiponectin causes increased cell proliferation and it inhibits the apoptosis. This is through the AMPK activation. So coming to insulin and IGFs. So obesity triggers an increased level of insulin and it leads to insulin resistance and also high circulating levels of insulin and IGF-1. This leads to upregulation of signaling pathways through the mTORC1 and ERK pathway, which leads to increased cell proliferation and increases the risk for cancer. And IGF-1 also independently inhibits the apoptosis or cell death. So this in turn leads to increased cell proliferation and disruption in the scavenging pathways. And high serum C-peptide, which is a byproduct of the insulin, also is known to have increased risk of colonic cancer. So coming to the first disorder that's associated with obesity or the GERD, here the abdominal obesity rather than the BMI correlated more accurately with the reflux esophagitis. And chronic GERD or reflux esophagitis over a period of time can lead to increased incidence of Barrett's esophagus or the intestinal metaplasia at the GE junction and LES level. So surveillance and endoscopy becomes very important in detecting this at the early stage so it does not progress to esophageal or gastric cancer. And weight reduction is shown to improve symptoms and also ameliorate the progression to these conditions. And Roux-en-Y gastric bypass is the preferred surgery when patients, obese individuals who undergo bariatric surgery are associated with GERD. The other important condition which is very, very common is the gallstone disease. Obesity causes increased incidence of presence of cholesterol stones because it affects the methylation of the bile, and it also causes increased risk of gallstone related complications and also post cholecystectomy recovery and response to treatment. And it's also known to have increased risk of gallbladder cancer. So the mainstay of treatment for symptomatic gallstone disease is laparoscopic cholecystectomy. And diverticular disease mainly affecting the colon. This is a direct relation to both mechanical factors because of increased intra-abdominal pressure and also because of increased production of methane, and also associated poor dietary factors which go hand in hand with both obesity and diverticular disease, like low fiber diet, low water intake, chronic constipation, which can precipitate this diverticular disease. So this is mainly an extraflexion of the mucosa and submucosal layers of the colon, which herniate through the muscular layers and causes outpouching. So there is a risk of these delicate layers to perforate and cause inflammation or diverticulitis, and perforation causing diverticular abscess, so which can increase the morbidity. So the treatment is mainstay for the grade 1, grade 2 hinges is antibiotics and conservative measures. If there is a diverticular abscess, then you will need to place an image-guided pigtail to drain out the abscess. And in case of free perforation or recurrent diverticulitis, you might need to resect that segment of colon. So non-alcoholic fatty liver disease. So this is a very common thing. You might have noticed that almost 80% of the ultrasound reports that you see would mention some level of fatty liver. So, and this has now become the leading cause for cirrhosis, which is soon to surpass even alcoholism and the chronic Hep B or Hep C as the predominant indicator for both cirrhosis and also for liver transplant. In fact, so much so that when we open up the potential donors for liver transplant, they are rejected because of high fatty liver. So the prevalence is very, very common now. So it's increased. So the incidence of NAFLD is increased almost 4 to 5%, 4 to 5-fold in obese population, and 75% of obese people have fatty liver. This is also strongly associated with insulin resistance and metabolic syndrome. So the accumulation of the hepatocytes and leading to NFLD is a two-hit process. First, it leads to insulin resistance and fatty acid metabolism dysregulation, and the second hit is causing the necrosis, leading to fibrosis and then cirrhosis. So it's very important to detect NAFLD in the early stages because it's reversible. Once it goes to the fibrosis stage, then not much can be done, and it causes irreversible damage. So the important test to indicate this is the fibroscan. It's a non-invasive because ultrasound is not very accurate. Even the imaging like CT and maybe MR with Dixon spectrography is, but it's not commonly available, and a fibroscan is much more economical. It costs about 4,000 to 6,000, and there is a grading where you can detect early steatosis, high-grade steatosis, and then implement the corrective measures. Pancreatitis can also be obesity is one of the causes apart from alcoholism and the biliary pancreatitis. So it causes systemic and paracrine increase of cytokines and adipokines. There's an increased risk of gallstones, hypertriglyceridemia, and diabetes due to chronic inflammation and damage to the pancreas. Also, the severity of pancreatitis is generally worse in obesity, as it's reflected in some of the scoring systems, and also the response to treatment is more challenging. And over a period of time, there is increased risk of pancreatic cancer as well. Obesity is also a risk for colorectal cancer. A meta-analysis of 30 prospective studies done showed that for every increase in BMI of 5, the risk of colorectal cancer increases by 30%, and the risk is higher in men. So again, surveillance programs come into play here, especially colonoscopy, imaging at early stage. Anybody above 40 with high BMI, it's better to recommend a surveillance colonoscopy and serum CEA imaging to detect early colonic cancer or changes and intervene at an early stage. So the management, of course, you'll be knowing that the cornerstone is, of course, the diet and physical activity, behavioral approaches, and pharmacotherapy, now with Wegovy and Ozempic being the star drugs. I won't deal much with it. I think you guys will be knowing more about that. As a gastroenterologist, I'll be dealing more with the bariatric surgery and the bariatric endotherapies. So just a brief overview of the bariatric surgeries. So the US FDA recommends that anybody above BMI of 40 or above 35 with concomitant conditions, medical conditions like osteoarthritis or metabolic syndrome should be recommended for bariatric surgery, because the reversal rate and the ease of getting the BMI down is much more feasible than just diet and lifestyle at this high BMI rates. So bariatric surgeries are classified into restrictive procedures like gastric banding and sleeve gastrectomy, restrictive with some malabsorption like Roux-en-Y gastric bypass, or predominantly malabsorptive procedures like biliopancreatic diversion with duodenal switch. So these are a brief overview of the different types of bariatric surgeries. So the sleeve gastrectomy is one of the most commonly done bariatric surgery. So it's recommended for the class 1, class 2 obese people, and it achieves about 30 to 50% of excess body weight reduction in 6 months. And since it's only restrictive, the associated malabsorption side effects are not there, like vitamin deficiencies and bone density loss. For higher BMIs, the recommended treatment is the Roux-en-Y gastric bypass, which is the gold standard bariatric surgery against which all the newer therapies are compared to. It achieves a very good weight loss of almost 60 to 70% of excess weight in the first 6 months. The only side effects are the malabsorptive consequences are more with this, because you are bypassing a significant amount of the duodenum and the proximal part of the jejunum, which are important for the absorption of many vitamins and minerals. Now there's a modification of Roux-en-Y gastric bypass called the mini gastric bypass. So more amount of the stomach is left behind. So in gastric bypass, only about 20 ml of the stomach is intact, to which the intestine is anastomosed to. And the common channel limb is about 75 to 100 centimeters downstream. So the more extreme form for high grade or severe obesity is the biliopancreatic diversion with duodenal switch. So here you disconnect the duodenum and then you create another anastomosis or channel for the food to go through, and there's a separate biliopancreatic channel. And they both meet at almost 80% after the small intestine has traversed. So there is a bypass of about 80% of the small intestine is achieved. So it leads to very high weight loss, almost to about 80% of the excess body weight. But also the malabsorptive symptoms are more, so it's very important to monitor the vitamin and the minerals, trace elements levels and supplement it accordingly. Nowadays, for people who are not that fit to undergo bariatric surgeries or who want to use it as a bridge for weight loss, there are new avenues of treatment called bariatric endotherapies, where endoscopically there are interventions which are formed. The most commonly popular and upcoming bariatric endotherapy is the Orbera intragastric balloon system. So you just do an endoscopy and then you deploy a silicone balloon which has a reservoir of about say 400 to 600 ml, and you instill it with saline and leave it in the stomach. So it acts as a de facto reduction in the stomach capacity, and it's left there for 6 months. And after 6 months, you again do an endoscopy, you puncture the balloon and take out the balloon. So the advantage of this is that you are not putting the patient through any surgery, and the patient compliance is also much better. The only side effects that we need to keep in mind are severe retching and nausea, which have to be handled with pretty strong antiemetics. There are also other avenues like putting a peg and doing serial aspirations after every meal. And there is the endoscopic sleeve gastroplasty, which is upcoming. So before I conclude, I would like to point out that here the family physicians play a very important role in mentoring and consolidating the myriad specialities that are required to handle obesity. It's not just about one specialist or one surgeon. It requires a clinical nutritionist, a psychologist, an endocrinologist, an orthopedician maybe, gastroenterologist. So everyone need to work as a team to give a good outcome to the patient. And here the family physicians can play a very important role in mentoring the patients, because you are the first point of contact and guiding them to the right path of treatment. Because now you see in the media everybody promises weight loss, and some of them are quite dangerous. So it's very important that we as a medical community show the right path to the patient and somehow overcome this pandemic. Thank you.
Just a quick question. What's the bariatric endotherapies where you put in the silicone?
Yes.
Right? So
That's called Orbera. So it's devised by Apollo Endotherapy Systems. So it's a silicone balloon. So you do an endoscopy and you deploy the balloon through the endoscopy. Initially, you need to do a check endoscopy to make sure that the patient doesn't have ulcers. And then you deploy the balloon and you instill it with saline to inflate it. So what happens is it decreases the effective reservoir capacity of the stomach without doing the sleeve. So the sleeve is also achieving that. So here, without any intervention, you are achieving decreased reservoir. So it achieves very good satiety rates, and it has shown to decrease the excess body weight by about 20% in the first 6 months.
Yeah, thank you.
And it needs to be, it's reversible also. So after 6 months, you need to take out the balloon.
Do we have any other questions? We have time for one question. No? All right. Thank you.
Thank you. Thank you.
Thank you, Dr. Raghavendra. It was an excellent presentation. Thank you very much. He works with Dr. Vikram Balyappa at the Sparsh Hospital, who's also a gastrointestinal surgeon, liver transplant surgeon. Yeah, they have a medical gastroenterologist team as well. Okay, we'll move on to the next speaker, Dr. Srihari Deshmukh, consultant medical gastroenterologist. I think the chairpersons will introduce.
Dr. Srihari Deshmukh is a consultant gastroenterologist at Sparsh Hospital, Bangalore. He did his MBBS from Ramaya Medical College, MD from Sardar Patel Medical College, Rajasthan, super specialist in the field of gastroenterology by doing his DNB from Manipal Hospital, Bangalore. Dr. Srihari has many publications to his credit and has presented several papers in national and international conferences. He has a rich experience as a consultant in the field of gastroenterology and hepatology. His clinical interests include EMR, motility disorder, and endobariatric therapy for weight loss. He is going to talk about the new therapy for GERD. Over to you, Dr. Srihari.
Hello. Yeah, good evening all. I would like to thank Family Physician Association for giving me this opportunity to talk on GARD. So one of the most common conditions we come across, each and everyone, cardiologist, gastroenterologist, physicians, everyone. So basically, first few slides I'll be talking about the basics of GARD. I'm clear, right? I'm audible, right? Yeah. So GER is a physiological process. GERD is a pathological condition. So it develops when reflux of stomach contents causes troublesome symptoms and complications. Here, complications I mean by stricture, bleeding, and ulcerations and dysphagia. So why do we get GERD? There are two things. There are few factors which protect us from having GERD. There are few factors which gives rise to GERD. Protecting factors are anti-reflux barriers, esophageal acid clearance, tissue resistance. Factors refluxing from the stomach actually gives rise to GERD, that is gastric acidity, volume of gastric juice, duodenal contents. Anti-reflux barriers are angle of His, diaphragm crura, lower esophageal sphincter. These are all the anti-reflux barriers. So basically, most of the patients who have GERD have all these findings. That is weakened and shortened LES. The normal LES is around 4 centimeters. In few people, in a GERD patient, the length will be much shorter. A loss of diaphragmatic support for the LES. Loss of intra-abdominal LES segment, that is hiatus hernia. There is something called retention of gastric juice in the hernial sac, that is called acid pocket. Stretching and rupture of the phrenoesophageal ligament, widened gastrodiaphragmatic hiatus. These are all the risk factors which leads to GERD. What are the clinical features? Classical symptom is heartburn. Basically, the occasional heartburn, as I told you, can be physiological. If it is 2 or more in a day, and it is affecting their day-to-day activities, that is called GERD. It is aggravated by large meals, spicy food, citrus, fatty food, chocolate, and alcohol. It is 89% specific, 38% sensitive. Other symptoms are acid regurgitation. Few patients can have dysphagia and duodenophagia because of ulcerations. Water brush. Few patients, they complain of watery mouth, that is sudden appearance of slightly sour or salty fluid in the mouth. Burping, hiccups, nausea and vomiting. These are all the GI symptoms. Coming to the extra esophageal manifestations, they can have chest pain. Chest pain is mainly because of the reflux esophageal spasm because of the acid reflux. Asthma. Asthma can be because of two things. One is microaspirations. Second is vocal cord spasm. Laryngeal inflammation leading to change in voice and global sensation. Posterior laryngitis, vocal cord ulceration, granulomas, and leukoplegia. If a patient has obese, large hiatus hernia, they can have nocturnal GERD leading to sleep disorders. So how do you diagnose GERD? GERD is purely a clinical diagnosis. You don't need any tests to diagnose GERD. One more thing is retrospective diagnosis. Retrospective diagnosis in the sense you give gastric medicines, patient feels better, so that means he has GERD. So it's a retrospective, or it's a basically a clinical disorder. So why do we do endoscopy? I'll be telling you shortly. So endoscopy, the sensitivity is very less because most of the patients have something called NERD. NERD is non-erosive reflux disease. But if erosions are there, especially grade C, grade D, that is almost 100% specific. In few patients, they can have only edema and erythema in the lower part of esophagus. So when do we do endoscopy? Endoscopy is done when there are symptoms like this: dysphagia, duodenophagia. Patient has alarm symptoms like more than 5% body weight in the last 6 months. When there is evidence of anemia or GI bleed, When you do some imaging, there is a mass or stricture or ulcer. Male patients more than 50. For screening for Barrett's, we do endoscopy. Patient has persistent vomiting for more than a week's time, we do it. And before we do any interventions, we do endoscopy. And before doing 24-hour pH metry, we will be doing the endoscopy. These are all the proper indications. But yeah, one more indication which I have missed out here is age. Guidelines say more than 50-55 years, but here in India we consider around 40. 40 is the cutoff what we take, the gastroenterology. Most of us take 40 years. Less than 40 we don't do upfront endoscopy. More than 40 years family history, the threshold for doing endoscopy is very less. So as I told you, there are we classify the erosions into 4 categories, A to D. This is Los Angeles classification. LA A and B are not very specific for GRD. LA A is the mucosal breaks less than 5 millimeters. LA B, that is right upper which is more than 5 millimeter mucosal breaks. The lower, the left and the right, it is C and D. C and D are very specific for GRD, where the mucosal breaks are more than 5 millimeters, and it can occupy up to 75% of esophageal circumference. Here it is more than 75 in D. So routinely we don't do biopsies. Biopsies are done in 2 conditions, basically to rule out Barrett's. Second is there is one condition which mimics GRD, that is eosinophilic esophagitis. Here what happens is, because of the reflux, the esophagus will become very sensitive to the acid contents, and there will be increased in the eosinophils in the esophageal mucosa. Usually in a normal patient there won't be any eosinophils. Up to 7 in few patients we can consider. Between 7 to 5 is eosinophilic esophagitis. More than 15 is significant. We do something called 24-hour pH metry to diagnose in few patients of GRD and in patients with refractory GRD. In this, what we do is we pass a small tube through the nose. We keep it in the esophageal mucosa, 5 centimeters above the G junction, and we keep the probe for 24 hours. Here we measure a few things. That is how much of acid is there, that is acid exposure time, number of reflux, duration of the reflux, a number of episodes greater than 5 minutes. Manometry, we usually don't do it, but it is done prior to doing 24 hours pH metry. Coming to the treatment aspect, first thing and foremost is lifestyle modification. Lifestyle modification has to be followed, without which patients will keep coming back to you. Otherwise, when you give medication, they'll be okay, but off medicines, again, the recurrence will be there. So I insist all my patients to follow these things. Elevating the head of the bed, losing weight. Obviously, Dr. Raghavendra spoke, obesity, especially the visceral obesity is a risk factor for GRD. So especially Indians have the propensity. We have, compared to Western population, we tend to accumulate weight in the center part of our body. Restricting alcohol and smoking, making dietary changes. As I told you, citrus, spicy, fatty, chocolates, alcohol, all these things contributes to GRD. Refraining from lying down immediately after meals. At least you need to give at least 2 to 3 hours prior to bedtime and the dinner, because most of the gastric stomach content would have entered into the intestine. Avoiding bedtime snacks. So how do we approach a patient who comes with typical symptoms? So typical symptoms, as I told you, we don't do any investigations. You give a trial of PPIs. Once, if they show response, you continue PPI for 4 to 6 weeks time, then stop. That is what we do. If patient has atypical symptoms like belching, So belching can be a symptom of pure GRD, or it can be something called supragastric belching. What is supragastric belching? You swallow air and you release air. So that is a psychiatric condition where they keep swallowing, then they'll be releasing. That is called supragastric belching. For that, you need to do 24-hour pH metry. When you do 24-hour pH metry, what you see is, in 24 hours pH metry, what you see is there are 3-4 parameters. Basically, you see what is reflexing. Is it the air or is it a liquid? Second, is it acidic in nature or alkaline in nature? In supragastric belching, mainly there will be air which will be reflexing. It might be acidic or it might be alkaline. There won't be any liquid which is reflexing. So when it is more of air which is reflexing, it is supragastric belching. When there is air combined with liquid, that is usually GRD. When patient has atypical symptoms, most of the times when they have a large hiatus, they'll be consulting ENT specialist, pulmonologist, physicians. They'll be giving steroids, local inhaler steroids and all. They'll have only partial relief. But when they give PPI, they get good relief. That's when they refer it to us. That time, so primarily we need to evaluate to rule out pulmonary conditions. If with PPI, if patient is responding, the cough, everything is getting better with PPI, obviously you need to see if there is any GRD component to it. Then other things atypical are global sensation, abdominal pain. So first we need to rule out local conditions, then evaluate for GRD as well. So one of the promising medicines which is there in the market is PPI. As I told you, give it for 6 to 8 weeks time. Most of the patients, they respond well to PPI. So many people ask me if there are any differences between the PPIs, pantoprazole, esomeprazole, rabeprazole and omeprazole and all. Usually more or less everything is same. If there is any difference, it is more of a placebo thing, psychological thing. But compared to pantoprazole and esomeprazole might be better because it is not metabolized through CYP2C19 pathway. One more thing is omeprazole you can't be used when, especially in elderly, if patient is using clopidogrel. So pantoprazole is the ideal medication. So basically this is a parietal cell. Here it is, the color combination is not good, so the pink color is not there. I think in the TV it is much more clear. The parietal cell, here there are two things. One is PCAB, which I'll be talking later. The PPI. So whichever PPI we give is all prodrug. What is a prodrug? It's an inactive medicine. It has to get activated after it gets activated within our system. So PPI, when you take in an inactive form, in the acidic environment, it becomes active. So it binds to H plus potassium, hydrogen potassium ATPase covalently, and it blocks the channel and H plus is not released. So this is the mechanism of action. PCAB, I'll come back to this slide again. What PCAB is, I'll tell you later. So coming to the side effects of PPI, theoretically, there are many side effects, but clinically, we don't see these side effects much often. Fundy gland polyps, we do see. Other things, enteric infections, interstitial nephritis, those things are not so often, but yeah, theoretically, we should be knowing all these things. Community acquired fundy gland polyp is basically because of hypergastrinemia. Community acquired pneumonia, enteric infections, spontaneous bacterial peritonitis. So patients with immunocompromised patients like cirrhosis, so we should use judicially, we need to use PPIs. There will be absorption of calcium, B12, magnesium and iron can be impaired. Acute interstitial nephritis and interaction with clopidogrel, as I told you. So there are other medications. These are all more of add-on therapy rather than primary therapy. This is prokinetic drugs. Prokinetic drugs basically helps in increasing the LES pressure, helps in acid clearance and gastric emptying. This I usually use it when patient is obese, elderly patient, diabetic patients. So metoclopramide, domperidone, these things are used. It's more of an add-on rather than primary medicine. One more thing is GABA B agonist. So basically, when patient has weak acid reflux, when there is hiatus hernia, to tighten the junction, we use baclofen, 5 to 20 milligram TID. One of the side effects is drowsiness. So in elderly patients, we need to be really careful when we are giving higher doses. So one of the effective options for refractory, basically it helps in tightening the G junction. H2RS, nowadays we don't see many doctors prescribing, but I feel it's a very wonderful medicine, very cost effective medicine. I still use Rantac in many patients because it's only 50 paise or 1 rupee each tablet compared to other PPIs. PPIs usually acts for around 16 to 18 hours, max 20 hours. So nighttime patients have GRD symptoms. So in these patients, elderly patients, large hiatus, obese patients, I use H2RS for evening dose before dinner time, 300 milligram Rantac, Ranitidine. So this is the new medicine which is there, potassium competitive acid blockers. This it has come to India very recently, but in Japan, in other East Asia, it's been there for more than 10 years. The one which has come to the India is vonoprazan. So basically, it has similar action to PPIs. So basically, it is a reversible binder. Reversibly, it binds to hydrogen potassium ATPase enzyme. Compared to conventional PPIs, it is not a pro-drug, it is an active drug. So it doesn't have to get activated after ingesting. So PPIs, we usually give it before meals, because before meals only the parietal cell gets activated. That time acid is being produced, that time this PPS gets activated. Here you are giving an active molecule itself. So independent of meal time you can give. That is one advantage. And full effect from first dose. What do you mean full effect from first dose? PPIs, on the other hand, let's say you start giving today, the full effect you see it only after 4 to 5 days, like aspirin, few other medications are there. You get it only after 3, like BP medicines and all. You see the effect, the full effect only after 3 to 5 days time. Similarly, PPIs take 3 to 5 days time, whereas PCAPs, they start acting on day 1 itself. Longer half-life. So usually nocturnal breakthroughs will not be seen in PCAP. And it has CYP2C19 independent pathway. So basically in Caucasians in Western population, almost 70 to 80% have CYP2C19, they are rapid metabolizers. In Asia, India, Southeast Asian countries, only 30% are rapid metabolizers. What do you mean by rapid metabolizer? You give 40 milligram pantoprazole, the duration should be for 18 hours. But if it's a rapid metabolizer, the duration will not last that long. So that is what I mean by rapid metabolizer. So because this PCAB is independent of this, so even if the patient is rapid metabolizer, the effect is the same. What are the therapeutic indications and recommended dosage? It can be used in all these conditions. That is GRD, vonoprazan 20 milligram once a day for 4 to 8 weeks time. When you compare it to the other medications, 20 milligram vonoprazan is equivalent to 60 milligram omeprazole given twice daily, 60 milligram omeprazole. That's the comparison. Gastric ulcer, 20 milligram vonoprazan once a day for 8 weeks. For ulcer disease, 20 milligram for 6 weeks. So when you are giving along with NSAIDs, you give it 10 milligram once a day for 8 weeks. So it can also be used for H. pylori eradication, that is amoxicillin, clarithromycin and vonoprazan. You use 20 milligram. Coming to the adverse effects, main thing is hypergastrinemia. Compared to PPIs, the gastrin levels are much higher compared to patient who is using PPIs. Similar to PPI, it interferes with nutrient absorption because acid is not there in the stomach. Because acid is not there, again, increased risk of enteric infections, kidney disorders. These are all the side effect profile is more or less similar to PPIs. Coming to two categories, that is children, pregnancy and breastfeeding people, breastfeeding mothers. In children less than 18 years, not much studies has been done. Same thing with pregnancy. It is still not proven. So for pregnancy, omeprazole, pantoprazole can be given. And for breastfeeding mothers, better to avoid because the safety profile is not very clear. And not to breastfeed. Not to breastfeed for at least 2 days after stopping. Like let's say you've stopped the vonoprazan today, you can start feeding 2 days after stopping the vonoprazan. So, so any ERD patient compared to a placebo, multiple studies has been done. So it is definitely superior to PPIs as well as placebo. So it's a very busy slide. I don't know whether you can see it or not. It's a very, I tried to concise it in one slide itself. Very small font. So basically, I'll just tell you the gist. So it's basically how to approach a patient. If it is a unproven or a proven GRD. So if it is a proven GRD and patient is not responding to PPA, that's what I mean this side. So you do all the things, that is endoscopy, 24 hours pH metry. If there is no ongoing GRD, consider other conditions. Let's say you have given PPI, patient is still having GRD symptoms. So you have done endoscopy and pH metry. Everything has come clear. Still if he is having GRD, then consider other conditions like functional heartburn, reflux hypersensitivity. That's what you need to consider. Let's say you have given, coming to the last column, I'm saying the red color column now. You have proven GRD, you have given PPIs, still symptoms are persisting. So that time when you do esophageal pH metry and endoscopy, if there are reflux symptoms, that means the medicine what you have given is not enough. So that time what you have to do is you need to advise the patient on diet and lifestyle if he is not following. Then try to optimize the PPI dose. If he is taking only once a day, try to take, tell him to take twice a day, higher dose, or changing the molecule, changing the brand. Few times it helps. And specifically the patient, no, they don't take it properly. When we say empty stomach, they take the medicine at 7 o'clock and they'll be having breakfast at 9:30. So they'll not really understand the meaning of empty stomach before meals. Before meals means they have to take it half an hour before meals. It's not like thyroid tablets. Thyroid tablets, empty stomach means you have to take it at 7 o'clock irrespective. Here before meals means 30 hours before meals. So timing the PPI, timing the POCAPs also helps. So other things, add-on medications you can try, that is sucralfate, baclofen, alginates, those things you can do. And if any of these things are not working, then you need to counsel the patient for interventions. Interventions, I mean endoscopic as well as surgical interventions. In endoscopic interventions, there are multiple techniques. So this endoscopic intervention was founded few years back itself. Initially, what they were doing was endoscopic anti-reflux mucosectomy. So they were like ESR and EMR, they will removing the mucosa. So nowadays, what we do is something called ARMA, that is anti-reflux mucosal ablation. What we do here is, it's like a horseshoe, we burn the area. So basically the principle is you burn the area, when it is healing, it will heal with a scar. Sorry? Okay. So basically what we do here is we burn the tissue in the horseshoe pattern around 1 centimeter. You can see this along the 1 centimeter along the greater curve. Along the greater curve, we leave an area, 1 centimeter area, and from the scope also around 1 centimeter area we leave, and 270 degree we burn the tissue. How do we burn? We burn using APC, that is argon plasma coagulation. Very simple procedure. It takes only half an hour, 45 minutes to perform this procedure under general anesthesia. So basically when we, okay, already half an hour, 25 minutes. Okay. So basically we burn this area for another 2 minutes, that's all. So we burn this area. When it heals after a few weeks time, it will cause narrowing. Other things what we can use the rubber band ligation. The EVL what we use for esophagoviruses, same thing we can use. There is something called TAF. It is a endoscopic counterpart of laparoscopic fundoplication. This Strata procedure is there. Strata procedure, basically what we do is we give radiation energy, radio frequency ablation to the LES. When we give radio frequency ablation, there will be scar tissue formation. When scar tissue forms, it acts like a the junction will become more tight. So surgical therapies, laparoscopic anti-reflux surgery is a well-known thing, Nissen fundoplication. There is something called magnetic, this is last few slides, magnetic sphincter augmentation. So basically what it is done by surgeons, it is laparoscopically done. So basically what we do is we place titanium beads along the GE junction. When patient is not eating, when it is at rest, it is like this. When you swallow, when the bolus enters the GE junction, it expands. There will be self-expansion, which will allow the bolus to pass into the stomach. So take-home message, symptoms of refractory GRD do not depend only on the presence of actual reflux, but also on other factors like reflux hypersensitivity and functional, that is functional disorders. First-line therapy should always include a thorough reassessment of dietary and lifestyle factors, reiterating correct PPI timing and dose modalities. PPI therapy should always be titrated to the lowest minimal effective dose after 4 to 8 week full dose therapy, in order to prevent potential long-term side effects. Sucralfate, alginates, mucosal protective agents together with GABA-B receptor agonist, it can be an effective option if there is persistence of non-acid or weakly acid reflux. If there is gastroparesis, kindly add prokinetics. If patient has functional disorders, along with PPI, use tricyclic antidepressant and SSRIs. So when medical therapy fails, surgery is always there. Endoscopic and surgical therapies are always there. Thank you.
Presentation, and thanks for introducing us to the new drug. So any questions? One question we can take up. Yeah.
Regarding new molecule vonoprazan,
can I answer this and then?
Do you have enough experience about this molecule, or can we change over from PPI to this molecule? Because PPI has ruled for almost a couple of decades, and this seems to be going to be bombarded from all sides for us and from the industry. About 100 people are waiting in the list. So as a physician, as a gastroenterologist, should we change over? Do you have enough experience about this molecule?
Sir, to be frank, more than practical knowledge, I have more of theory knowledge, because in India we got to know only a few weeks back. So I've used it in a few patients, 3-4 patients, and they have given very good response. Theoretically speaking, yes, it's definitely much better than PPI. New molecule comes and goes. Probably this is here to stay. It is not unlike other molecules. I feel it is going to stay, sir. It is definitely going to stay. If you ask me if it is better than PPI, only time will tell. But if you ask me personally, based on other country theoretical knowledge, if you ask me, it's going to stay, sir. Definitely. Coming to, Madam has asked for levosulfuride. Ma'am, better to avoid. I don't use levosulfurid at all. It is not, personally, I don't use it. I use etopride, much safer compared to levosulfurid, because patients, no, even if we say take it for limited time, 2 weeks, 3 weeks, patients, they get good relief and they continue to take it. They come back with us with extrapyramidal symptoms. So I tend to avoid levosulfurid at all. As in altogether I avoid, ma'am. So alginates, yeah, alginates you should use it. I use alginates rather than sucralfate, because sucralfate, it acts only when in alkaline pH, acidic pH. People tend to use sucralfate along with PPIs, which is theoretically it is not correct, because again sucralfate is like more of a prodrug. Do not use it with PPIs. Alginate, on the other hand, definitely can be used with PPIs. Definitely, like for immediate relief, alginates is it's a very wonderful combination. Yes, sir.
Thank you, Dr. Shri.
We conclude the session. I think request chairpersons please honor Dr. Shri Hari Deshmukh, President. We'll move on to the next topic for this session, the last topic for this session, and then we have one more session, session number 4 going on. I request Dr. Syed Imran to come, but before that I request the chairpersons to introduce Dr. Syed Imran, orthopedic surgeon, Manipal Hospital, Millers Road.
It's a privilege to introduce Dr. Syed Imran. He's been a friend. We share the same classroom in college. So welcome, Dr. Syed. And it's a happy coincidence seeing you. Yeah. So Dr. Syed he's done his MBBS and DNB orthopedic surgery. He's a fellow in joint replacement as well as in joint revision replacement in Germany. And he's currently a consultant orthopedic and arthroscopic and joint replacement surgeon at Manipal Millers Road. Right. So a few points which he has, he says that he is committed to professional. He's a professional who prioritizes the needs of his patients above all else. Well, he possesses extensive expertise in diagnosing and managing complicated procedures. He has received specialized training in Germany, which is the highest volume center in Europe. He has over 10 years of experience in joint replacement surgeries. Dr. Imran is adept to latest technologies and safe surgical practices. His dedication and passion in these areas of interest contribute to achieving excellent clinical outcomes for his patients. I think knowing him personally, I would definitely say the first point is really true and sincerely put there, where being a committed professional who prioritizes the needs of his patients above all else. Welcome. Over to you.
Good afternoon, everyone. And thank you, Dr. Murli, for a lovely introduction. It was a pleasant surprise seeing you too. So, okay, what is my topic is, I will be speaking to you about robotic joint replacement. This is the new buzzword in orthopedics. The new buzzword in orthopedics everywhere has been robotics. Okay, so it is all about robotic joint replacements. So coming to robotic joint replacement, is it something new? No, honestly, it is not something new. It has gone through a complete transition. So when we look at technology in orthopedics, what started in 1950s, what we used to do before doing any joint replacements was we used to have these sheets wherein we used to template it, and then went on to navigation, and then there was and then there was navigation, and then finally the robotics. This presently is the ultimate tool for doing joint replacements. Now, okay, there are many robos. The robo what we have in our hospital is called a Stryker, and the implants whatever we used, they are collaborated with that. Specified to that robo. So we will be using all these Stryker implants which are compatible with our Stryker robotics. So when we look at these number of joint replacements that are happening, if you look from 2007, 2007 is a US data, not an Indian data, and when we look at it, there has always been a rise in rise in the robotics market. So, and is robotics, does it really add cost to it? Definitely when we look at many things, and I will show you a few slides as I go on, it definitely adds cost and value to the patient. So now what is a robotic? So when I say robotic, the first impression everybody has is a robo will be doing a surgery. Honestly, it is only a robotic arm assisted. So this is a robo, this is the arm which comes. This will be what will be guiding us into doing the surgeries. So the robo itself will not do the surgeries, and even let's say if 2 robotic surgeons are doing the surgeries, the results will still be different because it is still the surgeon at play. So this is the advantage. So, okay, how does a robotic work? So unlike conventional, when we do a robotic surgery, first we take a CT scan. A CT scan is processed. A CT scan is taken 1 day prior. The CT scan is fed into the robotic system. The robo makes an images, and then it comes back with this data, which we can kind of like change, calibrate it. We can change the way we want to place our implants. So, and when we look at a robo, what we have, it has got over 14 years of experience. So basically, it's a very reliable robo, and it has a history, and it has stood the test of time. So right now, the robo what we have in our hospital is can do about 3 applications. The 3 applications are partial knee replacement, a total knee replacement, and a total hip replacement. Going forward, I think it will also be, they're trying to add a shoulder portfolio to the same thing, and also a revision portfolio to the same robo. Now coming to a partial knee replacement. Okay, I'll just show you a video so that I think we can save a lot of time on this. What exactly happens in a robotic joint replacement? So it's a small video. I'll make it quick. So this is about partial knee replacement. I'll only show you the workflow from the robo point of view. Let's skip all this. Okay, so this is what really happens. A CT scan is fed into the system 1 day before the surgery, and then we get data. So the data we get on table is the patient's data, which is kind of like templated, and then the robo creates a virtual model. So what for a partial knee replacement? So we come up with these green areas. So these green areas is the region where the bone has to be cut. So this bone, we can change, the robo allows us to change, we can change whether we want to change the implant positioning here and everything. This happens intraoperatively, wherein we have to basically, if you look at this, these points have to be corresponded with the patient. So the patient collects the points, what we feed on this one. So if you see, there is already a system, so using this handle, we have to collaborate exactly these points, so that we are in sync with the robo. So these points are marked on the patient, and then these are the points which are marked on the CT actually by the robo, and then this is our saw. And if you look at it, this is the first time when I'm doing the surgery, I'm not really looking at the patient, I'm looking at the monitors. So I have to look at the monitors to see if this green area is being cut. So once you cut more of the green area, it becomes red. So we have to just ensure that we are cutting only the green area. The advantage with this robotic system is, let's say if my saw blade goes outside the green area, it will not allow me to cut. So it's called as an haptic stop, wherein the robo will not allow me to cut more than what is intended and what is planned. So this is about the robotic, just a small video about it. Now coming back to the papers which say it. Okay, this is what is a partial knee replacement, what I just talked to you about. Okay, where does the robotics play an important role is? Okay, generally these partial knee replacements, wherein we are replacing only a part of the knee, is a slightly demanding procedure. So there used to be a revision rate of almost 25%, but now it has come down. Okay, when you look at this kind of like data, when you look at the partial knees done using the robotics and versus the conventional knee, and the percentage of knees, definitely it is constantly increasing. And then if you look at the final conclusion, it says it shows more accurate delivery of the surgical plan, and the implant can be put in less than about 2 degrees of what is really actually planned. So again, when you look at the pain scores, see if you look at the pain scores, this the top one is conventional knee, conventional surgeries. This is the robotic surgeries. So the robotic surgeries are definitely less painful. But again, when you look at 90 days, I mean, they flatten out. It is the same. So, I mean, the question that comes to your mind is, just for the sake of initial pain relief, is it worth spending so much? But it is just not the pain relief. Again, when we look at the revision rates, I mean, revision rates is a surgery failing and we having to redo the surgeries. Even the revision rates are much, much lower. Again, when you look at this, okay, the surgery is done using robotic. They have a revision rate of quite low of less than 3. They have a revision rate of quite low of less than 3%, which is a good value. So two advantages with a robo: reduces pain and gives you much better results. Let me skip through these. Okay, and then again, when it says there is more accurate placement of the implants using robotics, definitely less pain and 97% survivorship and 98.5% registry survivorship in the first year. Now coming to again the hip replacement. Okay, this is really a beautiful thing. I'll just show you again a very small video. This is again less than a minute video as to what really happens in the hip. So the patient is positioned and all. So again, same, the CT scan has to be fed into the system. One day, I mean, the CT scan has to be fed into the system at least one day before. The robot templates it, gives us a surgical plan like this as to what exactly has to be done. We can eliminate the femur, and this is where the acetabulum has to be put. The green area is where the acetabulum has to be cut. So okay, so again, this entire thing will be controlled by the robo, and it gives us a live angulation as to, suppose we change the angle, it tells me whether I'm going 5 degrees forward, 5 degrees backward, whether my cup is going inclination up and down, and how deep is my cup going. So this is exactly what a robo provides me with. It's a real-time data, and even when I'm actually implanting it, even with say with a hammer, there are still the sensors around it which will tell me whether I'm able to whether I can go one. It gives you a millimeter specific kind of a thing, and so the longevity and all increases with this. So this is the robotic arm, the same robo, we just have to change the attachment onto that. Now, okay, let me come back to my PowerPoint again. Okay, so again, when we look at the data again, okay, why is hip replacement important is the chances of, people who would have a hip revision are aseptic loosening, osteolysis, wear, instability, infection. These first three things are surgeon dependent actually. So infection is not surgeon dependent and fractures are not really surgeon dependent. So these three things can be controlled by a robo, so it gives you a much better precision. So, okay, this is a small area wherein, okay, when you look at this square box, this is where the ideal cup position should be in a hip replacement. When you do a manual, if you see, I mean, you have the greens all over the place. There are many things which are outside the box, no matter what the experience of the surgeon is. But when you use robotics, since it gives you the real information, you see most of the blues are within the box, which says it helps us in providing us with the accurate placement. So again, once you can do the accurate placement of the implant, definitely the longevity is better, and the survivorship of the implants are far better. So okay, this is again just the same paper which says what we had planned and what we achieved. If you see, it is almost very close to what our intraoperative planning and postoperative planning is. So there is maybe less than one degree of change between the plan executed and finally the post-op X-ray. And one advantage even with a hip replacement is it will allow you to judge the length. So that, I mean, one of the common thing in hip replacement is patients can have a leg length discrepancy. But with robotics, the limbs can be matched to just perfection. Okay, so this was a very interesting paper by one of the guys. First, he puts his first 100 hip replacements he had done, then the last 100, and the first robotic assisted to see where he lands in the box. So his first 100 hip replacement, if you see, many of them are outside the box where the implant should be. The last 100, many are there, but you can still see a lot of reds outside the box. But if you look at his own robotic thing, you can say almost 90% is hitting the box. when I say hitting the box, what it means is we are able to implant it more accurately. So, I mean, the final results, when I have to tell you, so robotic arm assisted surgeries demonstrated higher modified scores. So the blood loss is lesser, the robotic arm improved. I mean, like I told you, gives you much better leg-length discrepancy and all these kind of, all the parameters which we are trying to aim to control, all of these are much better with it. Okay, and then this is the paper which says ki, even the cup what we put, the amount of bone we remove when we use robotic is much lower than manual. So okay, so finally, the overall, if I have to say, robotics definitely does come with its own set of advantages. The most advantages is lesser pain, better, I mean, faster function, longer implant life, and everything. I mean, for me to stand on the podium and to say, okay, I have done almost 10 years of conventional surgeries, and when the robo was introduced to me, say about 5-6 months back, even I was really very skeptical about it. Should I be changing the way I'm doing it? Because okay, I have done my own ways for almost 10 years and I have given good results. So that is when I started using it and I found really good results. Now I can really say that almost 50% of my replacements work is going robotic. It is really a wonderful tool. For someone who stands having done 10 years of conventional, to make a statement like this is definitely it was heavy even on me, for me to accept that to give somebody else the credit. It took me quite some time to adapt to it. So finally, definitely, like I told you, it gives you much better acetabular components. So it is a short term and much decreased length of stay. And then I'll just show you 2 videos of, this is my own patient, done knee replacement. This is day 1. See, if you can look, she can lift her leg up directly on day 1. When she can do this, it means her quadriceps is working really well, and she can walk almost very comfortably. So now this is again the same patient. Okay, first see, she'll do a normal leg. This is the normal non-operated leg. She's got a straight leg. The left leg being the operated leg. See, she can lift it almost to the same level of extent, which means to say our muscle cuts is much lower in a robotic. So the recovery and all is much faster. So this is just one quote of the robotic, what happens. Okay, if you look at this, okay. So this is my pre-operative, this one. If you look at the joint space here it says 13, 18, 13, 18, which means to say medially I'm tight. If you look at the image also, here the knee before the surgery is medially tight, basically a varus knee. So post surgery, this is what we are able to achieve, a varus degree of less than 2 mm. So we are able to get almost everything to less than 1 mm of perfection, just the way we want it. And I mean, the patient video what I saw is of this patient. So basically with robotics, we are able to recreate the matches, recreate all this, and plus we get that real-time data. For example, okay, even when I'm doing conventional, I really don't know what it is. It is more based on feel. But here, I really know these numbers. Based on the numbers, I can still change it to balance the whole thing up. And before I finish my talk, I'll show you one more last video that I've been doing from quite some time. So now what I've added is I've added something called artificial intelligence in my physiotherapies. So basically what it is it is basically a remote physiotherapy. So let's skip the introduction by the patient and all that. Yeah, so yeah, I'll just pause it. So yeah, so this patient, normally at the time of discharge, I send the patient home with the device. If you look at this, there is a sensor attached there. There's a sensor attached to the thigh. And here, if you look at this data, it says ki, this is 100% we have to achieve. How are we going to achieve it week on week? So I mean, so these sensors basically record when the patient extends the knee, when the patient bends the knee, it really records whether they're doing it properly or not. So if you look at this, see, we started from 39 degrees and we have been able to achieve almost at 135 degrees of a normal thing. So this is the new thing that I'm kind of like incorporating, and it is giving me results. Okay, one more advantage that happens with this is since the patient is getting the real-time data, so the patients are also motivated. Okay, I'm 10 degrees lower today. Let me achieve that 10 degrees. Okay, today my movement is much less, so let me get that better. So I finally, to end it with, robotic is definitely it's a very nice tool to adopt to. Presently, the only deterrent to it is maybe a little cost, a little on the higher side, but beyond that, it is worth that cost. Some insurances accept it, some insurances don't accept it, but it's a beautiful technology to make the patients feel better. With this, I thank you all for listening to me, and thank you for giving me an opportunity to speak. Thank you, everyone.
Yeah, any questions? Thank you, Dr. Syed Zimran. We hear a lot of robotics and the precision that it brings to the surgeon and how much it helps the surgeon. But sometimes we even hear of the failure of robotics where it has been very difficult to repair on the table. Mm-hmm. Are there any such cases, or is there any need for any concern that you need to think about these things, or these are just random things?
No. I mean, nothing is random. See, with science, no science is perfect. Everything is bound to fail. Okay, even with robotics, okay, are there disadvantages to it? Definitely there are disadvantages to it. Okay, I agree, I concentrated to you only on the advantages. Okay, so what are the disadvantages of robotics? Okay, one is maybe a slightly longer operating time. And plus you need to put 2 extra pins as trackers that have to be done. In less than 1% of a chance, there can be a fracture at those points. And sometimes while doing the surgery, in case if one of the pin becomes loose, then you are kind of like in a messed up situation. So you have to redo the whole thing again. So I mean, like, no science is perfect. Everything is always an improving science.
Thank you.
The software fails, then you have to go into it.
No, manual. Yeah, that's why 10 years I have conventional.
Conventional is conventional.
Yeah, true.
Technology is technology. Gadgets cannot overtake human beings.
Yeah, that
is true. Okay,
Thank you so
Dr. Imran. Very short and excellent detailed presentation. Murli and Ramesh, you can come and honor your classmate, Murli. Yeah. Thank you. So I now request the President to honor Dr. Ramesh and Murli, Chairperson, Co-Chairperson. Take this seat. You stay in Fraser Town, huh? Auntie Nagar. Good, thank you. Thank you, and I think Murli also was glad to meet his classmate today, and I was glad to meet my neighbor in the morning. So it's very good to meet each other when we don't see each other also. I think Preeti agrees to that. Yeah. So now the last session for the day, session 5. I request Shivanna TK and Dr. Prabhakar to please chair the session, and the first speaker is Dr. S.M. Prasad, Professor of Pediatrics, and to introduce him, Dr. Shivanna will take over.
Good evening, everyone. I am going to introduce Dr. S.M. Prasad, Professor of Pediatrics. He is going to speak about rational use of antibiotics in daily clinical practice. His qualification MBBS, DCH, MD Pediatrics, PG DMLA, and present designation is Professor of Pediatrics, Akash Institute of Medical Science, Bangalore. Chief Editor, IMA Focus, affiliation, part of past President, past President, IIP Bangalore District, past Honorable State Secretary, IMA Karnataka State. Major achievements, Best Branch Award for IIP Bangalore Branch 2023, National Workshops, National IMA President Golden Star Award for Best Honorable State Secretary. Previously worked as Professor and HOD in AIMS, BG Nagar, Bangalore. Principal Investigator in hexavalent vaccine phase 2-3 clinical trials. Publications 30 in national and 8 in international journals. I welcome you, sir.
Thank you, Chairperson, sir. At the outset, I would like to thank the President, Dr. Harish Kumar, and Secretary, Dr. Abdul Salim, and all the office bearers of Family Physicians Association of Bangalore. And also I thank all our delegates who have attended this session. Though it is going late, there is no problem. I will take only about 20 minutes just to tell about what about the antibiotics resistance in India. So all of us, if you trace back, that is maybe 30 years back or 35 years back, when we started our journey as a medical practitioners, we have seen this or we have heard to ourselves, Doctor, strong antibiotics, heavy dosal kotputbedi doctor. ಆಮೇಲೆ ಡೆಂಗಿ ಫೀವರ್ ಸ್ಟಾರ್ಟ್ ಆಯಿತು 10-15 ಇಯರ್ಸ್ ಬ್ಯಾಕ್. ಡೆಂಗಿ ಫೀವರ್ ಅಂತೆ ಡಾಕ್ಟ್ರೇ ಚೆನ್ನಾಗಿರೋ ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಸ್ ಹಾಕ್ಬಿಡಿ, ಏನಾದರೂ ಆಗಲಿ ಕೊಟ್ಬಿಡಿ. ಇನ್ನೊಂದು ಫೀವರ್ಗೆ ಕಮ್ಮಿ ಆಗೋಕ್ಕೆ ಸೆಪ್ಟ್ರಾನ್ ಕೊಟ್ಬಿಡಿ ಡಾಕ್ಟ್ರೇ. ಅವ್ರಿಗೆ ಸೆಪ್ಟ್ರಾನ್ ಅನ್ನೋದು ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಸ್ ಅಂತಲೂ ಗೊತ್ತಿರಲಿಲ್ಲ ಆ ಕಾಲದಲ್ಲಿ. ಇನ್ನೊಂದು ಫೀವರ್ ಕಡಿಮೆ ಆಯಿತು ಡಾಕ್ಟ್ರೇ, ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಸ್ ಸ್ಟಾಪ್ ಮಾಡಿಬಿಡ್ಲ ಡಾಕ್ಟ್ರೇ, 2 ದಿನ ಸಾಕು, ಅದು ಒಂದು. ಇನ್ನೊಬ್ಬರು ಡಾಕ್ಟ್ರಿಗೆ ಯಾಕೆ ಪರ್ಸನಲ್ ರಿಲೇಷನ್ಶಿಪ್ ಚೆನ್ನಾಗಿರಬೇಕು, ಡಾಕ್ಟರ್ ರಿಲೇಷನ್ಶಿಪ್ ಚೆನ್ನಾಗಿರಬೇಕು, ಆ ಡಾಕ್ಟ್ರ್ ಹತ್ರ ಹೋದರೆ ಸುಮ್ಮನೆ ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಸ್ ಕೊಟ್ಬಿಡ್ತಾರೆ ಅಂತ ಹೇಳಿ ಒಬ್ರಿಗೊಬ್ರು ಹೇಳ್ಕೊಳೋದು. ಇನ್ನೊಂದು ಅಣ್ಣ ತಮ್ಮಂದರು ಒಂದೇ ಫ್ಯಾಮಿಲಿಯಲ್ಲಿ ಎಲ್ಲ ಡಾಕ್ಟ್ರು, ಒಂದೊಂದು ರೋಡಲ್ಲೂ ಡಾಕ್ಟ್ರು ಇದ್ದೇ ಇರ್ತಾರೆ. ಅಣ್ಣ ನನಗೆ ಒಂದು ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಸ್ ಬರ್ಕೊಟ್ಬಿಡು, ಲಾಸ್ಟ್ ಟೈಮ್ ಹಿಂಗೆ ಚೆನ್ನಾಗಾಗ್ಬಿಟ್ಟೆ. ಇದು ಕೂಡ ಕಾಮನ್ನಾಗಿ ಕೇಳೋ ಅಂಥ ಸೆಂಟೆನ್ಸಸ್ಸು ಅಥವಾ ಈ ಥರ ವಾಕ್ಯಗಳನ್ನ ಕೇಳ್ತಾನೆ ಇರ್ತೀವಿ ನಮ್ಮ ಲೈಫಲ್ಲಿ ವೆನ್ ವಿ ಆರ್ ಪ್ರಾಕ್ಟಿಷನರ್ಸ್. ಸೊ ಇಂಟ್ರಡಕ್ಷನ್ ಅಬೌಟ್ ದಿ ಆಂಟಿಮೈಕ್ರೋಬಿಯಲ್ ಮೆಡಿಸಿನ್ಸ್, ದೇ ಆರ್ ದಿ ಕಾರ್ನರ್ ಸ್ಟೋನ್ ಆಫ್ ಮಾಡರ್ನ್ ಮೆಡಿಸಿನ್. ಮುಂಚೆ ಗೊತ್ತಿರಲಿಲ್ಲ, ಪೆನ್ಸಿಲಿನ್ಸ್ ಬಂತು. ಆಗೆಲ್ಲ ನಾವೆಲ್ಲ ವರ್ಕ್ ಮಾಡಬೇಕಾದ್ರೆ ಗೌರ್ಮೆಂಟ್ ಹಾಸ್ಪಿಟ್ಲಿನಲ್ಲಿ ನಾವಿನ್ನೂ ಆಗ 30-35 ವರ್ಷದ ಮುಂಚೆ ಏನು ಹೇಳ್ಕೊಟ್ಟವರು ನಮಗೆ ಪ್ರೊಫೆಸರ್ಸ್ ಬರೋರು ಎಲ್ಲ ಹೇಳೋರು, ಏನಪ್ಪ PP 4 for 5 days ಹಾಕ್ಬಿಡು, ಬರೀದ್ಬಿಡ್ತಿದ್ವಿ ಚೀಟಿನಲ್ಲಿ. ಬಿಲೋ 5 years PP 2 ಬರಿ. ಆಮೇಲೆ ಇಂಟರ್ನ್ಶಿಪ್ ಮಾಡ್ತಿದ್ದೀವ, ಎಲ್ಲರಿಗೂ ಏಜ್ ನೋಡ್ಕೊಳೋದು, PP 4 for 5 days, PP 2 for 2 days. ಆಮೇಲೆ ಇಂಜೆಕ್ಷನ್ ರೂಮ್ಗೆ ಹೋಗಿ ತೊಗೊಳೋದು. ಆಗ ಎಲ್ಲಿ ಸ್ಟೆರಿಲೈಸ್ ಇದಿರಲಿಲ್ಲ, ಗ್ಲಾಸ್ ಸಿರಿಂಜಸ್ಸು ಬಾಯ್ಲರಲ್ಲಿ ಮಾಡ್ತಿದ್ವಿ. ಸೊ ಆಮೇಲೆ ಏನೇನಾಯಿತು, ಅದೇ ಥರ ಹೊಸ ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಸ್ ಬಂತು. ಆಮೇಲೆ ಈಗ ಹಾರ್ಡ್ಲಿ ಈಗ ಮೆಡಿಕಲ್ ಕಂಪ್ನೀಸ್ಗೆ 8 ಮಾಲಿಕ್ಯೂಲ್ಸ್ ಬಿಟ್ಟು ಇನ್ಯಾವುದೂ ಇಲ್ಲ ಮುಂದಕ್ಕೆ. ಈಗಾಗಲೇ 36 ಅಂದರೆ 36 ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಸು ಇದೆ ಲಿಸ್ಟ್ನಲ್ಲಿ WHO ಇದರಲ್ಲಿ 2017ರಿಂದನೇ. ಬಟ್ ನೆಕ್ಸ್ಟು ಮಾಲಿಕ್ಯೂಲ್ಸು ನಮಗೆ 6 ಇಲ್ಲ 8 ಮೇಲೆ ಇಲ್ಲವೇ ಇಲ್ಲ. ಇದರಲ್ಲೇ ಪರ್ಮುಟೇಷನ್ ಕಾಂಬಿನೇಷನ್ಸ್ ಮಾಡಿ ಬರ್ತಾ ಇದೆ. ಯಾವುದೂ ಹೊಸ ರಿಸರ್ಚ್ ಪ್ರಾಡಕ್ಟ್ಸು ಬರೋಕ್ಕಾಗ್ತಾ ಇಲ್ಲ. ಸೊ ದ ಎಮರ್ಜೆನ್ಸ್ ಆ್ಯಂಡ್ ಸ್ಪ್ರೆಡ್ ಆಫ್ ಡ್ರಗ್ ರೆಸಿಸ್ಟೆಂಟ್ ಪೆಥೋಜನ್ಸ್ threaten our ability to treat common infections and to perform life-saving procedures, including cancer chemotherapy and cesarean sections, hip replacements, organ transplantation and other surgeries. ಆಮೇಲೆ ಇದು ಪೆಟ್ ನೇಮ್ಸು. ನಾನು ಸ್ಟೂಡೆಂಟ್ ಇದ್ದಾಗ ನಮ್ಮ ಪ್ರೊಫೆಸರ್ಸ್ ಬರೋರು ಒಂದೊಂದ್ಸಲಿ, ಏನು ನಾವಿನ್ನೂ ಇಂಟರ್ನ್ಸು ಇದ್ವಿ ಆಗ ಎಲ್ಲರಿಗೂ ಆ್ಯಂಪಿಜೆಂಟ ಅದೊಂಥರ ಪೆಟ್ಟು ನೇಮ್ ಅದಕ್ಕೆ, ಆಂಪಿಸಿಲಿನ್ ಜೆಂಟಮೈಸನ್ ಕಾಂಬಿನೇಷನ್ಸ್ಗೆ ಹಾಕ್ಬಿಡ ಆ್ಯಂಪಿಜೆಂಟ ಹಾಕಿ ಅಂತಂದರೆ ಆಗ ನಮಗೂ ಖುಷಿ. ನಾನೇ ಆ್ಯಂಪಿಜೆಂಟ ಹೇಳ್ಬಿಟ್ರೆ ನಮ್ಮ ಪ್ರೊಫೆಸರ್ ನನ್ನ ಕಡೆಗೆ ಶಬಾಷ್ಗಿರಿ ಮಾಡ್ತಾರೆ ಅಂತೇಳಿ ನಾನು ಎಲ್ಲರಿಗೂ ಆ್ಯಂಪಿಜೆಂಟ ಎಲ್ಲ ಅಡ್ಮಿಟ್ ಆದವರು ಕೊಡ್ತಾಯಿತ್ತು. ಆ ಥರ ಆಗ್ಬಿಡ್ತು ಸಿಚುವೇಶನ್ನು. ಅದೇ ಥರ ಕೆಲವು ನೇಮ್ಸು ಪೆಟ್ ನೇಮ್ಸು ಅಮೆನೋಗ್ಲೈಕೋಸೈಡ್ಸ್ಗೆ ಮೈಸೀನು, ಸೆಫಲೋಸ್ಪೋರಿನ್ಸ್ಗೆ ಸೆಫು, ಟೆಟ್ರಾಸೈಕ್ಲಿನ್ಗೆ ಸೈಕ್ಲಿನ್ ಸಾಕು ಅನ್ನೋದು, ಪೆನ್ಸಿಲಿನ್ಗೆ ಸಿಲಿನ್ ಸಾಕು ಅನ್ನೋದು, ಈ ಥರ ಎಲ್ಲ ಬಂದ್ಬಿಡ್ತು. ಫ್ಲೋಕ್ಸಾಸಿಲಿನ್ ಅನ್ನೋದು, ಮ್ಯಾಕ್ರೋನಿಸ್ಗೆ ಥ್ರೋಮೈಸಿನ್ ಅನ್ನೋದು, ಈ ಥರ ಎಲ್ಲ ಪೆಟ್ ನೇಮ್ಸ್ ಬೇರೆ. ಅದರ ಜೊತೆಗೆ ಅಲ್ಲಲ್ಲೇ ಉಟ್ಕೊಂಡ್ಬಿಡ್ತು, ಬೇರೆ ಬೇರೆ ಕಂಟ್ರೀಸಲ್ಲಿ ಬೇರೆ ಬೇರೆ ಇದರಲ್ಲಿ ಬೇರೆ ಬೇರೆ ಫಾರ್ಮ್ನಲ್ಲಿ ಉಟ್ಕೋತು. ಆಮೇಲೆ ಹಂಗೇ ಯೋಚನೆ ಮಾಡ್ತಾಯಿದ್ದೆ. ಆಗ ಕನ್ನಡದಲ್ಲಿ ಒಂದು ಬೋರ್ಡ್ ಕಾಣಿಸ್ತು. ಮೈಸೂರಿಂದ ಬೆಂಗಳೂರಿಗೆ ಬರ್ತಾ ಇದ್ದೆ. ಆಗ ಅಷ್ಟೊಂದು ರಿಸ್ಟ್ರಿಕ್ಷನ್ಸ್ ಇರಲಿಲ್ಲ MCIಯಿಂದ. ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಸು ಯೂಸ್ ಮಾಡ್ಬೋದು ಅಂತ ಒಂದು ಬೋರ್ಡಲ್ಲಿ ಸಡನ್ನಾಗಿ ನೋಡ್ಬಿಟ್ಟೆ. ಇದೆಲ್ಲ ಬಂದ್ಬಿಡ್ತಿದೆ. ಡಾಕ್ಟ್ರು ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್ ಮಾಡೋಕ್ಕೆ 3 ಸಲ ಮೇಲೆ ಮಾಡೋಕ್ಕೆ ಬರಲ್ಲ ಒಂದು ಕಡೆ ಎಸ್ಟಾಬ್ಲಿಷ್ ಮಾಡಿದಾಗ. ಇದನ್ನು ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಸ್ ಅಂತ ಯಾವುದೋ ಕಂಪ್ನಿ ಹಾಕ್ಬಿಟ್ಟಿದೆಯಲ್ಲ ಅಂತ. ಅದಕ್ಕೆ ಅಲ್ಲಿ ನೋಡಿದರೆ ಕನ್ನಡದಲ್ಲಿ ಏನಿತ್ತು ಅಂದರೆ ಆಂಟಿಬಯೋಟಿಕ್ಸ್ ಅಂತ ಬರ್ತಿತ್ತು ಇದೇ ಥರ. ಈ ಬಯೋಟಿಕ್ಸ್ ಕಂಪ್ನಿ ಅಂತ ಒಂದಿದೆ. ಯಾರು ಕಪ್ಗಿರೋರು ಬೆಳ್ಗಾಗಬೇಕು ಅಂದರೆ ಬಯೋಟಿಕ್ಸ್ದು ಕೋಕೋನಟ್ದು ಒಂದು ಸಿಗುತ್ತೆ, ಅದು ಹಾಕೊಂಡ್ಬಿಟ್ರೆ ಒಂದು 3 ತಿಂಗಳಲ್ಲಿ ಬೆಳ್ಗಾಗ್ಬಿಡ್ತಾರೆ ಅಂತ ಒಂದಿದೆ. ಸೊ ಅದರಲ್ಲಿ ಏನಾಗುತ್ತೆ, ಬಯೋಟಿಕ್ಸ್ ಕಂಪ್ನಿನ ಅದನ್ನು ಇದೊಂಥರ ಕಾಸ್ಮೆಟಿಕ್ಸ್ ಥರ ಯೂಸ್ ಮಾಡಬಾರ್ದು. ಸೊ ನೆವರ್ ಯೂಸ್ ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಸ್ ಆ್ಯಸ್ ಕಾಸ್ಮೆಟಿಕ್ಸ್. ಆ್ಯಂಡ್ ಆಲ್ಸೋ ನೋ ಮಾರ್ಕೆಟಿಂಗ್ ಲೈಕ್ ಕಾಸ್ಮೆಟಿಕ್ಸ್. ನಾವು ಇದನ್ನೆಲ್ಲ ನಿಂಬೆಹಣ್ಣು ಪಕ್ಕ ಅದಿಟ್ಬಿಡೋದು, ಗ್ರೇಪ್ಸ್ ಪಕ್ಕ ಇಡೋದು, ಚೆರೀಸ್ ಹತ್ರ ಇಡೋದು, ಇದೆಲ್ಲ ಮಾಡೋಕ್ಕಂತೂ ಆಗೋದೇ ಇಲ್ಲ. ಇದು ಕ್ಲೋಸ್ ಸರ್ಕ್ಯೂಟಲ್ಲಿ our discussion among the professionals with reasons we have to follow. ಸೊ ಇದೆಲ್ಲ ಮಾಡಲಿಲ್ಲ ಅಂದರೆ ಡೆಫಿನೆಟಾಗಿ ಆ್ಯಂಟಿಬಯೋಟಿಕ್ಸ್ ರೆಸಿಸ್ಟೆನ್ಸ್ ಬಂದೇ ಬರುತ್ತೆ. ಸೊ ನೆಕ್ಸ್ಟು ಆ್ಯಂಟಿಮೈಕ್ರೋಬಿಯಲ್ ರೆಸಿಸ್ಟೆನ್ಸ್ ರಿಸಲ್ಟ್ಸ್ ವೆನ್ ಮೈಕ್ರೋ ಆರ್ಗನಿಸಮ್ಸ್ ಇನ್ಕ್ಲೂಡಿಂಗ್ ಬ್ಯಾಕ್ಟೀರಿಯಾ, ಫಂಗೈ, parasites, viruses evolve to the extent that they eventually become resistant to antimicrobial medications such as antibiotics, which are used to treat such conditions. And it has now emerged as one of the biggest global concerns 21st century due to the rapid growth of infections rate and lack of new antimicrobial medications being introduced to combat this issue. So ಈಗೇನಾಗಿದೆ, WHO ಕೂಡ ಅಲರ್ಟ್ ಆಯಿತು. 2016 their theme was to fight the drug resistance or the antimicrobial resistance. They brought out so many things like antibiotics ಬರಿಬೇಕಾದ್ರೆ, ಪೆನ್ ಡೌನ್ ಮಾಡಬೇಕಾದ್ರೆ ನೀವು ಯಾವಾಗ ಬರೀತೀರಾ? when you are writing things, so more at least 5 times, 6 times, whether it is indicated or not. And write the antibiotic name in capital letters and also in the color pen, or you can use a highlighter. That is very, very, very important, so that you should be more alert about before you pen down the name of the antibiotics. So misuse of the antibiotics, underuse of the antibiotics, overuse of the antibiotics, definitely it is going to bring more fire or more oil to the fire of already the antibiotic resistance is going on. Global burden is also there. It is not only in India, everywhere, most of the places. So we hear evidence-based medicine is there in UK. So definitely there they say without any reason you cannot start antibiotic. First day no, third day no fever, no, fourth day fever, no, fifth day fever, you have to suffer, then only antibiotics. Or if somebody is there in ICU, intensive care units, neonatal intensive care unit, respiratory RRIs, respiratory infections, RCIs, respiratory intensive care units, there only you can start that too with where there is a life-threatening condition happening. Without any indication you can start, but prove that it is a bacterial infection, then only continue the antibiotics, otherwise you have to stop. This is the protocol which is followed in most of the ICUs. And the burden, what was there in 2000, all antibiotics we are using, same thing we are using in 2015, 2024, whatever available. So there is a resistance which can spread not only from human to human, but also from animal, because not only we as the allopathy pediatricians or physicians we are using, but also the veterinary people they are also using. For example, one of my uncle, he had kept dogs those days, about 30 years back. He was telling, same molecule what we use for adults, if the dog is getting some infection, I am going to put quarter of it, half of it, so that I will give. So there is a self-medication of pet owners also. So even that can spread. Even through plants it can spread. It can spread through as an insecticide, pesticide. So many things are there. They can put for anything. And also when we are discarding these antibiotics, are we properly disposing it? Waste disposal? even we need to think. We give to some people, they are going to throw into the corporation dustbin, not to the pollution, whatever the waste collection, medical waste. We are not going to give it. So it is all adding somewhere. Some animal will graze or somebody will take. So gradually this resistance, this cycle will go on repeating. So in India, antimicrobial resistance is one of the major public health problems which you are going to come across. Easy availability and higher consumption of medicines have led to the disproportionately higher incidence of inappropriate use of antibiotics, greater level of resistance. Not only we, the allopathic doctors, but also the homeopathic doctors, self-made doctors, retired hospital attendants from government service, they are also doctors. Dr. Lingappa is also famous because he was a laboratory technician in a government hospital. Then he started practicing in his village. As he became a Dr. Lingappa. He also prescribed all antibiotics. And he has been taught by sometimes the medical literature, somehow he reads. That is happening. So just he gives. Ayurvedic doctors also are writing this. They don't know for what they are writing, but they will write. This is what is happening. And infectious diseases burden is, we know that in India, like our country, other countries are also facing the same issues, other developing countries. So inappropriate, irrational use of antimicrobial agents, definitely it is going to a challenge for a drug resistance or the antimicrobial resistance. So there are so many. Bacteria can respond to wide variety in the environmental tests like heat, cold, even alkalinity, salinity. They can react to the presence of antibiotic molecules that can jeopardize their existence due to the remarkable genetic plasticity. So it can be anything, like I told you, inappropriate use of the antibiotics, antibiotic resistant genes may be there, and even extensive use in agriculture. That can also one of the cause where this can happen. So we are all the risk factors for this. One is a male gender, the poor socioeconomic factors, poor adherence to therapies and higher consumption of clinically inappropriate antibiotics, hospital admissions, ICU stay for a longer time. Sometimes we have to scold or we have to think ourselves retrospectively. When anybody comes to ICU, definitely with so much severe condition, we just, to prevent, prophylactically we start antibiotics. Are we justified in starting these antibiotics? And so many species, like left and right we use the broad spectrum antibiotics. Are we justified in that? It is like putting a bomb to the whole city if only one pocket is having some enemies there. We are going to destroy both the healthy bacteria and the unhealthy bacteria as well. So healthy bacteria get also jeopardized here. The microbiota also gets jeopardized. Human microbiota also, it can get jeopardized. So one health approach is, it is a multi-sectorial approach where combined efforts from all stakeholders are required to successfully engage in this program. It is not only the allopathy doctors with, otherwise even the veterinary medicines, they also should come forward. The pharmaceutical companies, I am very delighted to say that the micro labs, especially they are having this rational use of the antibiotic program which is being conducted to all the pediatricians, not now from 6 years. Now they have come out with the antibiotic prescription made easy, that is APME program, which is happening among all the pediatricians now. So that at least when the child is there, we will justify using which antibiotic, which organism, we think in terms of that. We don't use broad spectrum antibiotics left and right for any child. Now we are very much cautious about using what kind of antibiotics. I cannot use a AK-47 for a small thing, for a small thief. It can be a small thing. You can just catch him red-handed. But you cannot use a AK-47 or a bomb to destroy the whole community or like that. We should not do it. So the global action plan, that antibiotic resistance, this plan aims to ensure that infectious disease can always be successfully treated and prevented by preserving antimicrobials in responsible manner with appropriate accessibility and quality checks. And those days were different. If you don't write many drugs, patients were not happy. Nowadays, if you write less number of drugs, they are very, very happy. It is not the cost factor, it is the education level of India, rural India has also come up. Many people, they express to me also. Those days, we used to say 3 antibiotics for one infection. But if you write more infection, they used to think he is a super specialist. No. Now the things, the mentality, attitude of our customers, that is our population, has totally changed even in India. And there is a AVERE classification. It is for the antibiotics which developed in 2017 by WHO expert committee on selection and usage of essential medicines as a tool to support antibiotic stewardship, that is especially at local, national and global levels. WHO in 2017 introduced the access, watch and reserve, that is AVERE. So classification of antibiotics in essential medicines list. The classification is a tool for antibiotic stewardship at local, national and global levels with the aim of reducing antimicrobial resistance. So this is A for access, that is for watch, and RE, that is for reserve. And antibiotics are classified into 3 groups, that is access, watch, that is you have to classify and then you have to think and use it in appropriate steps. And also, whenever you want to choose antibiotics, always try to go for a narrow spectrum antibiotics, that is activity, then the fewer side effects, a lower potential for a selection of antibiotic resistance, lower cost, recommended for empirical treatment for most common infections, and it should be easily available. They should not bush around, beat around, where is this antibiotic, that antibiotic. And better we have to write the trade name as well, and under that we can write the generic name, all the whatever is the pharmacological name we have, so that they will not get confused by the pharmacist. Usually they can confuse the pharmacist. Your doctor has given a very strong antibiotic, this one I have not seen you taking this. This is the first time I have seen this kind of antibiotic. Even you will train them, so that our name also will go, and especially Ayurvedic doctors also, they will have the confidence level also will come down among the patients. And always watch for the antibiotics. So higher potential for the selection of the antibiotic resistance, commonly used in sick patients in the hospital setting. I told you about intensive care and all. And we need to carefully monitor whether they are taking it properly or not. That is also very important. In pediatric doses, we say we have to show the cup, we have to show what is the measurement, because that will cause underuse of the antibiotics. Suppose sometimes they will give the whole bottle, or the half a bottle child will drink, because if it is very sweet, that causes overdose of the antibiotics. Misuse, again, it can be improperly taken. Improperly, they will be taking it. So what is targeted for urinary tract infection, it should be for that. What is taken for upper respiratory infection, it is for that. And what is for lower respiratory tract infection, it should be for that. And we have to think of what are the commonest organism occurring for this. Suppose streptococcal sore throat. So those days I was telling you, anybody coming with upper respiratory tract infection, we used to write PP4 for 5 days. Were we screening? Was it a bacterial or viral? We were not screening. We were not told to do that. Nowadays we know, if it is a really bacterial infection, we know that there is once we open the mouth, we know petechial hemorrhages on the soft palate, petechia over the soft palate. You can see some of the loculations or the pus follicles on the tonsils, jugular digastric lymph nodes in this one, enlarged. Then nasal, there is a purulent nasal discharge. There is a crusting in the nose. There is a voice change, like me, what has happened. Then is there any other condition like pain in the throat? All that it says, and also going for more than 5 to 6 days without any treatment, without antibiotics, becoming lower respiratory tract infection. All that is, it can be usually a bacterial infection when we treat in the outpatient department. Otherwise, wait for 3 days, then do the test, then look for is there any polymorphonuclear leukocytosis. That can also be done, then you can start. Till that time, better to avoid the antibiotics at least for 3 days of the initial illness of fever. Because one of the Kerala lady came once to me, adult lady, mother of one of the child whom usually I take care. Then she came and told me, doctor, I went to this corporate hospital, just see the prescription. Then I took the prescription, yes, what has happened? Then I, looking at that, then I said, you must be suffering from influenza, swine flu. She said, what? Doctor, yesterday, I was all right, only today I have gone. Today I went there, corporate hospital, they have given me, it is swine flu. Do you want me to take this medicine? She is asking my opinion. Then I said, please consult the doctor again. You tell properly. Then I feel that 2 to 3 days you wait. Without anything, anti-flu, oseltamivir given. First day of fever. If everybody start doing this, are we really going to combat this antibiotic resistance, antimicrobial resistance? So now it is not an antibiotic resistance, it is antimicrobial resistance. So it can include starting from antibacterials to antifungals to the even antiparasitic also we can include. Even resistance are happening everywhere. So always we have to watch this group of this one. And also antibiotic stewardship, this is the one to work with the healthcare practitioners to prescribe 5 Ds of the antibiotic therapy, drug, correct dose, right drug route, suitable duration, timely de-escalation of this. To prevent antibiotic use, misuse or abuse in a patient, outpatient, inpatient, community settings, including the agricultural industry. Agricultural industry, very important. Then to reduce antibiotic related adverse effects, then also to minimize the resistance, also to reduce healthcare associated cost. Even cost is going up like anything when we use the antibiotics, which was 30 rupees. Now for a strip we are paying around 120 rupees. What was 120 rupees, it has become 340 rupees. Like that it is going up. So in a nutshell, this is the thing we can learn to know. The antibiotic stewardship, enhancing the infection prevention and control, controlling the source of infection, then the prescribing antibiotics when they are truly needed, prescribing appropriate antibiotic with adequate dosage, using the shortest duration of antibiotics based on the evidence. The general rule all of us know, gram positive 14 days, gram negative 3 weeks when it is in the hospital setting. And educating the staff, not only ourselves, even the nurses as well. Time is there? 1 minute or over? Yeah.
Oh, thank you for a very wonderful talk on antimicrobial resistant. Your talk was very humorous.
Thank you, sir.
And everybody was awake the way you presented. Thank you.
I didn't go to the depth because it is very much boring. And we have got a training program. If anybody interested, we can do. That is a one-day full day program which goes on Bangalore and other places in India as well. So, we announce it frequently. That is called APME program, Antibiotic Prescription Made Easy, APME, APME. Definitely, I will share it. So it will be definitely useful. And also patients nowadays, they're all educated and they will appreciate us very much when we think of the antibiotics. They will ask out of all, which is the antibiotic here? Then I started highlighting. Then they were showing paracetamol, then there were things. I said, this is the antibiotic. I will boldly say, this is the antibiotic I am using. In my prescription, always I say, I wanted to show that prescription. I have put AB, yes or no. If AB, yes is there, I have given the antibiotics. If no is there, I am not using the antibiotics. Because later they should not scold me that I didn't start the antibiotics. I will tell this is a viral infection. Whatever I have examined you, signs and all, it is not convincing for a bacterial infection. That is why I am not starting this. If you want to wait, wait. Otherwise, if you want to start, I can start, but under risk, I will start. Thank you.
Thank you, Dr. Prasad. It was a very nice presentation. Okay. The last speaker for the day today, Dr. Arun Kumar, consultant psychiatrist at Kadabam's Hospital. He'll be speaking on neuromodulation, novel treatment for depression and anxiety spectrum issues. So I request Dr. Prabhakar, you can come and introduce Dr. Anil Kumar.
So it is the final session of the day. So the last talk is on psychiatry. So it's my pleasure introducing Arun Kumar, who is the lead consultant psychiatrist at Kadamam's Hospital. He is a UG from Ambedkar Medical College, PG from JSS Medical College. He has a lot of presentation. He has presented a lot of papers on psychiatric illness, and he has attended and he has published so many articles in Indian Journal of Psychiatry and even in Sri Lankan Journal of Psychiatry, and Scholars Journal of Medical Case Reports, and he has worked on role of nicotine dependence in severity of COPD, anxiety and depression, and he has attended lots of conferences at the state and national level, and he is a very good cricket player. He has represented his UG days in Ambedkar Medical College, JSS Medical College, now currently playing for Bangalore's zonal teams at state level psychiatric cricket tournaments and even national level psychiatric cricket tournaments. He is the cricket player. Over to Arun Kumar. Everybody is patiently waiting for your lecture.
Hello. Yeah, so I thank the Family Physicians Association to give me an opportunity to talk about the neuromodulatory services. So I work as a consultant psychiatrist at Kadavam's Hospital. I'm heading the neuromodulatory services there. So let me give you a brief talk about neuromodulatory services. So I'm only going to talk about neuromodulatory services for depression and anxiety because it's a vast subject and a lot of services are there. So I'll keep it very specific. So a lot of patients come to us, and they have resistance to pharmacotherapy and no response to psychotherapy. So such candidates, the neuromodulatory services are a very good option. The neuromodulatory services can also be an option for people who do not want to go ahead with pharmacotherapy options. So the neuromodulatory services specifically, they target specific systems from the areas of the nervous system, especially the brain, and improve the neural functions. They used in unipolar major depression. There are about two kinds of techniques that can be used: non-invasive techniques and invasive techniques. The non-invasive neuromodulation procedures generally use electric currents or even magnetic fields to stimulate the system. So they're highly reversible, and you can take out the stimulus whenever it is, you don't want to use it. So what are the classification of the non-invasive techniques? What is clinically available at the moment is the ECT, of course, very widely used. The repetitive transcranial magnetic stimulation, also now developing very much, and the cranial electrical stimulation. Some of the other techniques are also there. They are in an investigational stage, and they're developing. In fact, I do TDCS very much, and I see a very good response to a lot of individuals. So the investigation approaches are magnetic seizure therapy, focal electrically administered seizure therapy, TDCS, transcranial low voltage pulsed electromagnetic fields, trigeminal nerve stimulation, low field magnetic stimulation, and transcutaneous vagus nerve stimulation. So let's see the development. ECT was introduced in 1930s, TDCS in 1960s, TMS in 1990, deep brain stimulation in 2005, the cortical stimulation in 2007, and the MST, the high frequency MST, is in 2008. So the timeline of approvals, FDA approvals, we got approval for ECT in 1979, and vagus nerve stimulation for depression in 2005. The TMS for depression in 2006, the deep brain stimulation for OCD, obsessive compulsive disorder, in 2009, and the deep TMS for depression in 2013. The rest, of course, are used by the neurosurgeons as well, the neurologists, for other purposes, medical purposes. So the general neuromodulatory effects that we see with these procedures are the acute effects, of course, the phasic activation of neural circuits, the prolonged effects being neuroplasticity most importantly, because that is what sustains the recovery, the change in synaptic efficacy, alterations in neurotropic factors, modulation of cortical excitability, and improving the functional connectivity. So let's start with ECT. ECT, what we do in ECT is passing electric current between two electrodes placed against the scalp to produce a general cerebral seizure. So we do it under general anesthesia and muscle relaxants. ECT involves a series of treatments. As we continue to do it, the response is better, and the continuous treatment ensures that the recovery is sustained. It's considered one of the most efficacious treatments for depression, and however, the practice has been stigmatized because of the procedural, misinformation regarding the procedural methodology, generally depicted in movies. So that has a very bad impact. So what is the anatomy and physiology regarding depression, and what is a probable theory between about ECT? So what happens in severe depression is there is reduced activity and volumetric reductions in the dorsal areas of the frontal lobes. The areas of ventral and orbital frontal cortex also, there's altered processing of emotional stimuli. There's functional alterations and volumetric reductions in the hippocampus, paracampal gyri, and amygdala. The HPA axis also becomes very sensitive, releases stress hormones, and then there's an impaired feedback mechanism that is there. The mesocortical limbic dopamine system as well as the HPA axis are also very activated in people with stress, and the dopamine functions also come down in depression. So these are what is seen in depression, and ECT reverses all of this, and hence the antidepressive effects. So in ECT, the general parameters that we use as per the American Psychiatric Association is the voltage of current is around 70 to 120 volts. The usual amount of current passed is about 200 to 1600 mAh of current, and duration is about 0.7 to 1.5 seconds, frequency being about 3 times a week for an average of 6 to 10 ECTs. It can go up to 25 ECTs depending on the condition and the severity of the depression. And the general methodology of use is bitemporal methods, the bifrontal, and the unilateral method. This is a picture depicting the three methods of electrode placements. So the indications, the primary indications being, ECT of course is used in very severe conditions. So hence, when there is suicidality, when there is depression with psychotic symptoms, food refusal generally seen in depression, it is primarily used. Also, where antidepressants and antipsychotics are, the safer, not of a safer profile in debilitated patients, elderly patients, pregnancy and breastfeeding. Pregnancy and breastfeeding, very much, ECT is very much safe. So we go ahead and do this as a first preference. There's a past history, where there's a past history of poor response to psychotropic drugs. ECT also is a very good option. And of course, most of the patients themselves come and choose ECT over psychotropic medications. Some of the secondary applications of ECT being impaired activity because of a chronic treatment-resistant depression and intolerance to pharmacotherapy in the current episode, no response to the medications. What are the contraindications of pheochromocytoma and elevated intracranial pressure with mass effect is an absolute contraindication for ECT. Relative contraindications being elevated intracranial pressure with mass effect, cardiovascular conditions, high-risk pregnancies, aortic and cerebral aneurysms. The complications that we generally see with ECT being increase in blood pressure, myocardial oxygen consumption, heart rate, increase in heart rate, and intracranial pressure. Bitemporal ECT, generally we see cognitive impairment, although this effect is very transient. In unilateral ECT, the amnesia is very much minimized. So some of the evidence, I put some of the evidence-based, recovery based on ECT. In a 2017 meta-analysis with randomized trials of 792 patients, specifically compared moderate bilateral ECT with high-dose unilateral ECT, and remission was very much comparable. The suicidal ideation is rapidly relieved by ECT, and the complete resolution was seen in about 38% of the patients in 1 week, 61% of the patients after 2 weeks, and 81% of the patients with the completion of ECT. Also, electroconvulsive therapy is a favorable method to reduce depression symptoms regardless of whether the antidepressants are used or not, as per Hussain et al. The consortium for research in ECT, supported by 4 collaborating clinical centers, showed a significant effect of bilateral ECT over unipolar depressed patients. With 253 patients totally enrolled without antidepressants, an acute series of ECT demonstrated a relatively high speed and rate of response and remission. To prevent relapse, the core group conducted continuation ECTs, indicating continuation ECT can prevent remitted individuals from relapsing. The core and pride studies from ECT was not inferior and possibly had better preferable outcomes than antidepressants themselves. In fact, the results of ECT exceeded those of medications in treatment-resistant bipolar depression. Continuation ECT meaningfully maintained remission and combined with medicines may maximize the benefits of ECT without increase in memory loss. In relation to suicide, large nationwide studies performed retrospectively indicate that in patients with unipolar depression and bipolar depression, ECT had a superior and anti-suicidal effects. So some of the MRI changes that we see after ECT, which I already mentioned. So brief pulse ECT showed significant volume increase in the bilateral medial temporal cortices, inferior temporal cortices, and right anterior cingulate after ECT. That responded to HAM-D scores. HAM-D is a scaling to show the recovery in terms of depression. Bilateral medial temporal lobe and perigeneal anterior cingulate cortex volume increases were also seen with ECT and associated with significant clinical improvement. Hippocampal and amygdala volume increases also were seen with ECT. Abbott et al. Also found that hippocampal connectivity was also better with ECT. Wang et al. Demonstrated that ECT may contribute to enhanced interactions with the intra and intercellular networks in patients with major depressive disorder. ECT studies have brought renewed interest in neuroplasticity to the brain. Not only the hippocampus, but neural networks also showed more profound activity, which was suggested by these 4 studies. So going on to another process, the magnetic seizure therapy, very similar to ECT. There we use electrical charge. Here we use a magnetic stimulus. MST uses magnetic stimulation device that is also used for RTMS, very similar device to induce a seizure. The only difference is the intensity here is very high. We use a 100 Hertz stimulus. It causes fewer side cognitive effects than ECT because the stimulus is a very focal area of the brain. The procedure is targeting the prefrontal cortex and it spares the temporal areas, hence the cognitive effects or deficits are not much as we see in ECT. The treatment course with MST involves a series of seizures that are induced under general anesthesia. The muscle relaxant also is used, it's very similar to ECT, and patient typically receives about 8 to 12 sessions over a 4-week period. So this is the picture depicting the device. Here we use the magnetic coils, very similar to RTMS. RTMS you use a single coil. Here we use 2 coils and 2 difference to induce a seizure. So some of the evidence is being in one prospective study, which included about 38 patients. They did not respond well to pharmacotherapy and received MST. Response occurred in about 70% of the patients. Another prospective observational study includes 27 patients with unipolar major depression and found that MST was associated with a reduction in suicidal ideation. 3 other studies showing the efficacy of MST over ECT, where in one of the studies in about 20 patients with major depression, all patients received 12 treatments and symptomatic improvement was comparable in both the groups. In one of the studies with MST and ECT in 37 patients with major depression who continued baseline pharmacotherapy, each group received about 12 treatments of the convulsive therapy and improvement was comparable between MST and ECT. Another trial also indicating MST and ECT in 20 patients with major depression receiving pharmacotherapy, they 8 to 12 treatments improved with, they are also very comparable. I mentioned the studies that have, the evidence that best supports the benefit of MST is a network meta-analysis of 130 randomized trials that studied the efficacy of non-invasive brain stimulation in about 6,700 patients. The likelihood of response was greater in MST than the sham stimulation. Okay. So another technique here is the focal electrically administered seizure therapy. This is also very similar to like ECT, but here the difference, the current is unidirectional. There is asymmetric electrode placement and one electrode being larger than the other. This is to induce a generalized seizure. Here also, the adverse cognitive effects are very less because only there's a target area, the prefrontal cortex, and the associated temporal areas are not targeted. The treatment course of fees involves, there's a series of seizures very similar to ECT, and it's done under general anesthesia and muscle relaxant. Here also, one study enrolled about 17 patients with major depression who discontinued pharmacotherapy and received a course of FEAST with a median of 10 sessions. Response was seen in about 8 patients, that is about a 47%. Another study with 20 patients with major depression, including 16 who discontinued therapy. Also, the response was seen in about 13 patients here, 65% of the patients. Coming down to RTMS, RTMS is another procedure that we are currently doing. A lot of patients are enrolling for RTMS because non-invasive and does not involve any anesthesia or so. So what we do here is applying magnetic fields, to produce electric currents through pulses in the cerebral cortex. What it does is it depolarizes the neurons in the focal area on the dorsolateral prefrontal cortex. Generally, it does not penetrate more than 5 centimeters in the brain, and it has a neuromodulatory effect by neuronal excitability, and has very, very good in having a neuroplastic effects. So this is the procedure. We have a figure of 8 coil that is placed over in depression, the dorsolateral prefrontal cortex, which induces electric current. So what it does is, it induces a local current in the cortex, which depolarizes the neurons by eliciting the action potential, and then release of local neurotransmitters. The serotonin production improves. So what happens there is the depolarization of the neurons occur in the dorsolateral prefrontal cortex and releases local neurotransmitters. It also causes depolarization of the pyramidal neurons in the dorsolateral prefrontal cortex, thus releasing neurotransmitters in the deeper parts of the brain as well. This activates the brain neurons and then acts on the limbic system and causes improvement in the target. The targeted mood circuit is the limbic system, thus causes improvement in the mood. So it stimulates the surface neurons, which in turn stimulates the neighboring neurons, which then targets the nucleus accumbens and the limbic system. Now, why I'm depicting this is, as we continue to stimulate repeatedly, the neuroplasticity comes into the picture. So the recovery that occurs is sustained because of neuroplasticity, because there are new networks that keep developing parallel to the actual network which was deactivated. So this helps with neuroplasticity. So this is the machine that we use there, a figure of 8 coil that is placed. So this is the point of stimulation. The coil is placed. Initially we see the motor threshold, that is the intensity that is required to penetrate the skull and target the brain center, and then we apply it in the dorsolateral prefrontal cortex. So the basics are, we can use high frequency or low frequency. That was the conventional RTMS forms. The newer forms, we see the theta burst techniques and quadrupulse stimulation techniques. Among the theta burst, we see intermittent, continuous and intermediate forms. Generally, it is done around 3 to 5 times a week. Some of the newer protocols say doing it twice a day can be more beneficial, and the conventional target areas being dorsolateral prefrontal cortex and sometimes temporoparietal cortex as well. So what are the indications? In depression, most importantly, unipolar and bipolar depression, peripartum depression, post-stroke depression, post-traumatic brain injury depression, and depression associated with Parkinson's disease. Anxiety disorders, like generalized anxiety disorder, OCD spectrum issues. I've seen very good response in OCD where the response to medications have been very minimal. Post-traumatic stress disorders, suicidality, impulsivity, and borderline personality issues. So what are the contraindications? Wherever there are ferromagnetic implanted devices in the brain or head or neck regions, then it is contraindicated. Like in deep brain stimulation, there are subcutaneous leads that are there. So, if you are doing, the procedure should be about 10 centimeters away from the position. Any other metallic devices like chips, pumps, pacemakers, cochlear implants, dental implants, permanent piercings, tattoos, etc., it is contraindicated. The target location, how do you calculate the target location? Generally, the normal is a 5 centimeter system, or the 1020 EEG system is used. In some of the cases, we may have to use neuroimaging MRI, SPECT or positron immersion technique, and to localize the area. some of the TMS machines these days, they come with inbuilt neuro navigation systems, but they're very, very costly to acquire. So at the moment, we are trying to acquire these systems. So the safety, in terms of safety, one of the well-known is very, very safe. You know, in the first 2 or 3 sessions, we check for any seizures. If there's no seizures, the probability becomes 0. And then the most common side effect that we see is headache. And in pregnancy, RTMS is also a very minimal risk to the mother and the child. So RTMS has a higher chance of success rate when we diagnose and administer in the first year of onset in patients less than 65 years of age. And in cases where there is a resistance to other forms of treatment is very limited. The other beneficial facts of RTMS being twice a day rather than once a day. And meta-analysis also shows significant antidepressant effect with high frequency RTMS than the low frequency RTMS. And one recent meta-analysis showed that increasing number of sessions and the total number of pulses per session associated with an increased antidepressant effect of high frequency RTMS. Generally, we prefer high frequency RTMS over low frequency RTMS. So one center with 170 depressed patients showed low frequency RTMS of the right dorsolateral prefrontal cortex was effective as venlafaxine administration. Venlafaxine belongs to the SNRI group of antidepressants. And another study showed that 32 patients showed high frequency RTMS of the left dorsolateral prefrontal cortex was effective add-on treatment in patients with treatment-resistant depression. Okay. Some other evidence showing that RTMS, the efficacy of RTMS. I generally apply high-frequency RTMS or the left dorsal prefrontal cortex for all the anxiety spectrum, and they have been really, really efficacious, basically in about 60 to 70% of the patients. Let me just get through this. So RTMS was approved for major unipolar depression and OCD. In 2014, the International Federation of Clinical Neurophysiology gave guidelines for therapeutic use of RTMS. The most recent approval for RTMS came by US FDA approval for OCD came in around August 2018. So this is the protocol for unipolar depression. High frequency RTMS at the left DLPFC. Low frequency RTMS is also known to be effective in the right dorsolateral prefrontal cortex. Bilateral RTMS, intermittent TBS over the left dorsolateral prefrontal cortex. Bilateral TBS, deep TMS, priming RTMS. Bipolar depression also is known to be effective, but here we have to be careful for a switch. Sometimes there could be a switch from a depression to a mania, so we have to monitor. And in treatment-resistant depression, also high-frequency RTMS in the left DLPFC is very, very useful. The protocol involves each session is about 37.5 minutes and about 5 sessions a week for about 4 to 6 weeks, and it's tapered over 3 weeks. And the magnetic field is generally 120% of the motor threshold that we acquire. The practice guidelines say in case of RTMS, it says that if the first line of treatment, which is a single trial of antidepressant fails, we can straight away go on to RTMS, which can show a very, very good response. So the other technique that is currently in use is the TDCS. It's in an investigational stage, but I've seen developing new protocols right now that can be very, very useful. It uses 2 scalp electrodes with low amplitude direct current over the cortical regions. Either cortical annular stimulation can be used. The target of stimulation typically is the left dorsolateral prefrontal cortex, and the series of treatments generally administered over consecutively for weeks together, and it can be very beneficial when done alongside with psychotherapy. In a meta-analysis, trials suggest that TDCS can be beneficial for acute treatment of unipolar depression. Another meta-analysis of patients, with 6 trials compared with TDCS and sham stimulation showed that in 289 patients with major depression who received about 5 to 15 sessions, response occurred in about more patients who received active treatment than the sham treatment. in a meta-analysis with 12 trials compared with TDCS, sham TDCS patients with depressive symptoms, the likelihood of response was 3 times more greater with active TDS. And TDCS may be efficacious for post-stroke depression as well. So the mechanism action generally involves neuronal firing. There's cortical excitatory stimulation. The tone, cortical excitatory tone improves. And the cathedral stimulation generally is associated with the decrease in spontaneous cell firing, and annular stimulation, which increases the spontaneous firing. TDCS is thought to exert in antidepressant effects via functional changes in the neural networks. So, is it time? Yeah. I'll just get through some of the other techniques. Other techniques that still is in investigational stage is the transcranial low voltage pulsed electromagnetic field stimulation. Here, oscillating currents are applied in order to get a better response. This works by angiogenesis and intracellular signaling. It also improves the cortical excitability. Trigeminal nerve stimulation can also be used. This is, we apply through an external pulse generator. We use cutaneous leads over the supraorbital and the supratrochlear nerves. Low field magnetic techniques also used. Generally, the head is inserted into a cylindrical magnetic structure. This also is targeting the dorsolateral prefrontal cortex. And, we get, cortical, it causes activity of the cortical neurons, which project onto the subcortical regions that involve with mood regulation by the limbic system pathway. Transcutaneous vagus nerve stimulation also can be used, where the electrodes are generally, included into the ear, basically, to trigger the afferent vagus nerve fibers. Cranial electrical nerve stimulation is another method where the electrodes are either used on the scalp or on the ear lobes. This is FDA approved for depression. Just 2 minutes about invasive techniques, where generally we liaise with the surgeons. Invasive techniques like vagus nerve stimulation, deep brain stimulation, direct cortical stimulation, and ablative neurosurgery can also be used. Okay, they are very reversible, revisable, and adjustable. Vagus nerve stimulation also can be used, where there's a pulse generator that is implanted into the chest wall, and then leads are wrapped around the left vagus nerve. This leads it causes stimulation of the vagus nerve, which in turn improves the mood through the limbic system. Deep brain stimulation also very much. Electrodes are placed in the cortical regions of the brain in order to ensure that the response, we see a good response. For depression, we target the nucleus accumbens. Okay. So recovery in terms of duration, in terms of deep brain stimulation, we see depression, the improvement, we see improvement in terms of anxiety and moods that occurs immediately within a day itself, but the moods and the energy and the interest, that takes some days to weeks to improve. Okay. The direct cortical stimulation also, that is one of the ablative neurosurgery techniques, of course, very minimally used because of the probable risks that are involved. Some of the techniques here are anterior capsulotomy, anterior cingulotomy, the subcaudate tractotomy, and limbic leucotomy. Okay. Okay. Thank you.
Do you have any questions? Can untreated depression or partially treated depression lead on to schizophrenia?
No, sir. No, generally, schizophrenia, the onset of illness is generally seen around 25 to 30 years of age. That is in case of depression, what happens is the schizophrenia in the early onset is misdiagnosed as depression because of the early onset of negative symptoms. The first thing that we see is depressive cognitions. So it is treated as depression earlier, but the positive symptoms, which are in terms of hallucinations and delusions and all these things, develop later part of life. So it is not that depression develops into schizophrenia. It is basically the schizophrenia that is misdiagnosed as depression in the initial phase. It's called as a prodromal phase of psychosis, basically. Prodromal phase of schizophrenia. No. The prodromal phase of schizophrenia mimics the depressive phase.
And the ECG completed patient, during some course of time in his life, can he develop natural seizures?
natural seizures, not definitely not. So what we have seen, sir, is in a couple of cases, what we have seen is in a person who is prone to have seizures, with childhood seizures, it has triggered off a seizure, episode. It has, but that is why, yes. One, if at all he had a probability of a seizure, sir, like I said, most of them who have, we have gone ahead with ECTs, they never developed, seizure episodes. But when we have seen there has been a childhood history of seizures, it can trigger of a seizure, onset of independent seizures. It can trigger, but most of the cases we take a good history, we ensure that there's. But sometimes, in the seizures that are, ECT is also on a treatment for treatment-resistant seizures. So.
Thank you, Dr. Arun Kumar sir, for your wonderful presentation and newer approach in neuromodulation and novel treatment regarding depression. Thank you, sir.
So, thank you, Dr. Anil. Now, we have the request Dr. Harish to honor Dr. Shivanna and Dr. Prabhakar, chairperson and co-chairperson. Prabhakar. Thank you, Anil. 30 minutes. Already very late today. Okay, now we come to the conclusion of today's CME, and we have to thank all our sponsors and other people. Can I have the list, or you're coming here? Your list. I think Harish, you can go take over. You can announce the. So,
thank the
yeah.
chief guest of honor. Yeah, the vote of thanks. It's my privilege to propose the vote of thanks. I would like to thank today's chief guest, Dr. Sharan Shivraj Patil, guest of honors, Dr. B.C. Rao, and Dr. Ravindranath Methi, and Dr. S.K. Srinivasan was kind enough to, have his presentation over here. And the other sponsors, we have the Manipal Hospital, Airport Road, Manipal Hospital, Millers Road. Anybody?
Manipal Hospital.
Manipal, from Manipal Hospital. Nobody. Okay. Sparsh Hospital, Infantry Road.
You can please come forward on the desk.
I think all representatives of the hospital, please come. Vaidehi Super Specialty Hospital, Chirag Hospital, AstraZeneca Pharma India, Kadambams, next we call upon our Vaidehi, anybody is there? Neura.
So,
Neura has given complimentary coupons, you can all use it.
Okay. We are very grateful to our chief sponsors, Microlabs, who have been conducting our annual conference for the past 33 years, and they are continuing. We are very much grateful to late G.C. Surana. On behalf of Family Physician Association, we thank their rich legacy and which they have been continuing to do so for the past couple of years, which has been followed by their sons Dilip Surana and Anand Surana. So we call upon Micro Labs representatives, Manjesh BM, GTF 1, Trimurti N, GTF 2, and BP Shashikant Pai. Next, Trimurti and
help her out.
Shashikant Pai.
I think we like to honor our organizing secretary and president. Vanni, Prabhakar, yeah, Harish, all EC members come on the dais. We can take a group photograph and then disperse, go home and sleep. Come Preeti, come Preeti. Card, shawl, ella hakirappa. शाल इल्ला दो शाल लेके आ.
Thank you all. I thank the audiovisuals and of course the hotel management